Crescendo 2023, organized on behalf of the Endocrine Society of Bengal. It is my pleasure to welcome all of you. We will shortly begin, and I request all delegates to please be seated for our first presentation, which will begin shortly. Thank you. Hall B for Crescendo 2023, which is the flagship conference of Endocrine Society of Bengal. I would request everyone to please be seated, and if there are any delegates or guests in the corridor, they could please come inside the hall. And for the first presentation this morning, I'd like to request on stage Professor Shotinath Mukhopadhyay sir. Shotinath sir is Professor, Department of Endocrinology, SSKM and IPGMAR Hospital, Kolkata. And his CV is on there for everyone to see. And sir will be talking about approaching recurrent fracture in children. Shotinath sir, please.
Good morning, everyone. At the outset, I thank Dr. Rana Bhattacharya for allowing me to speak first, because I need to rush for another meeting.
Could we have sir's presentation, please?
But then how do I work the pointer? I need to go to the presentation mode. It's not working. Pankaj, I need to go to the presentation mode, but this cursor is not working. And the slides are also not moving. Okay, good. No, it's not here. Okay. Good. So, fracture in children, the first thing we need to realize is that most fractures in children are actually normal. And this is due to the peculiar geometry of the growing bone and the high levels of physical activity that most children have. So the challenge is to distinguish between fractures that are normal, age-appropriate fractures related to bone geometry and high levels of physical activity, from fractures that are pathological in nature. And then if you go on to the list of causes of fractures due to pathological fractures, then you have primarily three broad categories: fractures that happen due to nutritional deficiencies, then primary bone disorders, and endocrine disorders. This being a short presentation, I will focus only on primary bone disorders that present as pathological fractures in children. So here is a long list in front of you. The first three causes are highlighted because I am going to walk you through some data that we have been able to generate over the years concerning the first three conditions. OIU is a common heritable connective tissue disorder. When we were students, we used to see only a few cases in a year or so, but then when we started looking for them, you will see the large number of cases that just move around in the hospital from clinic to clinic, just waiting for you to pick them up. So OI happens due to quantitative and qualitative defects in type 1 collagen, and most children are disabled by multiple fractures and deformities. So multiple fractures lead to short stature because those fractures invariably involve the long bones of the limbs. Then they can have skull base deformities including basal invagination. Hearing loss has been reported, but in our series, as you will see in a minute from now, we did not encounter in a series of 18 cases which we saw over a period of 1 year any sensorineural or conductive hearing loss. Dental abnormalities are common. Blue sclera is common, but not that specific for osteogenesis imperfecta. Multiple conditions in children can give rise to blue sclera, growth hormone deficiency being one of them. And then they can have hyperextensible joint. Hypercalciuria again has been reported in OI across the board without regards to the type of OI that the patient may be having. Hypercalciuria can happen and can lead to renal calculi. The cause of hypercalciuria in OI is not known. So this collage actually is a snapshot of, can I use a pointer? This one? Okay. So cursor, if it is coming here, no. Anyway, so a snapshot of some of the patients that we saw over the year. Thanks to Pankaj for putting them up in one slide. What I'd like you to focus on is that children, when they present with fractures, you can see the sad faces they present with. In the bottom panel, the third child, you can see how sad he looks. Now you go to the top panel, the last three pictures, the fourth picture actually is the child presenting with a fracture. Then after 1 year of bisphosphonate, this one. Koi dekho baba. Okay, so and after 1 year of his bisphosphonate, the same child looks so happy. So picture 5 and 6. So this is, I mean, quite revealing that how your treatment influences their mood. Some more pictures of OI, so blue sclera and overcrowding of teeth and dental abnormalities you can see, and on the right panel you can see how severely the bones get deformed, they look twisted, and that lead to severe short stature. One more picture, you can see the leg bones, how bent they are, how twisted, and again invariably cause a short stature. Here, no, this X-ray is interesting. On the right top panel you can see hypertrophic callus, which is characteristically seen in type 6 OI. No matter what type of OI the patient suffers from, they invariably have severely low or compromised bone mass. And in children, it's conventional to do a total body DEXA less head. So this is the TBLH picture. And if you look at the Z-score and the BMD, you can see how severely they are compromised. This happens without regards to the type of OI that the patient is suffering from. This is how the mutations are captured in OI. So just to walk you through one such panel where they give you the gene mutation to start with. So in this particular patient, you have a COL1A1 gene mutation, then they give you the variant, the location of the exon where the mutation happens, and finally they tell you the mode of inheritance and the classification, whether it's pathogenic or of doubtful pathogenic significance. There are no definite biochemical tests or clinical tests by which you make a diagnosis of OI. So this is a typical clinical history, and followed by the mutational studies that help in clinching the diagnosis. There are multiple differential diagnoses, one of them being pseudogliomas syndrome, where you have an LRP5 mutation. Then you have the PLOT2 mutation presenting as Bruch syndrome. And then there are others. Finally, a large group is there where you don't find any discernible or detectable mutation, idiopathic juvenile osteoporosis. The treatment goals are threefold: prevent deformity, improve daily activity, and reduce fracture rates. So how can you do that? Bisphosphonates remain the standard of care, and if you go by the recent data, intravenous zoledronate is the agent of choice nowadays in centers across the world. This slide captures our data, our center's experience in children with OI, impact of bisphosphonate. So you can see the mean age, so very young patients, they fracture, the height centile is less than third, like I said before, severe short stature, and you can see the number of upper limb and lower limb fractures, they're kind of matched. And earlier you start zoledronate, the better. Here in this study, the mean age was 3.5. Male and female are almost equally matched. Family history is uncommon, most mutations being sporadic in nature, no matter whether they have consanguinity or not. You tend to see sporadic cases more frequently than heritable cases. Blue sclera we have discussed. Then exuberant callus, we had only one patient. And finally, hearing and echocardiographic abnormalities were not seen in this small series. Some abnormalities that are described mostly involve the aortic valve, aortic regurgitation, and sometimes mitral valve prolapse. Busy slide. So the type of mutations captured here, and the variants and the exons also shown. I will summarize this for you. So the COL1A1 mutation, which is the presenting feature in Y type 1 and type 3. So they are seen in the majority of cases, 8 out of 14. Then we have had 4 cases of type 4 OI, where you can get a combination of COL1A1 and COL1A2 mutation. And we could see only one patient with IFIT M5 mutation, which is type 5. So this is the zoledronic acid infusion protocol, which we adapted from the NHS Trust, and you can see the dose and the frequency of administration varies depending upon the age at which you initiate zoledronate treatment. So this shows the follow-up data in terms of the reduction in fracture rates per year, and you see how remarkable impact on the fracture rate reduction is seen with institution of zoledronate. So before zoledronate, fracture rate around 2 per year, and this comes down to less than 1 within a year or 2. So this is a remarkable impact of zoledronate on fracture rate reduction. Zoledronate is fairly well tolerated. In 6 out of 16 patients, only mild febrile reactions were reported. The 10 children did not have any side effects to describe by the parents. So to conclude this part of the presentation, so type 1 OI was the most common type in our cohort. Blue sclera was fairly common, but as I said before, it's kind of non-specific. No hearing abnormality was noted. COL1A1 mutation was more common than COL1A2. One patient with hypertrophic callus had IFIT-M5 mutation, which is consistent with type 6 OI. So fracture rates per year improved dramatically following zoledronic acid infusion. Zoledronate treatment was fairly well tolerated, and there was no adverse impact on the bone biochemical parameters following zoledronate infusion. Now to switch gear from here, this is a limitation of the study. Of course, the sample size was small, and when we presented the data, we did not have the BMD data with us. Now, fortunately, we have BMD data on most of the children. And apart from the fracture rate reduction, we did not really have much information on the quality of life of these children. And the follow-up was short. Now let me switch gear from here and take you through a series of cases of fragility fracture that presented to us with sclerotic bones. So here is a 17-year-old short boy, he's still a boy, not an adult, who gives a history of multiple low trauma fractures over the last 5 years. So the problem started at the age of 12. At the bottom panel, you can see how sclerotic the bones are, dense bones. And on the top right panel, if you look carefully, you can see acroosteolysis, which is considered one of the defining features of a syndrome that I will quickly take you through. So acroosteolysis, sometimes you can see the distal phalanges of 4th and 5th fingers missing also. So overcrowded teeth. On the top left, you can see obtuse angle of the jaw, which is due to mandibular hypoplasia, which is considered one of the characteristic features. Then on the top right, you can see again acroosteolysis. Then the bottom second panel, you see the notched vertebrae and the dense bones everywhere. So more dense bones for you here. Again, overcrowded teeth you can see, and acroosteolysis involved in the feet also. So here is a series of 5 children picked up from 4 corners of the country, which we published in Clinical Dysmorphology. And if you look at their facial features, you see they're unrelated to each other, but how familiar they look, because the dysmorphism actually is so similar, and it gives you the diagnosis. On the top right, you see the prominent frontal bossing. Then you have the depressed nasal bridge and the other features there. And if you look at I am not sure if you can see there, again, they are invariably short due to multiple fracture. And if you follow the growth trajectory, it's below and parallel to the 3rd percentile. So this is the paper. So we reported data on 5 children. Busy slide, you can't see it from there, but then only thing it tells you is that the 5 patients are from different parts of the country: east, central, south, and northern India. Here's the Sanger sequence for you, which picks up the cathepsin K gene mutation, which is pathogenic in nature. You may be interested to know that cathepsin K inhibitors were explored as a potential treatment for osteoporosis with a use of a drug called Odana-Catib, which is supposed to be marketed by Merck. The study endpoints were reached, but then the drug did not hit the market because the patients had excess cardiovascular mortality. So if you inhibit cathepsin K, you have bone accrual, And here is a loss of function mutation of cathepsin K gene giving rise to dense bones, but those bones are brittle. They just break like a piece of chalk. If you go back to your school days physics, you would know that chalk is harder than bone. If you measure its hardness, the Young's modulus, you will see that it is harder than bone. But chalk is many times more brittle than bone. Something similar happens in this condition known as pycnodysostoses, which actually means dense bones. Here is another patient which came to us for follow-up after publication of the data. This is the latest patient with us. I have some 4 or 5 minutes now, and I will just share our data with 2 more cases. This is a 10-year-old boy who presented with a fracture, supracondylar fracture, and then we went on to investigate the boy and found out that he was suffering from primary hyperparathyroidism with a due to a parathyroid carcinoma. So what is of interest here is a histology slide at the bottom right corner, where you can see the arrow pointing towards vascular invasion, and on the top left of the same photograph you can also see tumor cells breaking the capsule, so you have evidence of capsule invasion. So capsule invasion and vascular invasion, two histopathologic hallmarks of endocrine malignancies, are present in this child. So parathyroid carcinoma presenting with fragility fracture, multiple fragility fracture in this child. And finally, we came across this patient long time back, so who presented with large skull, multiple pathological fractures. There was on X-ray, you can see loss of corticomedullary differentiation in the skull, which is on the left panel, and then you can see the inappropriate sutural closure, and on the right the characteristic X-ray appearance of bone within the bone. I think my time is up. I'll stop here and would love to have questions. Thank you. Thank you for listening.
The talk is open for questions and discussions, if any. Any of the delegates, residents, if you would like to ask any question to sir regarding fractures in children.
Sir, how common is spine involvement in osteogenesis imperfecta, and can it be a clue to differentiate juvenile idiopathic osteoporosis from osteogenesis imperfecta?
Actually, spine involvement is rather uncommon in OI, and it's more commonly seen in idiopathic juvenile osteoporosis.
Thank you, sir, for that lovely talk. And are there any types of OI which don't respond well to bisphosphonates? And if yes, so then how do we optimize management in that setting?
I wouldn't say they don't respond, but type 6Y is associated with elevated alk-phos levels, and bisphosphonates have not been found to be useful, and they are rather considered contraindicated in type 6Y.
Right.
All otherwise, they usually respond.
Right. Yeah. Thank you, sir.
Thank you.
What's your take on using denosumab and bisphosphonate non-responsive OI cases in children?
Yes, so cases unresponsive to bisphosphonates have been treated with denosumab, but at this point of time the therapy remains experimental in nature. It's not approved, off-label. Thank you.
Thank you, sir.
Thank you, sir. Sir, I have an in-house question from our department itself. So when I was talking about OI at the ISBMR conference last year, head of the department over there, Bhadada sir, he particularly talked to me regarding the long-term safety of bisphosphonates in OI treatment, that we should be careful because we are giving them zoledronic acid infusions, about the quality of bone that might happen, about the other adverse effects. So do we keep going about giving this infusion year after year to these children, and is there an end to it, or I don't know?
Absolutely. At this point of time, we cannot say when we should stop. They are all growing and they are prone to fracture. So the key is to keep them under regular follow-up and evaluate before each dose of zoledronate regarding their bone quality and quantity. Now you have the TBS also, so you can look at the matrix also. Thank you.
Thank you, sir. Thank you, sir. If there are no further questions, we would like to conclude this talk and thank Professor Shotinath sir for his wonderful talk regarding recurrent fractures in children, focusing on these topics. Thank you, sir. Thank you so much.
Thank you.
For the next talk in this bone clinic, we have none other than Dr. Rana Bhattacharya, rickets, and the approach for the same. Thank you.
Thank you, Pankaj. A very good morning to all of you. So I was asked to speak in place of Professor Thomas Paul, who unfortunately couldn't attend due to some family-related emergencies. As you know, it's to fill in his shoes is not only difficult, it's impossible. But however, you have to bear with me for the next 20 minutes or so while I discuss an approach to refractory rickets. Now, this is one of the condition that is not very well defined, let's admit. The diagnostic criteria are many and all of those are arbitrary. So one of those we can use practically, that even after 3 to 6 weeks, after an empirical doses of vitamin D, which seem to be adequate, the cumulative dose is around 6 lakh IU, 1 or 2 doses, maybe oral, maybe IM. If there is non-appearance of healing line, we can call this ricket as refracted. However, there are many caveats. One of those is there are some refractory rickets which may partially respond to vitamin D. Just to give an example, rickets secondary to renal tubular acidosis, as there is a problem with vitamin D related mechanism in this rickets. If you give a high dose of vitamin D, there may be faint appearance of healing lines. That doesn't mean the defect is non-refractory. So actually what we need, whatever the definition may be, we need a long-term follow-up of this patient. After giving a dose of vitamin D, we can have a follow-up and see whether they are responding properly or not to label them as refractory. Broadly speaking, refractory rickets can be classified as calcipenic, which is mainly due to disorders of vitamin D metabolism. It can be phosphopenic, which can be FGF23 dependent or non-dependent, and other causes which have some difference from the typical features of ricket. Those can include renal tubular acidosis, chronic kidney disease, and a rare condition, that is hypophosphatasia. Among all these conditions, what we found in our institutions, the commonest cause of refractory ricket is renal tubular acidosis, followed by FGF23 mediated phosphopenic rickets. Now, if we talk about the vitamin D related rickets, which are not due to deficiency, the causes are many. This is the pathway of vitamin D metabolism. Well, the cursor is not appearing there. Oh, okay, you use this. Okay. Anyway, if you can see in the middle panel, there is CYP27B1, that is 1-alpha hydroxylase. If it is deficient, we can call it VDDR type 1A. If there is a defect or mutation in the hepatic 25 hydroxylase, we call it VDDR or vitamin D dependent ricket type 1B. If there is a problem in action of 125 dihydroxyvitamin D, we call them VDDR2. That can be further subdivided into 2A, where there is the defect is there in the receptor itself, and 2B where the defect is in the post-receptor area. And a recently described condition known as type 3B, it is due to the gain of function mutation of CYP3A4, which is a hepatic enzyme which actually accelerates the degradation of both 25 hydroxyvitamin D and 125 hydroxyvitamin D. So this in nutshell covers all the congenital conditions which leads to abnormality of vitamin-related metabolism and subsequently rickets. If we move to phosphopenic rickets, it can be due to impaired intestinal absorption or low phosphate intake, both of which are extremely rare. But sometimes with the use of long-standing aluminum containing antacids or phosphate binders, or if there is malabsorption leading to chronic diarrhea and steatorrhea, very rarely we can get phosphopenic ricket which is due to GI cause. But more commonly, we find the causes related to impaired renal absorption, and as I've already said, in our experience, excess FGF23 mediated rickets are most common, and there are lots of those. Due to short of time, I won't discuss all these things. Beyond FGF23, there is a very common phosphaturic agent, that is PTH. So primary hyperparathyroidism, it is occurs in children. It can also lead to rickets. And proximal tubular dysfunction, be it generalized in the forms of Fanconi syndrome and its variant, or isolated phosphate reabsorption defect where only phosphate reabsorption is hampered, like classic HHRH, that is hereditary hyperphosphatic ricket with hypercalciuria, which is due to biallelic mutation of NAPI2C, the transporter, phosphate transporter in the proximal tubule of kidneys, or monoallelic mutation of NAPI2A also leads to phosphaturic ricket with hypercalciuria. Whereas the homozygous mutation of this NAPI2A leads to Fanconi rather than isolated phosphate loss. Now, when a patient comes to us, there are many clinical pointers by which we can pinpoint or we can at least suspect the etiology of ricket. It's too exhaustive, but I will just tell you a few of the salient points by which you can identify or you can suspect a particular type of rickets in a given individual. As for example, if there is a history of tetany on convulsion, you can think about VDDR group of ricket as a cause of refractory ricket. If there is fibrous dysplasia, you think about MAS, which causes phosphaturia. There are rare variants of ricket like autosomal recessive hypophosphemic ricket. There can be osteosclerosis in the long bones. There can be periosteal bone formation. There can be excess calvarial bone formation and excess bone formation at the base of the skull in ARHR. There can be midfacial hypoplasia, which is typical of autosomal recessive hypophosphemic ricket type 3. I will show you some of a picture of our patients later on. Craniofacial abnormalities can also point towards certain forms of rickets like X-linked hypophosphemic ricket or osteoglophonic dysplasia. Arnold-Chiari malformation and craniofacial bone dysplasia can also be present rarely in these conditions. Skin changes are very important. Once you get a patient with ricket, even without bone deformity, please look carefully for a cafe au lait spot, because the cafe au lait spot with irregular margin should raise a suspicion of underlying McCune-Albright syndrome and the rickets related to this. Linear nevus sebaceous syndrome is extremely rare forms of nevus which can secrete phosphatonins and leading to rickets. And other skin changes like alopecia, as we all know, that VDDR type 2A, I will show you a picture again, that can point towards this condition. enthesopathy, indicates towards X-linked hypophosphatemia ricket. This enthesopathy can become disabling in a person who is kind of in late adolescence or in adult periods. They are usually manifested early in the X-rays, but the symptoms appear later on. Hearing loss can indicate sensorineural hearing defect related to distal renal tubular acidosis due to proton pump mutations, or it can be present in other forms of phosphaturic rickets as well. Tooth abnormalities are very, very important. Please look at the tooth of a patient with rickets. It can give you multiple clues like caries, enamel hyperplasia, which can be associated with various forms of calcipenic rickets, dental abscesses classical of phosphopenic rickets. Premature tooth loss can occur in many conditions, including some forms of hypophosphatasia. Amelogenesis imperfecta can occur with distal renal tubular acidosis related phosphate associated with WDR17 mutation. So please look at the teeth, they can give you multiple clues. Iron deficiency can exacerbate the rachitic features in a patient with autosomal dominant hypophosphatemia ricket. Polyuria can indicate underlying tubulopathy. It may be distal tubular acidosis, or even other forms of tubulopathy can also lead to polyuria. And renal stones are classically associated with distal renal tubular acidosis, as you all know, but some rare cases of proximal renal tubular acidosis like dents, Fanconi-Bickel, and cystinosis, you can get renal stones. So presence of renal stone doesn't automatically mean the patient is having distal renal tubular acidosis. Some hypophosphatemia rickets that I have already said, that is HHRH, and the autosomal dominant hypophosphatemia ricket with nephrolithiasis, that is monoallelic mutation of NAPI2A, can also give rise to nephrocalcinosis. Now, regarding the special investigations, I won't go into all of this. I will just highlight some important points regarding some investigations which you need to do in a patient with rickets. Let's start with serum calcium. It's a very commonly performed test, should be done in all cases of rickets, but please remember the recent data says that the preferable type of calcium that you should measure is the ionized calcium. And how to send the blood for it? You draw blood in a syringe and keep the needle in situ. You just twist the needle in the middle so that no air entry will be there. So it's there in the anaerobic condition. You should transport it and measure it as soon as possible. We commonly used to use a Payne's formula, that is albumin corrected calcium, but recently multiple studies in hospitalized patient, in ICU, in hemodialysis states, and in OPD basis, it has been shown that the formula that we use, that is multiplying 0.8 into albumin plus the difference plus the total serum calcium is actually a reflector of actual calcium. This is not helpful at all. This correlates poorly with ionized calcium. So we should always use unadjusted calcium value as is there in the report. No need to correct with albumin. And if you have suspicion, do ionized calcium from a good lab. There is no use of albumin correction. And this is just, it's all of you know, although the name says it's a calcipenic rickets, the serum calcium level is often normal in all the calcipenic rickets. In some, where it's very severe, and many of the resistant rickets like Viridier, type 1 and type 2 can have hypocalcemia definitely, but hypocalcemia is not a must in a calcipenic rickets. Now regarding phosphorus, again it is very important to draw it in the empty stomach, because if you send it after a meal, it can be falsely high if patient gives blood after a phosphate-rich diet, or it can be falsely low if patient takes a carbohydrate-rich diet which helps secreting insulin, which drives phosphate intracellularly. So ask the patient to give blood in the empty stomach in the morning hours because of his diurnal variation. And proper transport, you need to separate the blood as soon as it gets clotted. Otherwise, more the time the RBC is there in the sample, it will get lysed and phosphate may be falsely high. And in rickets, you should use a pediatric reference range. Is very important because as the child grows older, the normal phosphate level comes down. So you need to use this reference data. Alkaline phosphatase, again a very important test we need to do often. It is raised in most of the most of the types of rickets, except few of those like hypophosphatasia. Here also it has tetraphasic kind of graph. That is, in the neonate it's high, it comes down in the childhood, then it again goes up during puberty, then again the values are lower in the adulthood. So you need to remember this, or rather you should have this data with you when you interpret a particular patient's data. Regarding 25-hydroxyvitamin D, again must be sent in all patients with rickets. Please look at the assay that we are using. The values with LCM, SMS and chemiluminescence is a bit different. What we commonly use the chemiluminescence assay. Second point is that please look at the units, whether it's in millimole or nanogram per ml, because the values differ by 2.5 magnitude. In a partially treated ricket or patients with dietary calcium deficiency, there the vitamin D values less than 20 may rarely suggest calcipenic rickets. But please remember, unless vitamin D level is less than 10 or 20 nanogram per ml, please do not think the ricket is due to vitamin D deficiency, because vitamin deficiency is a very commonly prevalent condition in our population. So a lower vitamin D does not automatically mean that the ricket is due to vitamin D deficiency. But however, we tend to replace the vitamin D and then we see the response. If there is no response, then we should promptly shift towards the evaluation of the refractory rickets. PTH is a very important test to differentiate between calcipenic and phosphopenic ricket. It's usually markedly high in calcipenic rickets. And again, proper sample handling is important. We can do a serum sample, and where after clotting we can send it promptly to a lab, or we can do a plasma sample which should be drawn in a cold chain method. That is, the syringe should be cool, the vial should be pre-chilled, and we should send there preferably with a cold centrifuge lab should do it. So it's very important to have a proper sample handling. A very important aspect when you get a phosphopenic ricket, to demonstrate phosphaturia. Now what we do usually is replace phosphate first for 4 to 6 weeks before doing evaluation for phosphaturia ricket, because irrespective of cause of hypophosphatemia, even if it is due to some GI abnormality, if phosphate level is low for a prolonged period of time, you know phosphate is a very important molecule for intracellular energy production. So prolonged hypophosphatemia leads to the tubular dysfunction which can induce phosphaturia. So whatever cause of this hypophosphatemia may be. So ideally we should replace phosphate first, followed by evaluation. We can evaluate with urinary phosphate creatinine ratio, fractional excretion of phosphate, or TMP-GFR. Each has its advantages and disadvantages. TMP-GFR is the most commonly performed test. We preferably do a second morning spot sample. Please do not use the nomogram that is given in your textbook. This is not valid in children, okay? This is for adults. So another formula when the TRP is more than 0.85, again there also the formula that is called Kenny and Glenn's formula, which we commonly use, that should also not be used, because this formula is actually derived by fitting a hyperbola in the splash section of this bivoid nomogram. And this particular splay, that is when TRP is high, the linear relationship between plasma phosphate and urine phosphate, which is there, which is lost, this loss is not there in children. So in children, we should always use the standard formula called Brodel formula, which should be used irrespective of serum phosphate level. And who are lazy like me, I have already given a reference. This is a standard calculator, online calculator that is available, by which you can calculate TMP-GFR. It is particularly useful when serum phosphate is low, because when the serum phosphate is low, the fractional excretion of phosphate actually can be falsely normal. That is, it can be less than 20%, which may not suggest renal loss. So here comes the importance of TMP-GFR. This is the particular condition where we should use TMP-GFR instead of fractional excretion of phosphate. However, if serum phosphate is extremely low, then another problem arises. Whatever test you do, like TMP-GFR, whatever calculation you use, all may show a lower value. That's why in the beginning I said, for number one reason, due to the altered tubular function, you should replace phosphate. And secondly, if the calcium load is, if the phosphate load is extremely low, there the TMP-GFR calculation doesn't help. So it's always better to replace phosphate first. But even if still you want to do it, do phosphate creatinine ratio in the urine, and there is a normative data, although it's quite old, but there is a data which you can follow to guide you. And there is a TMP-GFR, again, it's also age related. With age, it comes down, just like urinary excretion of phosphate. So I think it's one of the way that you can do it practically. You first calculate TRP. If TRP is less than 0.8, that is fractional excretion phosphate is more than 20%, the renal loss is there for all practical purpose. But if TRP is more than 8, it can be falsely, as I've said, it can be falsely high, so use TMP-GFR. And when you suspect GI cause, you should do a phosphate creatinine ratio. So this is a practical way to assess for assessing phosphaturia. Urinary calcium creatinine also needs to be used in some of the cases, as I've said, to demonstrate hypercalciuria, but the cutoffs should be ideally based on locally available data. Unfortunately, we don't have one, so we can use a Canadian data or British data that are available now. FGF23, again a test which is very important in the case of phosphopenic rickets, but again sampling handling is very, very important, and cold chain should be maintained. So at the end of it, how should we approach a patient with phosphopenic ricket? Let us discuss some of the few of the very common approach that we can use. Initially, we can use calcium, phosphorus, ALP, creatinine, PTH, potassium, and of course X-ray. ABG, if preferable, if technical expertise is not available, you can use venous blood gas instead. If the ALP is normal and phosphorus is normal, first think about ricket mimics and then DRTA and hypophosphatasia. If there is high creatinine, of course, is due to azotemic rickets. How to exclude mimics? Look at the X-rays and clinical features carefully. Blount disease is a common condition which may come to us and referred to us as a ricket. Please look at the medial baking of the tibial epiphysis. So this is very characteristic, and the child is usually obese. There are various forms of metaphyseal chondrodysplasia. This one is called McCusick type, where it's also known as cartilage hair hypoplasia syndrome. You can see the typical hair here. There are various forms of metaphyseal dysplasia as well, the other forms like Smith type, Spar type, or anadysplasia. So there the features are like moth-eaten kind of appearance of metaphysis. There is a sclerotic margin along with some beaking. So these will give you the clinical clues. Progressive pseudorheumatoid dysplasia, not uncommonly referred to us for evaluation of ricket. Again, of course, it's a mimic. Now, if you get a low phosphate and if you get hypokalemia, then first you need to rule out RTA. And metabolic acidosis, again RTA. So hypokalemia and metabolic acidosis plus phosphaturia. And even without phosphaturia, if these features are there, think about RTA. So this is one of the RTA typical patient which presents with ricket. And we did a study in a patient with RTA, and 95% of the individual had rickets in childhood. It's so common. Not only distal, but proximal renal tubular acidosis can also lead to rickets, although rarely. This is our case series where, as you can see, multiple etiologies of proximal tubular dysfunction led to ricket. If there is hypercalcemia, always think of primary hyperparathyroidism associated with raised PTH. This is one of our patient where there is features of rickets. You can see the parathyroid adenoma there. If there is the calcitriol level is high, then of course the PTH, if it is elevated, initially we discussed, think about vitamin D related conditions, and if after replenishing of vitamin D, if calcitriol is high, think of viridia type 2, if it is low, think of viridia type 1. This is a typical picture of viridia type 2A, where you can see the alopecia along with the rachitic changes. And lastly, typically if the PTH is slightly low, slightly high or normal, think about FGF23 related disease, and if the hypercalciuria is not there, think about the other forms, whether if hypercalciuria is there, think about HHRH. This is one of our patient of X-linked hypophosphatemia rickets, which you all know that it's a X-linked dominant disorder, so it's in mother and her child. Calvarial thickening, which I said, is seen in autosomal recessive hypophosphatemia rickets, as you can see here, and rarely some patients may come to you with a bone scan. That it is not typically recommended in ricket, but that can give you a clue towards ricket. It's called a tie sign and rachitic rosary sign. If these features are present in a bone scan, always think of phosphatemic rickets, because due to bone pain, often they are advised by orthopedician or other specialties for this. So to summarize, the resistant ricket are the commonest group of rickets which are referred to as endocrinologists. RTA and hypophosphatemia rickets are commonest, as in our experience. Proper algorithm is needed to help uncovering the underlying etiology. Please remember the pitfalls of various tests that I have described, and be aware of various mimics which are there in rickets to help you to guide towards a proper diagnosis. So thank you all for your patient hearing.
It's always a pleasure to hear Rana sir talk about anything, particularly bone, and it was a wonderful overview of what we should be doing in a case of rickets, particularly refractory rickets. The session is now open for discussion. Vijay sir.
Thank you, Dr. Rana.
Thank you, yeah.
In fact, it's a very crystal clear talk.
Thank you.
But I had a concern regarding the definition of refractory rickets.
Yeah.
Typically in clinical practice, if we give 6 lakh units of vitamin D, we wait at least for 4 to 6 weeks to give the second shot.
Yes.
But the definition includes after 2 to 3 weeks.
Yes.
So is it practically?
Yeah, that's what I said. Actually, you know, I mean, whenever we search a literature, the definition of refractory rickets varies from one literature to another. So for all practical purpose, after giving vitamin D adequate doses, we should wait for a period and see both radiologically, biochemically as well as clinically, because these definitions, when it was developed, it was where mainly the STOS therapy was popular, and we used to assess by the X-ray mainly. But now we have come a long way, so that's what I said, that we should rely on our clinical judgment as well as biochemical and radiological parameters taken together to stamp a ricket as refractory.
Right. The second thing is the TMP upon GFR. So we discussed so much about TMP upon GFR. So have you seen any scenario where really it helped you to differentiate between a gastrointestinal cause to renal cause? Or because since we are probably doing unnecessarily for so many patients, can you help us to select the patients where probably TMP upon GFR is going to be really helpful?
Yes. So your question is, when you can avoid doing TMP-GFR, right? So yeah, unless the patient has an overt GI problem, or unless the patient have a history of chronic intake of this aluminum containing ancillary, which are very rare nowadays, for all practical purpose we should consider ricket as, hypophosphatemia ricket as phosphaturic. So we can do away with that, but again, at least doing a urinary phosphate creatinine ratio, which may be quite a simple test, can give you a clue. So in any way we do a calcium and all those tests to differentiate this, so along with that we send phosphate, that's it. But it's not really mandatory in most of our patients that we see in our clinical practice.
Yeah, thank you so much.
Thank you.
Any more questions for this topic on refractory rickets? If there's none, sir, I have a question.
Yes,
Sir, I need a little clarification on correcting phosphate before doing TMP-GFR
Yes.
in patients with very low phosphate.
Yes.
Sir, actually, we were told that not to do a TMP-GFR when the patient is on phosphate. And now you've said special conditions like it may affect the renal tubular function as well as very low phosphate may make the TMP-GFR very low. So the contradictory views could be
Right,
presented.
it apparently seems contradictory, but it is not, because I said you can't normalize the phosphate level with phosphate replacement, right? So what I said that you need to replace phosphate for 4 to 6 weeks, so that most of the time the phosphate level remains normal or high or whatever. We do not measure phosphate during follow-up, but at least we are giving adequate dose of phosphate so that the renal tubular dysfunction, whatever is there due to chronic phosphate deficiency, that gets better with time. And of course, on the day of test, we do not give phosphate replacement. That's not necessary, and that should not be given rather. But if we have a phosphate replacement period of at least 4 to 6 weeks before proceeding for calculating phosphaturia, that will give us a better impression, because you know the kind of hypophosphatemia due to any cause, even if there is a GI cause, it can show you a phosphaturia, because you know the conditions like phosphaturia and hypomagnesemia, these two are the conditions, you know, these two molecules are very important for intracellular energy. And tubules, renal tubules are a very kind of energy dependent cells. So other than brain cells, the renal tubules are possibly one of the most energy consuming cells. So if there is a deficiency of phosphate or magnesium, so there can be tubular dysfunction. So that's why it needs to
And
be
sir,
replaced.
so you
Yes, Partho.
Hypophosphatemia is another cause of form of acquired renal tubular acidosis. You may
Yes,
have
again,
both proximal RTA and
Yes.
distal RTA.
So again the tubular dysfunction.
Secondary to hypophosphatemia.
Absolutely.
So if you look at the algorithm, upstream there was, he tried to rule out DRT upstream. So the hypophosphatemia can give rise to acquired form of
Yes.
DRT.
So whenever you suspect, actually we had patients like this, hypophosphatemia leading to acquired DRTA. So we need to hypophosphatemia. So with presence of hypophosphatemia long-standing, a host of tubular dysfunction can appear. And give rise.
so we correct phosphate, so you recommend this?
Not correct, but you replace phosphate for a period of 4 to 6 weeks. It's not possible to correct the phosphate. If you measure fasting phosphorus even after years after adequate phosphate replacement, you still find it low.
Thank you, sir.
Thank you, Rananda. So it's a very good talk.
Thank you.
indeed.
Thank you.
So recently, it's a comment maybe. Recently we got a patient who presented with severe weakness, maybe quadriparesis, 6 years of age, and the ABG was little bit in the metabolic acidotic range. It is normal anion gap metabolic acidosis, but patient was so sick, the potassium level was less than 1.
Right.
And actually at that time there is a huge tenderness in all the muscles, and the CPK was above 20,000. But at that time, the CPK was not done initially. Initially, potassium was done, and because patient was so much sick, then we go for CPK. And the phosphate and calcium level at that time, the phosphate was around 6.2 or 6.3. So initially, we thought that we are dealing with some case, but initially we have to restore first, then we will differentiate.
Yes.
And after 2 to 3 days of treatment, the CPK level was going down and the potassium level was going up. And then when we go revisit the case, the phosphate level then again going to come down.
Yes. Because
So,
this is
this is the scenario. So
Yes.
and finally, possibly we are dealing with a case of prime proximal renal tubular acidosis. And so my take-home message from this case may be that the initial stage, sometimes a patient, if presented with severe hypokalemia which may be due to renal tubular acidosis, which could be due to proximal, but the phosphate level could be elevated.
I have a small point here.
Yeah.
Possibly rather than proximal, we should think more of a distal RTA here,
Yeah.
because hypokalemia is more common in distal RTA.
Yes.
And this is a typical
It is
case
quite
of...
it's actually a mixed type. You
Okay.
pointed it out,
Okay.
right? that usually it is probably distal with some component of proximal, but
Right.
with treatment we see the proximal, in this age the phosphate level is coming around 2.1 or 2.2. That means definitely it is low.
Right.
So, in these type of cases, sometimes we can spuriously phosphate level may be elevated due to some kind of rhabdomyolysis.
Yes, it's
So
suggestive of
this is also
it's suggestive of rhabdomyolysis due to hypokalemia itself.
Hypokalemia
Because
itself,
in
yes,
rhabdomyolysis per se the potassium and phosphate level
Phosphate
should
level-
go up.
yes,
But
exactly.
if phosphate is apparently pseudonormal and potassium is very low,
Exactly.
it suggests hypokalemia as a cause. And if we find a mixed type of RTA here,
yes.
I would suggest replace with alkali and phosphate for a given interval, for a prolonged period, say few weeks, then recheck. In all likelihood, the proximal dysfunction may also disappear, because as we have seen in many of our
Yes,
cases, that distal renal tubular acidosis leads to acquired form of
Acquired form of
proximal
proximal
renal tubular.
yes.
So in this case may solely be due to distal renal tubular acidosis with all other various manifestation which masquerades as different conditions. Thank you for sharing this case.
Sir,
I think that will be the last question.
Sir, one basic doubt.
Yes.
Why we are calculating TMB GFR for phosphate, while other ions like calcium we calculate calcium creatinine ratio also.
Right,
Only
right.
for phosphate we go with TMB GFR. Why
Right.
is that?
The problem lies because the exact cause is not known, but however it is seen, if the filtered load of phosphate becomes very low, there the fractional excretion of phosphate will not give you the actual picture. It will give you a kind of value which suggests non-renal cause, that is adequate renal reabsorption of phosphate. So there you need to correct it with the serum phosphate level, and that is we call TMP-GFR. Otherwise, it can be falsely normal. But say if the TRP value suggests renal loss, then possibly we are dealing with a renal loss, right? It's not, we may not do TMP-GFR there, but if it is normal, or if it is, say, the reabsorption is adequate, or if we think that renal function is adequate, then you should do TMP-GFR to correct it with serum phosphate. This is not true with calcium or other agents like sodium and others.
Thank you, sir. Another big round of applause for Dr. Rana Bhattacharya.
Thank you.
Thank you, sir. Thank you so much. We now quickly move from the bone to the adrenals, and to present the first talk, we have Dr. Belinda George, who is Associate Professor at St. John's National Academy of Health Sciences, Bangalore. And Madam will be talking about critical illness associated adrenocortical insufficiency. Thank you.
Good morning, everyone. At the outset, let me thank Team Crescendo for the invite, and it's my privilege and pleasure to be here. So today, the topic for discussion is critical care illness-associated adrenocortical insufficiency. So this is the broad outline of my talk. We will look at a few definitions. First, we will see how certain concepts have evolved over the last 2 decades. We will revisit the physiological changes that occur in the HPA axis during critical care, and I will explain a few probable scenarios of adrenal insufficiency that we should not miss. And lastly, we will look at the diagnostic and treatment dilemmas and consensus that we have today. So coming to the introduction, critical illness basically is any condition which is either evoked by a major surgery or a severe medical illness or even trauma. This will require a pharmacological or mechanical support of vital organ functions in order to ensure that patient will survive. So that is what we define critical illness as. So this is basically a condition of severe physical stress for the patient. And it is not just severe, it is also sustained over a period of time. So here, of course, there is a definite need for a stress response. So the stress response has to be a combination of various physiological factors which are interrelated. It should involve the endocrine system and should also involve the neural system. So it's a combination, and they work synergistically to improve this stress response. So one of the primary components of this stress response, of course, is the HPA axis. So when you look at the HPA axis, basically in very simple terms how we used to study in physiology, whenever there is a stress, first the brain identifies a stress response, then it signals to the hypothalamic neuron, the paraventricular nucleus, from where CRH is stimulated. The release of CRH will stimulate ACTH from pituitary, and the ACTH will act on the adrenal cortex, and it will increase both synthesis and secretion of cortisol. And the cortisol that comes out actually will activate both glucocorticoid receptor and mineralocorticoid receptor in the peripheral tissues, and those changes that come about in the peripheral tissues is what will sustain life. It's multi-system, cardiovascular, metabolic, immune regulatory responses, all of them, which will ensure that the patient does not die. So now the concept is, or the question is, during critical illness, we know that the HPA axis has to, increase its activity and increase the production of cortisol. So is there a problem if the adrenals do not respond in critical illness? And we know that this is an issue because in lab animals who have undergone adrenalectomy, when they are exposed to stress, there is uniform lethality, which means you definitely require the adrenal gland cortisol in order to ensure survival. We also have human data, correlating data, which is patients with Addison's. So this is primary adrenal insufficiency, and in the era before synthetic corticosteroids were available, the mortality rate was very, very high in patients with adrenal insufficiency. Even today, if there is inadequate or under replacement of steroids, this can be a lethal complication. So in patients with critical illness, if there is an intrinsic failure or insufficiency of any of those three glands, either the hypothalamus or the pituitary or the adrenal, which involves the HPA axis, this can actually cause what we call adrenal insufficiency, and this will lead to quick clinical deterioration and a life-threatening condition. So this is what adrenal insufficiency in critical illness will look like. They will come with life-threatening issues. So now we will just look at briefly history of how the concept of adrenal insufficiency in critical illness has evolved over the years. So historically, traditionally, what we are taught after the advent of synthetic steroids is that whenever there is stress, like for instance, severe stress, like a patient who is admitted in ICU, we have to give about 200 to 400 milligrams of hydrocortisone per day. And how did we arrive at this number? This is basically 10 to 20 times higher than what the usual substitution or replacement dose. And this is based on the assumption that in order to achieve the cortisol in patients who are critically ill, this is what a normal HPA axis would respond and produce. So that is how the golden figure of 200 to 400 milligrams of hydrocortisone per day have been recommended and used for a long period of time. Now, the first time this was assessed in the clinical setting and a new concept was introduced was way back in 2000, when they looked at cortisol as a prognostic marker to define or to decide whether it affects mortality. So they checked the basal cortisol, they gave ACTH stimulation and looked at the response to the ACTH stimulation, and they studied the 28-day mortality. So this was a landmark paper. So here you can see that the basal cortisol, if the basal cortisol was less than 34, survival was better. So it just says that, patients who are responding and producing a lot more cortisol probably have more sickness or are more severely ill, so they are likely to die. So lesser the cortisol, better the survival. Now the other factor was response to ACTH stimulation. So irrespective of the basal cortisol, when you gave ACTH, if the response was better than 9, the mortality was better. So here there was a relative adrenal insufficiency. Even though the basal cortisol is good, if the patient's response to ACTH is not adequate, that means there is some relative adrenal insufficiency which is leading to mortality. And this is a combination, and you can see that the best survival probability was when the cortisol level was not very high and the delta max was more than 9, which means adrenals are functioning adequately and responding well to ACTH. And the worst was when the plasma basal cortisol was extremely high and the delta max was less, which means patient is already severely ill, and on top of that the adrenal is not able to compensate. So this is beautiful data, very, very convincing data, and we were all quite enamored by this data, and we thought, okay, this is going to be true. But this was an observational study, so you really have to conduct an RCT, give corticosteroid and see whether there is going to be a benefit from this or not. So that would be the next step. So the same group put out a paper 2 years later where they looked at mortality after giving hydrocortisone, which was given at 200 milligram per day, and they found that there was a benefit in 28-day mortality. But after that, multiple RCTs failed to show that there was a significant improvement in mortality. So this is a 2008 Corticus and again 2018 article and the 2018 Adrenal article. All of them showed that the benefit of mortality was not actually there when patients received corticosteroids. So there was some benefit with regards to, mechanical ventilation timing or number of inotropes or reduction in the duration of inotrope use. However, it did not have mortality benefit either at the 30 days or the 90 days. And majority of the RCTs, except for 1 or 2, did not actually confirm that there was a benefit of mortality. So there was a lot of conflicting data with regards to mortality benefit. However, what was clear was that there was clearly benefit with regards to vasopressor use and days of mechanical ventilation. Most of the studies said hyperglycemia was an issue when you give corticosteroids, but otherwise no major harm. And there was no clinical difference between the responders and the non-responders that we saw in the first study, which means the delta change was less than 9. Did they fare better? They did not. So there was not much data to kind of back up the original observational data that we saw. So here it was time for us to relook at what is going on. Why is the patient not responding in spite of us knowing that, when the adrenals don't function, the mortality benefit is poor. So this is the next big challenge that came in 2013. There was we had to revisit how cortisol works in critical illness because of this paper, because this paper showed that the cortisol production was not significantly higher. It was actually the cortisol metabolism or clearance that made the cortisol level remain high during acute illness. So this is a picture which shows cortisol levels, and the blue bar shows cortisol in normal healthy individuals. So you can see in critical illness, the cortisol level persistently from day 1 to day 7 is clearly higher than what you would see in a person who was not under stress. But look at the ACTH level. This is the corticotropin level, and you can see that the ACTH level is consistently lower in patients who are critically ill. So this really doesn't fit well with our theory that the HPA axis has to be activated. CRH has to increase, ACTH has to increase, and cortisol has to increase when somebody is exposed to stress. Because here clearly, through the entire 7 days, ACTH was much lesser in patients when compared to healthy controls. So we have to have another explanation. Either something else is stimulating the cortisol, non-ACTH factor, or it has to be another reason like a reduced metabolism. So this came to be called as the ACTH cortisol dissociation, which is seen now and very, very well established fact in HP axis physiology during critical illness. So this, the same study group went on to look at the cortisol kinetics. To make it very simple, here you can see that this is roughly the rate of production. So you can see that in patients, the cortisol production is higher than in controls. So there is some amount of increase in cortisol production according to this paper. However, it is not as high as one would expect, because we thought 10 to 20-fold higher. So that much difference was not present. And when you look at the cortisol clearance, you can see that in patients, the cortisol clearance was much, much lesser. So hypercortisolemia is present, yes, but the major contribution was not more cortisol synthesis, but lesser cortisol clearance. That was the impression from this paper. And these are enzymes which are involved in cortisol metabolism. So if you look from B2E, you can see that all of the enzymes are much lesser in patients who are critically ill. So the cortisol clearance is not occurring, cortisol is not getting metabolized, and hence you have more and more plasma cortisol in circulation. So this, of course, study made us relook at the entire HP axis, the physiology of HP axis in critical illness. So this is just overall all how the anterior pituitary hormones behave when somebody is critically ill. So you can see that all the anterior pituitary hormones in the acute phase, there is a sudden surge. After that, all the anterior pituitary hormones, whether it is GH, ACTH, TSH, all of them show a steady fall going on to the chronic phase. The only hormone that responds to this initial surge is actually cortisol. But if you look at T3 or IGF-1, you can see that they actually don't increase concurrently with the pituitary trophic hormone, probably as an adaptive response to conserve energy. And then you can see that the peripheral hormones continue to reduce as the anterior pituitary hormones fall. The only opposition is cortisol, and here you can see that cortisol is elevated and it continues to remain elevated even when the ACTH levels fall. And this is what we have seen, this is similar to what we have seen earlier. This is plasma ACTH, which is much lesser than controls when patient is critically ill. This is plasma cortisol, it's much higher. The other interesting factor is the free plasma cortisol. So we know that bioactive cortisol has to be free. Cortisol largely circulates bound to either albumin, small percentage, and largely to cortisol binding globulin, CBG. So you know that the CBG also dynamics change when patient is critically ill, right? The CBG cleavage is increased, so there is less amount of CBG. Also synthesis of CBG from the liver is also reduced. So amount of functional CBG comes down, which makes sure that more and more free cortisol is available. So that is what is seen here. You can see that the free cortisol is significantly higher when compared to controls in patients who are critically ill. And this is just a brief on cortisol metabolism. What actually happens to the cortisol is that in the kidney you have this enzyme called 11-beta-HSD2 which inactivates it, and in the liver and adipocytes largely it is the reductase enzymes, both 5-alpha and 5-beta reductases, which reduce it. And if you remember the previous picture I showed you, this is 11-beta-HSD2 activity in the kidney. You can see it is less, and these are your 5-alpha and 5-beta reductase activity. Again, it is much less. So the cortisol metabolism is what is reduced when patient is critically ill. So just a picture of adrenal steroidogenesis just to kind of draw your attention towards few key steps. This is the ACTH. It acts on a receptor called the MC2 receptor, and this starts off a bunch of downstream effects. It activates this pKa, and the pKa has action on, this is the cholesterol synthesis pathway. So cholesterol synthesis increases, de novo cholesterol synthesis increases, and cholesterol is what you require for your hormone synthesis. Similarly, there's a lot of cholesterol stored here in lipid droplets. And how does the cholesterol get into the adrenal gland? It is through these two receptors which take up the lipoproteins, the scavenger receptor and the LDL receptor. And this cholesterol lipid droplet also releases cholesterol once ACTH activates pKa, and all this cholesterol enters the mitochondrium via the activity of STAR, and then you have the entire adrenal steroidogenesis pathway happening here. So why I'm showing you this is because ACTH actively stimulates this receptor, these receptors, this enzyme, and the STAR also. So here you can see, if you look at this picture, we'll spend a little bit of time with this. So these are all various proteins, gene expression of mRNA expression of proteins. So this is the MC2 receptor, the receptor on which ACTH acts. This is the scavenger receptor, and this is the LDL receptor, which takes up lipoproteins into the cell. And this is the cholesterol synthesis pathway, and this is adrenal steroidogenesis pathway. So here you can see that there are three columns there, or three bars there. The first bar is patients, these are all from adrenal glands of patients who have died. The first bar is patients who have died of sudden death, outside and broad death. So they have not really had a period to be exposed to so-called stress of illness or critical illness. So that is the first, that is taken as a control subject. The second patients are patients who died in ICU in a very short period of time, 5 to 7 days. And the last group is the patients who had a prolonged ICU stay beyond 20 to 25 days and then eventually succumb to their illness. So here you can see that there is a clear pattern emerging, that the sudden death and the short death, they don't really differ that much. In fact, if you look at the p-values, it's not significantly different in any of these parameters. But when you start looking at the long stay patients, you can see every step that ACTH is supposed to stimulate to increase cortisol synthesis in the adrenal gland is actually significantly lesser in patients who have been exposed to chronic prolonged ICU stay. So that is a take-home message. So this is a simple thing which capsulates it, that once the stress is there, hypothalamus gets activated, entire HPA axis get activated. However, if this stress is prolonged, then probably there is feedback inhibition from high cortisol, and there are other mechanisms in place to ensure that the cortisol remains high. So these are the newer insights. We have HPA axis dissociation, low ACTH with high cortisol. Cortisol metabolism reduction may be the most contributing factor. And also there is a redistribution of the cortisol volume. So plasma cortisol is not truly reflective of what is going on inside, and there may be iatrogenic factors that will interfere. So we look at three three quick scenarios. Scenario one is a frank adrenal insufficiency pre-existing. Clearly, this patient will benefit. Scenario two is what we're discussing about. Somebody is admitted to ICU, acutely ill. Should we treat them or should we not treat them? Scenario three is what I just showed you. Patient has had a prolonged ICU stay. Here, risk of adrenal insufficiency is high. So do we have any evidence to say that we should treat them? Scenario one, very clear, we have to treat them. Scenario two, we have extremely conflicting data, so it is important that we individualize these decisions. And in scenario three, it is important that we learn to identify adrenal insufficiency. This is possible in them, and if it is present, we should have some mechanism or some guideline to treat these patients. So this is just a picture depicting the prolonged critical illness and how it contributes to adrenal insufficiency. So this, we will just look at the therapy quickly. So this is in pre-existing, there should be no doubt. Maybe you can cut down the dose of hydrocortisone that we used to use earlier. Now when it comes to the random ICU patient who's been there only for a short period of time, if there is refractory shock, earlier guidelines said do an ACTH stimulation, look at the incremental cortisol, decide on therapy. We know that is not very useful now, so we don't have to do it, but you can consider treatment with 200 milligrams per day of hydrocortisone and assess the response. If the patient is not showing any response, there is no need to continue it. You can give it for a maximum of 5 days. The last one is what we call the prolonged critically ill patient associated adrenal insufficiency. So it's important for us to identify this, suspect this. What are the things that we should look for? Continued or unexplained requirement for inotropic support, some CNS manifestations, hyponatremia, hypercalcemia, and if these are there, we should consider giving them therapy. However, do not use the usual 400 milligram dose because we now know that cortisol metabolism is reduced even when you give exogenous cortisol. So hydrocortisone can be used at a dose of 60 milligrams per day and then tapered and stopped. So coming to the end of my talk, it is important for us to understand changes occurring during various phases of critical illness. And our understanding, though it has progressed, we have more unanswered questions and a lot of diagnostic and treatment dilemmas continue. Going forward, possibly the best way to assess would be to use the ACTH stimulated free cortisol in critical illness, but we do not have enough data as of now, and we don't have any clear cutoffs for treatment decisions. So we have to combine values that we get from the lab to the patient's clinical condition and then take a decision. Thank you.
Thank you, ma'am, for the wonderful talk and overview of CIRCI or critical illness cortical insufficiency, adrenocortical, and the session is now open for some quick questions, if any.
Yes.
Nice talk, ma'am. I have a question that in AACE algorithm, there is a concept of albumin corrected cortisol value, that is less than 10 and more than less than 15. So your take on that, should we use it?
So in critical illness, again, so there will be a lot of flaws in the plasma total cortisol that we calculate. Number one, CBG and albumin values will differ. In critical illness, we only assess cortisol, but actually 80% is attached to CBG, which is also reduced in critical illness. Secondly, in patients with critical illness, because of the redistribution of the volume, the plasma cortisol is not truly reflective of the total cortisol. We are only calculating the circulating cortisol, which is why it may actually underestimate the true cortisol that is there in the body. So going forward, probably it will become free cortisol estimation rather than total cortisol estimation, because there are too many flaws with total cortisol estimation in patients who are critically ill.
Good morning, ma'am. Excellent presentation. Wanted to know regarding the diagnostic tests for CIRCI, as you said, this 250 microgram synactin test, it's a flawed result because many of the trials have showed that it doesn't really lead to predict outcomes. Regarding the ACTH response, if the HPA axis is suppressed, 100 microgram CRH test, is it useful in this scenario?
Yes, so they have looked at CRH from outside, but to start off with, CRH is not available in India, so that's not an easy test for us to use. Secondly, even whether it's basal ACTH or CRH-induced ACTH, we don't have clear cutoff values as of now. So right now, we don't have a clear cutoff value to say that this is truly adrenal insufficiency, hence you would treat, but we have to use a mix of clinical and the lab values that we get, yeah.
Thank you. Thank you so much, ma'am.
So,
I believe that the data you have shown is from medical ICU. So is there any difference in terms of hormonal profile cortisol and SCTIs from medical ICU versus surgical ICU?
no, sir. So, irrespective of the admitting diagnosis, whether it is medical or surgical, the effects have all been the same. It's a mix of patients. We have data from both surgical and medical patients.
Thank you, ma'am, for the wonderful talk, and we conclude this session. Thank you so much. A round of now. Quickly move on to our second talk for the day, second talk of this session, which will be on approaching 46 XY DSDs, to be delivered by none other than Professor Vijay Sharthi, who is the head of the department at Bangalore, Vaidehi Institute of Medical Sciences, and sir will take us through 46 XY DSDs, primarily the genetics part of it, when to test. Thank you, sir.
So, good morning, everyone. At the outset, I would like to thank the scientific team of Crescendo 2023 for inviting me and giving this interesting topic. So, the topic is 46XY DSD. So, should genetic testing be the first line investigation? So, indeed, we always remember that 46XX DSD as the most common cause of DSD maybe a decade ago. It is true that indeed, even today, if you take a single diagnosis, congenital adrenal hyperplasia because of 21-alpha hydroxylase deficiency is the most common cause. But if you take a group of disorders, the 46XY disorders of sex development are the most common cause of DSDs. So let's crack how do we reach at the particular diagnosis or a specific etiological diagnosis among 46XY DSD patients. So why do we need to attain at the exact diagnosis in 46XY DSD? So we do have several implications of it, starting from the decision making for sex of rearing, which is sometimes quite imperative to have an early diagnosis as early as in few days. And it also has implications for the future therapies, including the timing of surgery, the hormonal therapies, and to predict the malignancy risk as well as predict the fertility. And of course, many other attained needs are there which are not highlighted here. So when we understand that there is a great need to attain an accurate diagnosis, so how do we achieve that? So what are the tools we can use to attain an accurate diagnosis in 46XY DSD? So very first thing we do is look at the gonads, then we look at the uterus, we look for the level of AMH, gonadotropin levels, steroid hormone levels, especially testosterone, including the ratios, that is testosterone to dihydrotestosterone and testosterone to androstenedione, and finally the genetic testing. So as of in our armamentarium, the genetic testing is quite down the line. So let's look at how each of one perform in giving you an accurate diagnosis. So look at the gonads. We know that if they're palpable, it rules out GD. So that's what we always believed, right? Is it true? In fact, indeed we are recently reviewing the data of SF1. We have collected around 200 odd patients of SFN from the literature and from our KEM center. So if you look at the presence of palpable gonads in SF1, which is actually a known cause of gonadal dysgenesis, 80% of the patients have palpable gonads. So where does this rule stand for? So definitely the palpable gonads does not rule out the diagnosis of gonadal dysgenesis. Similarly, it's not uncommon that we don't have a palpable gonad in the other sex differentiation defects, that is non-gonadal dysgenesis disorders of 46XY DSD. So there almost 30% will have non-palpable testes. Indeed, in 5% of them, even if we do an ultrasound, we won't be able to localize the gonads. So this probably is not going to help us clearly know even to differentiate between dysgenesis versus non-dysgenesis. Let's look at the uterus. So again, it's the same issue as like a palpable gonad. So in patients, we know that if the uterus is present in a 46XY DSD, the diagnosis is for sure it's an XY gonadal dysgenesis, though the other rare possibilities of PMDS and mixed gonadal dysgenesis, which could be really in 46XY also could be the other DDs. But again, coming to SF1, 80% of the SF1 patients will have absent Mullerian structures. So if you take that Mullerian structures have to be present to make a diagnosis of gonadal dysgenesis, you may miss 80% of SF1 patients. On the contrary, though extremely rarely, usually a miniature Mullerian structures have been reported even in histopathology and some of the AAS patient, that is androgen insensitivity syndrome. So again, the uterus presence or absence is not going to give us an accurate diagnosis to differentiate dysgenesis and the non-dysgenetic 46XY DSD. How good is AMH? So probably slightly better than the other previous two. So because whenever it's low, it favors GD. But though in SF1, still a proportion of patients had AMH, this proportion was pretty small compared to the uterus and the gonads. It's only around 15% who had a normal AMH among the SF1 patients. But it's on the other side, it's not uncommon to have a low AMH in other sex differentiation defects that is non-dysgenetic DSDs of 46XY. So indeed, like this is the data from KEM, which I closely work with. So we had data of around 150 patients where we have done an NGS and we have looked at the data. So in this data, when we looked at the AMS, you can see the AMH is all around. So it's consistently, it's low in gonadal dysgenesis, but it's not uncommon to other conditions to have a low AMH. As you can see, even 17 beta, some primary that androgen biosynthetic defects, all of them had low or low normal AMH, which may confuse you as a gonadal dysgenesis. So AMH is also not giving us a clear answer. So let's look at the gonadotropins. How do the gonadotropins fare? In fact, like when we are doing DM, this was one of the very useful tests we always used to look at to know what is the possible differential for a 46XY DSD patient. So let's look at the data from mini-puberty, again data from KEM. So the data was useful only in 2 patients who had an FSH which was markedly elevated. Those were the only 2 patients where we could definitely say they were the gonadal dysgenesis patients, whereas in all other patients FSH was not elevated. Not at all useful was the LH, whereas again testosterone, probably we were looking for a height value and androgen insensitivity syndrome and phi alpha reductase deficiency, but again the accuracy was very minimal. In fact, it was not, in fact, not surprising to see even a gonadal dysgenesis patient had a testosterone of 7 nanogram per ml. So these values are not helping us. Another caveat in evaluation of these testosterone and FSH LH is that in the mini-puberty especially, the complete androgen insensitivity syndrome patients will not have an activation of the HPG axis and the basal levels will be similar to a gonadal dysgenesis patient or a testosterone biosynthetic defect patients. But fortunately, they are stimulable to HCG, and if at all, if you have any patient with mini-puberty and the low values, don't just conclude that it is a dysgenesis or a testosterone synthetic defect. You may still be having a CIS with an suppressed HPG axis, so always consider an HCG stimulation over there also. So moving on to the puberty and post-puberty, how do these gonadotropins and androgen are helping us over there? So again, if you look at the FSH, so at least in a small proportion of GD patients, when it's more than 40, we are quite sure what we are dealing with is actually gonadal dysgenesis. But for differentiation among other conditions, FSH is not helpful even in post-puberty who are rated as males. So when I'm saying about males rated as males, they're typically the partial defects in all the spectrum. Look at the LH. LH is all around, definitely no differentiation, but probably what you can see here where it was not very high is actually phi alpha reductase deficiency. Then look at the testosterone. So testosterone was probably somewhat helpful. When it's more than like 4 to 6 nanogram per ml, it's quite often likely that we are dealing with phi alpha reductase deficiency or androgen insensitivity syndrome. Again, the accuracy was not great. So let's move on to now pubertal or post-pubertal patients who are being rated as females, that is XY females. So probably these tests were more useful in this setting. The FSH was quite elevated in gonadal dysgenesis as well as testosterone biosynthetic defects, whereas in phi alpha and androgen insensitivity syndrome, they were pretty much below 20. So at least here we know a more than 20 is pointing towards either gonadal dysgenesis or androgen synthetic defect, but in the other 2 conditions, it's less than 20. But however, LH is not helping here because even LH elevation more than 20 is not uncommon in patients with androgen insensitivity syndrome. But again, somebody who is less than 10, probably more likely to be a 5-alpha reductase deficiency. So again, we look at the testosterone, probably slightly more helpful when compared to those who are raised as males, but again, still not accurate. So let's look at the ratios. So the testosterone DHT, in fact, again, like as was discussing about with Dr. Rana previously, we talked so much about TMP and GFR in rickets. Similarly, we talk about so much on T by DHT and DSDs. But what is the great utility of it? So is it really accurate? So if you look at the 5-alpha reductase deficiency, so few may still have a ratio between 10 to 20, but more than 20, at least is it specific to 5-alpha reductase deficiency? No. So if you look at even other patients, there's quite a good amount of patients who had an elevated T by DHT more than 20, which you made a diagnosis by biochemical diagnosis, you would have made a diagnosis of 5-alpha. But actually when we look at the genetics, they were not 5-alpha. It's not only our study from KM, even there are a lot of studies which have shown the poor accuracy of T by DHT ratios. So as you can see here, even in testicular feminization syndrome, at least more than 2/3 of the patients had a value of more than 20. So more frustrating results probably came from AIMS, where almost around 90% of the patients with anterior insertase syndrome or conditions other than 5-alpha had a ratio of more than 10. So what we conclude here, the T by DHT is definitely not a useful tool to differentiate 5-alpha from other conditions, though it could be relatively sensitive for 5-alpha, definitely not specific. So let's move on to another interesting ratio, that is testosterone by androstenedione ratio. Typically we know that less than 0.8 usually favors the diagnosis of the 17-beta HST type 3 deficiency. So in fact, like we did a very detailed systematic review and published in Clinical Endocrinology 2 years ago. So it's relatively doing good for the non-Asian patients, but in Asian patients, especially in the Indian cohort, so it's not having a good sensitivity. As you can see here, so almost 4 out of the 5 17-beta HST deficiency patients had a ratio of more than 0.8. However, it was relatively specific, though 2 patients had a less than 0.8 despite not having 17-beta HST deficiency. So what we conclude here is that these ratios are not useful. Initially when we got this abnormal ratios, we thought whether the assays are going wrong. Indeed, we had an opportunity to repeat the ratio by LCMS by 1 patient. Even after repeating the ratios by LCMS, the ratio still remained discordant. So we show that it's not assays, probably some other parameters which are preventing the accuracy of these tests in the accurate differentiation of the 46XY DSDs. Right, so when we are doing all these tests, so we are not getting an accurate diagnosis, but we are losing money. So at every step we do an investigation, we are spending good amount of money over that. So another important thing I talked about was a steroid panel. Indeed, like we had a steroid panel which was very useful for us till last a year and a half or so. So where that 13-point steroid panel was actually using it as providing dihydrotestosterone and estradiol. But these are only 2 hormones when compared to all other hormones in the panel which are expressed in picogram per ml. So that means they exist in a pretty smaller concentration in the circulation. So obviously the concentration is smaller, it's very difficult to attain a standardization and give accurate results. There's a reason that the commercially service providing center, they stopped providing these values and indeed they moved to other agents like 21-deoxycortisol and 11-deoxycorticosterone, which are actually not helping to evaluate a 46XY DST patient compared to the old panel. Indeed, we urged them to include DHT and estradiol for a few months, but after that we had another interesting patient. As you can see here, the T by DHT for a patient came as 3.9. So we thought it should be a diagnosis other than 5-alpha reductase deficiency, but when we did the genetics, it was indeed a 5-alpha reductase deficiency. So indeed, after that, we stopped stressing up on the steroid panel DHT values as well. So here, all biochemistry, including steroid panel, are going wrong. So probably we need to look at something which is robust, something which is more accurate. So then we moved on to genetics. So what are the genetic modalities we can have? So we can have a karyotype, which is typically for any losses more than 5 to 10 megabases or large chromosomal abnormalities can be picked up. Whereas next is the fish, where probably 50 to 500 kb losses or duplications can be picked up. Whereas further smaller changes like 10 kilobase changes, either duplication or deletions, can be picked up by microarray, which could be either a CGH or an SNP. Or small base pair changes, including the single base pair changes, can be picked up either by Sanger sequencing or the next generation sequencing. So when we talk about next generation sequencing, probably the more robust ones are the targeted gene panel, especially for 46XY DST, where we are going to look at only the known genes which have been associated with DST. The list is indeed expanding. Initially to start it was 34, maybe 7-8 years ago. I think now it's crossing more than 150 genes. If at all, in the next level is probably want to more answers are the whole exome sequencing, where we are going to sequence all the protein coding sequences of the DNA. And the next one is the whole genome sequencing, where probably we would be looking at, so not only the protein coding regions, even the non-coding regions, that is both exons and introns. So coming back to the experience of KEM, so we had 150 patients, out of which 78 had identifiable molecular diagnosis, giving a yield of around 52%. And among them, pi alpha reductase deficiency is the most common, followed by androgen insensitivity syndrome. Indeed, the yield in our study is slightly better than the previous studies, with a yield of around 52%, but still almost around nearly half of the XY DSDs are not answerable. So there are several mechanisms why you're not able to pick them up. There's something called as androgen insensitivity syndrome type 2, so which has been given several explanations, maybe some imprinting defects, maybe some variations in the promoter region, which probably the routine genetic testings are not picking up, or also there's a scope for the fetal milieu, which is affecting the genital formation. So, but a very recent study, in fact from Brazil, where probably the Mendonica works, and one of the greatest work done by her in the field of DSD has given us many lessons to learn, and it's her study, and indeed they could achieve the diagnosis in around 60% of the patients. So this is a paper which actually made a big difference, or probably people now thinking towards the initial or the first line diagnosis with genetic testing. So when we talk about the targeted gene panel, but like which is commonly we are doing in our routine clinical practice, so is there any advantage of considering whole exome sequencing either in place of clinical exome or when clinical exome doesn't give an answer? Yes, we can consider, but it's going to give only 5 to 10% of additional yield. But it gives a unique opportunity to identify the new candidate genes, especially for people who are working with research. But often we have to send a sample of parents along with the index case, because we don't know what are the genes where we are going to isolate the abnormality, since we don't know what is the function of the gene. So the very great reliability to know whether the change which is observed is abnormal or normal, or it's pathogenic or non-pathogenic, depends on the comparison to the parents. Moreover, the whole exome sequencing has a relatively lower depth. It's not as robust as targeted gene panel, and the low frequency variants may be missed. The other variations like aneuploidy, low level mesoism are also missed. So another interesting thing probably where we are trying to increase the yield in patients with 46XY DST is the microarray, especially in patients where there is syndromic DSD. In that set of patients, it's definitely going to be useful. But there's also some use in non-syndromic gonadal dysgenesis also, but it's only around 5%. Even in KEM cohort, when we had a large number of gonadal dysgenesis patients who did not have an underlying genetics, we thought we may be missing some amount of CNVs, that is copy number variations. So when we asked for this, the SNP array, but the results were very disheartening for us, because only 1 out of the 20 had a microarray. In fact, we have to shell out a lot of money on that. So, but probably in Indian setting, it may not be a very useful test to increase the yield. Even in the Brazilian cohort, the 2 in the syndromic DSD cohort, we probably were expecting a greater yield. Even in that, there was only a yield of around 3/17. The surety of diagnosis was only in 2/17. So with this data coming up with a greater yield from Brazil, there was an editorial in the JCM, why not the next generation sequencing be the first line diagnostic test? Yes, of course, definitely it provides a quicker and more accurate diagnosis, but it has its own limitations. So indeed, the old approach we always followed was a stepwise approach, but including the guidelines from DSD-NET, now they say rather than going for a stratification, you go by parallel testing, you do the clinical phenotyping, biochemical analysis, genetic analysis, all at one go, so that you reach at the management decisions faster. But nevertheless, the clinical phenotype and the biochemical phenotype can definitely help us in choosing which type of genetic test we have to choose. So as you can see here, if there is syndromic features, definitely it is the array which could be a first line of investigation. So if it's hormonal evaluation, give us something to have a specific etiology, definitely we can go for a targeted gene panel test. If not, definitely it's a whole exome sequencing. So if targeted gene panel does not answer when we are suspecting etiology, still you can go to whole exome sequencing under our array as a second line test. So with this, I would like to conclude my talk. Thank you so much for the patient hearing.
Thank you, sir, for your wonderful talk on 46XY DSDs. For want of time, we'll allow only one or two questions if there are from any of the delegates. The talk was so self-explanatory, we do not need any questions.
Thank you.
Thank you so much, sir. Thank you so much for that talk. Another round of applause for sir. With that, we move on to the third talk in the adrenal session to be delivered by Professor P.K. Jabbar, sir, who heads the Department of Endocrinology at Government Medical College Trivandrum and who also happens to be the President-elect Endocrine Society of India. So we'll be talking about primary adrenocortical insufficiency in pregnancy. Sir.
Slide. Good morning, everyone. Regards from God's own country, Kerala. Respected senior members of profession, Dr. Nilanjan, Dr. Subhankar, co-faculties, friends, ladies and gentlemen. I'm extremely happy to be a part of this beautiful conference in this beautiful place. My topic is unfortunately a rare situation. As such, primary adrenal insufficiency is not that common, and pregnancy, if a patient comes with adrenal insufficiency and pregnancy, things can get complicated. So I will discuss with a basic case discussion today. I know this crowd is a mixed crowd, consists of faculties, postgraduate students, practitioners. So I will start with the case. We have a patient, 34-year-old female. Patient is having recurrent episodes of lassitude, and especially this happens during stressful events like a short febrile illness. And she used to take a lot of salt also. Whenever she gets malaise, she will go for salt intake. And patient gives history of autoimmune thyroid disease in the form of an Hashimoto or something like that, and patient is taking thyroxine for that. Admitted in local hospital many times because of these problems. After some time, the patient will become better and they will discharge the patient. No history of any significant medical illness in the past. This was a picture. You can see what's happening in the dorsum of the hand and the face also. You can see patient has got significant hyperpigmentation. My dear friends, this was a picture much more before, and you can see the patient complexion on the left side. It's pretty good and fair complexion, and subsequently as the disease progress, patient the pigmentation has increased. You can make a diagnosis from this picture itself. So what is investigation of choice for this patient? There are n number of causes for hyperpigmentation. One of the cause for hyperpigmentation for an endocrinologist point of view, that is adrenal insufficiency. What is a diagnostic investigation? Just go for a basal cortisol value. If the basal cortisol value less than 3 micrograms per deciliter, that indicates patient has got adrenal insufficiency. Having made a diagnosis of adrenal insufficiency, your job is to look for the problem. Is it a pituitary disease or an adrenal disease? The investigation of choice. If you have a good laboratory, ACTH is the investigation of choice. For our patient, the basal cortisol was practically not detected and ACTH is sky high. That clinches the diagnosis of primary adrenal insufficiency. If you see the right side of the panel, thyroid function reported as normal with the antibody positivity. We could not find out any other association like premature ovarian problems or B12 or pernicious anemia, and the final diagnosis would be patient has got an autoimmune thyroid disease and Addison disease. This gives a final diagnosis of autoimmune polyglandular syndrome. That's a final diagnosis. Now, suppose this patient wants to go for pregnancy. What are the issues you should address? Pregnancy, as I said, is sometimes difficult to conceive because of many reasons. Because an ovulation may be defective and patient may be having some occult autoimmune phenomenon in the level of the ovary also. So sometimes a pregnancy can get delayed. But if you pick up adrenal insufficiency or Addison disease and giving proper treatment, definitely fertility status is good. Now, let us discuss what's happening in the pregnancy and adrenal physiology. You can concentrate only on the right side. Each trimester cortisol or total cholesterol is going up. You can see that. You see that open circle is cortisol and the close one or dark line shows ACTH. So proportionately your ACTH is also going up. The lower panel, what is shown there is CRH level. My dear friends, what's happening here is each trimester cortisol is going up, ACTH is going up, and CRH is also going up. So CRH, I'm not discussing it again. What you should understand that basically pregnancy is a hypercortisolemic state. So eventually you may think that this hypercortisolemia, will it produce any fetal effects? Practically no. That's because of placental 11 beta HST that will inactivate the cortisol. So God has given a beautiful system to protect the fetus. Now, renin-angiotensin system, these are very important because you can ask for any investigation for that matter in pregnancy. One of the common teaching by my teacher is don't investigate the patient during pregnancy and critical illness. That's a very basic information from our teachers. So what I want to tell you that renin-angiotensin aldosterone system is also overactivated. So these investigations are not useful for the monitoring of mineralocorticoid treatment. Please remember, this is the bedside view. What's happening here in the placental changes, you can see when finally the cortisol is increasing, ACTH is increasing, and CRH is also increasing. So basically everything in a phase of hyper, that's what's happening. So let us explore what are the causes of adrenal insufficiency. I'm not discussing nothing peculiar. All the causes of Addison disease that is applicable for in pregnancy also, any cause, but by and large, the commonest cause is autoimmune disease. What is happening in our place? Little different, but there also, I think it's a commonest cause is autoimmune phenomenon. So this was a picture. When we saw the patient on the left side, you can see, and the patient was having hyperpigmentation. After a few months of treatment, patient became absolutely fine and patient's very happy. Now, this patient wants to become pregnant. So, what are the issues we should address? Pregnancy, you should change the molecule sometimes, and you should modify the molecule dosage, and monitoring also you should discuss. So, these are the three important points we should discuss. But no history of adrenal insufficiency or Addison disease. There are a lot of other challenges also. Because in first trimester of pregnancy, what are the usual symptoms of pregnancy? You will have fatigue, you will have hyperemesis-like situation, little anorexia. All these situations likely to get mistaken with, say, your simple pregnancy or is it adrenal insufficiency. Mind you, adrenal insufficiency is not the common cause for all these symptomatology. So we are likely to miss these type of problems. But fortunately, the first incidence or first case of autoimmune adrenal insufficiency is unusual, so we are lucky. Now, how to diagnose? First thing is clinical. On the right side, you can see one picture here. Symptoms are more or less same. And on the right side, we have a patient like that with a plasma, and somebody made a diagnosis of adrenal insufficiency because he was thinking that the ACTH is responsible for this pigmentation. But by and large, clinical manifestations are same. But if the patient has got mild hypernatremia, 2 to 5 millimoles, please suspect the possibility of adrenal insufficiency. This is one of the clue. And in first trimester, I told you, this patient can go for an adrenal crisis also, and mortality was pretty high, but in the present current scenario with modern technology, we are picking up adrenal insufficiency, and I think this awareness factor is also very good. So we are picking up adrenal insufficiency, and mortality has come down significantly, definitely significantly came down. And there are small issues, fetal problems is definitely described, like little IUGR, birth weight. But what is written and what's our experience is, if you are giving correct replacement dose, you can avoid all these complications of practice. This paper, this paper we showed, they were looking at the outcome in more than 1,000 patients with autoimmune adrenal insufficiency. Risk of cesarean section and preterm delivery, it was slightly higher, and fetal mortality, morbidity, Apgar system, everything was similar. It was not significantly increased. Now coming to the diagnosis, very funny situation. Diagnosis in pregnancy is not that easy, very easy to discuss, but it's very difficult. So if you get a very low value, as in our patients, very easy. But there are the changes in the cortisol dynamics also, sometimes you'll be in trouble. So if you have a patient very low cortisol and very high ACTH in pregnancy also, that will clinch the diagnosis of Addison disease. If nothing is there, if everything is equivocal, such a situation you can go for synactin test, which is not absolutely contraindicated in pregnancy. But see, there are physicians thinking in a different direction. Why don't you treat the patient and reinvestigate the patient? That's also probably acceptable. So this paper, what is shown, a junk paper that showed in pregnancy, these are the changes with the cortisol. What you can see here, the cortisol is increasing, pre-cortisol is also increasing, and CBG also with the influence of estrogen, CBG is also increasing. And this is couple of papers you can see here. The level of cortisol, salivary cortisol and pre-cortisol is well described by various authors like Suri, Jung, Abreu articles. A lot of articles are available. Everything gives an information that the level of cortisol is changing in pregnancy. That's a message. Cosintropin, even though it's a category C drug, it's not contraindicated, you can do that. Of course, the values are different. This one paper, Suri's paper, which showed the level of cortisol, level of salivary cortisol and aldosterone, everything increases with each trimester. And finally, we have a value for synactin test positivity. If value exceeding more than 25 micrograms in the first trimester, 29 micrograms in second trimester, and last trimester, if the value is exceeding more than 32, that will give a diagnosis of normal or adrenal sufficiency state. Now, these are the data with your salivary cortisol. Also, salivary cortisol, we tried to do that, but we could not succeed because of some technical problem. And there are various data available with salivary cortisol also. These are the normative data available with from various authors. There are other investigations just for the theoretical discussion, like insulin tolerance test. You can go for metronidazole test, but all these investigations are not really needed. Probably that is dangerous if you go for metronidazole test, that can kill the patient because of adrenal crisis. That will suppress the level of cortisol. Insulin tolerance, in my institute also, so we are not doing insulin tolerance test. And coming to the other investigation, just for theory discussion, autoantibodies. I can't go for autoantibodies for all patients, but what is written in the textbook, up to 80% of the patient you can get positivity if you are dealing with autoimmune thyroid disease. Coming to the imaging, by and large, what I feel, and personally I feel that imaging you can postpone, and if you want to go for imaging, probably or perhaps MRI is the investigation of choice and safe also in our pregnant patient. Now coming to the second hormone, that is mineralocorticoid deficiency, my dear friends, see this edema you can get in pregnancy, little other problems also you can see, there are a lot of overlap is likely to happen, and basically renin, angiotensin, aldosterone is getting activated and the level is high, so these are practical difficulties for monitoring this type of patient. How to manage this patient? By and large, there is no difference between pregnant adrenal disease and non-pregnant adrenal. The most important issue is you pick up the case, educate the patient. That's very important. I think so we are all giving classes to our patients to give intramuscular injection of steroid preparations also. Even though it's not that easy, but it's our duty to educate the patient regarding the stress cover also. Choice of drug, as usual, hydrocortisone, but in our experience in our hospital, being a government hospital, we used to give prednisolone also. It gives very good result, and I think adequacy is very difficult to assess, but practically the clinical methodology, clinical pointers, clinical findings are very, very useful for looking for the sufficiency state. Usual dose is around 20 to 30 milligrams of hydrocortisone, multiple doses, various others gives multiple doses, 2-dose regime, 3 doses regime, and 4 doses regime is also described by various others. But by and large, the last trimester, please remember that you may have to give little extra dose to a 25% of the basal dose. That's an important message you should remember. And you can go for cortisone acetate also. Corticosteroid is not really studied in pregnancy. Plinadrin or chronocort or all those preparations are not, we don't have any data for the time being. But mind you, dexamethasone treatment for adrenal insufficiency in pregnancy is contraindicated. This very important message. Dexamethasone is not the drug of choice for adrenal insufficiency in pregnancy. Please remember that. Mineralocorticoid, you can go for fludrocortisone. There is no issue. But increase in dose probably is not needed if you are, especially if you are giving hydrocortisone. And this chart gives a beautiful the topic presentation, glucocorticoids, mineralocorticoid, and there is no role for DHEA also in pregnancy and adrenal insufficiency. And monitoring, I am repeating the same sentence again and again, clinical point is there is no role for hydrocortisone curve, no role for any other assay, ACTH, all those things for monitoring purpose. Even mineralocorticoid activity also, you can go for electrolytes. Don't go for renin, aldosterones, all those things for the monitoring purpose of your mineralocorticoid. See, this paper gives 128 pregnancy they were studied. Hydrocortisone was commonly used, the corticosteroid preparation there. They could reduce, or they had to increase the dose of hydrocortisone to the tune of 50%, and a few patients they reduced the dose of fludrocortisone also and hydrocortisone. Delivery, see, so stressful events, always you should be ready with the stress cover, and once the cervical dilatation above or exceeding more than 4 centimeters or 1 contraction per 5 minutes, probably the time to start your treatment. And post-delivery, you can change the medication to pre-delivery system. Lactation, you can continue same medication. There is no contraindication at all. The breast milk, the level is very meager, very small in quantity, so there is no issue. And I'm not discussing anything about adrenal crisis because Dr. Belinda discussed in detail regarding the adrenal crisis. There is no difference between adrenal crisis management between pregnant and non-pregnant. My dear friends, let me finish my topic discussion here. Addison disease, an uncommon situation. It's not a common situation. Don't think that all these clauses are due to adrenal insufficiency. And recognition of Addison disease is very important. There are many challenges, especially diagnostic problems, and cortisol dynamics is changing. Outcome is usually good. And I think you should get the help of your friends also for a better outcome. Ladies and gentlemen, let me sign off. Thank you very much.
Thank you, sir, for that wonderful talk on adrenal insufficiency in pregnancy. The forum is now open for discussions.
you have rightly pointed out that we should monitor the patients with clinical parameters and also biochemical parameters, electrolytes mainly. We should not do ACTH level. But how is your experience in the long run in managing adrenal insufficiency patients and your patients also after adequate replacements? The patient's complexions become pretty fair. So what is your experience regarding the mean ACTH level after long-term adequate replacement? So how many patients actually you are able to prevent Nelson syndrome?
Sir, for the monitoring purpose, for diagnostic purpose, yes, we used to go for ACTH. Not for all patients. Sometimes, say, I told you I'm working in a government sector, I can't go for all the investigation, but I've written the textbook. But for diagnostic purpose, since we started our DM training, and we used to go for ACTH. For monitoring purpose, I never did ACTH for monitoring purpose. And for this patient, clinically patient improved, I think that's more than enough. In our setting, that's more than enough is possible also.
So,
I never looked into the ACTH level. Nilanjan sir, did you look for ACTH for monitoring?
No, I don't. Only for that.
Yeah.
So in spite of adequate treatment, we have seen patients that patients' complexions also sometimes becomes fair, sometimes becomes darker. And in the interest of in academic interest, we did ACTH monitoring in some of our patients, and it remained still high.
Yeah.
And we also did MRI in one of my patients.
For this patient, when we looked into the clinical picture, the patient showed good improvement in the pigmentation. We stopped there. We did not do that, to be very frank. Okay. And what I feel is a clinical method is the best method to assess the sufficiency. And very clearly written in the textbook, given the position statement, no value for ACTH. Even when in our time, when I was in KM hospital, we used to go for hydrocortisone curve and all. I think that also outdated for the time being. Okay. Sorry, I don't have much experience.
ACTH may not be suppressed. You may not be able to normalize the ACTH, but if the clinical response is good, I think that is good.
It will never become normal. Yeah. In spite of adequate replacement, in spite of thorough adequate replacement, it will never become normal. No. We should not attempt to suppress the ACTH level. It will never become normal.
If there are no further questions or comments,
thank you very much.
I'd like to thank Jabbar sir once again. Big round of applause. We can now move to Hall A, where we have the Soroshi Ranjan Memorial Oration right now about to start. And we will reassemble in this hall again at sharp 12:45 p.m. for two interesting discussions on hypopara and aldosteronism. Thank you everyone. Thank you so much. We had a lovely oration by Bansali sir in Hall A, and now we move on to our first session to be delivered by Professor Ravinder Goswami sir from All India Institute of Medical Sciences, New Delhi, who will be talking about an update on hypoparathyroidism. I'd request sir to please. Thank you sir.
Can I start? Yes. Okay. Good afternoon. I shall be briefly covering the salient aspects of hypoparathyroidism. It is a simple topic, and many of you might be knowing almost everything what I am going to talk. But still, whatever new points you can pick up. These are my authors. In fact, all my works, but then more than the authors, they are friends also, because they have gone out of the way to help us in our research. Considering the number of patients we have, we are working on idiopathic hypopara. Why we are working on idiopathic hypopara? Because our teachers told to work on problems which are not solved. So we pick up the problem like idiopathic premature ovarian failure is another aspect, malnutrition related diabetes mellitus was another thing. Unique aspects of Graves in India was another area where we worked. But ultimately I settled into this idiopathic hypoparathyroidism for last 10-15 years, and I shall be giving you brief whatever I have done in hypopara. Diagnosis of hypopara is very simple: low calcium and low PTH. You may have high phosphorus or may not have, but then low calcium, low PTH defines the hypoparathyroidism. Most cases are surgical, post-surgical cases, and they are really very severe because immediately post-surgery there is hungry bone syndrome and it's difficult to control calcium level. So as such, post-surgical, because you remove the parathyroid gland from the body, so there is no action of PTH left in the body. So these are more difficult to treat post-surgical. Pseudo-hypoparathyroidism, they are easy to treat because there is still some PTH action, and the midway lies the idiopathic hypoparathyroidism when you want to give them calcium. And the post-surgical, besides post-surgical idiopathic, you have a congenital disease such as DiGeorge syndrome or ARI, the Epcot syndrome, which is also called type 1 APS. Just to give you a summary, if we get around 120 grave disease patient, we have around 10 to 12 patients with idiopathic hypoparathyroidism. And in our clinic every year, Dr. KVS Hari has a data in clinical oncology where he showed that 2 patients of idiopathic hypoparathyroidism per lakh patient years. So it is really a rare disease, and why it is over a period of years, we have around 300 subjects in the last 22 years, which we have carefully maintained this cohort. Why we have 10-12 patients in one room every year, and that itself is a huge number compared to Western data, maybe because we have background vitamin D deficiency which makes their hypocalcemia more manifest. Large number of patients give us a unique opportunity to study their pathogenesis and clinical aspects. In the pathogenesis, we already had a hint from the familial and type 1 APS that this could be query autoimmune, and in the familial could be genetic. So we took up those hints and started investigating our cohort of idiopathic hypoparathyroidism. From the autoimmune point of view, we first looked for the calcium sensing receptor autoantibodies using parathyroid adenoma tissue and Western blot technique, and we found that 40% of the patient had calcium sensing receptor autoantibodies, but then the 13% control also showed similar autoantibodies, so non-specificity was there. Subsequently, we cloned the antigen and then showed that the prevalence of autoantibody in idiopathic is in 12%. It's associated with HLA type 1, indicating that CD8 mediated mechanism is operative in the loss of parathyroid tissue. There is a specific antigen which is associated with type 1 APS syndrome, that is called NALP5. And its antibody is also specific in the type 1 APS syndrome. But none of our idiopathic hypoparathyroidism had this autoantibody when we tested around 160 of them, indicating that it's truly idiopathic, not a variant of type 1 APS syndrome. And 12% we could find autoantibodies. Because we got the hint that autoantibodies are there, we wanted to see whether they have associated thyroid autoimmunity there or not, because spread of autoimmunity is common in autoimmune disease. And if you can see that they have spread of autoimmunity to thyroid, but the prevalence compared to controls is just, they have 14.6 sporadic idiopathic hypoparathyroidism, 14.6% prevalence of thyroid peroxidase antibodies, unlike type 1 and premature ovarian failure, which are the first 2 bars. So it is not a huge problem of spread of autoimmunity. They do not have other major problem except they come to us with hypocalcemia and remain as idiopathic hypoparathyroidism. Spread of autoimmunity is not very common in them. Similarly, the remission, which is a feature of autoimmune disorders, is also not a feature of idiopathic hypoparathyroidism. Over a period of 20 years, we have seen only 1 patient who has truly gone into remission, and 3 other patients who had gone into remission, they came to us as idiopathic, but when we carefully looked their history, they were pantoprazole induced hypomagnesemia, and then reversibility happened when they stopped taking pantoprazole and when their magnesium levels corrected. So truly remission is not a feature of this idiopathic hypoparathyroidism disease, and we should not give false hope to the patient also whether they will recover or not. We do say that one patient in 300 has recovered, so if luck is with them, they will be extremely lucky. Compared to the genetic causes, if you see the genetic causes, we did the PTH gene sequencing but found normal in all except 1. Here it was normal, but when we did 160 patients, 1 patient showed PTH gene sequence. Calcium receptor gene sequencing initially in 67 and subsequently again in 160 was normal. These are common autoimmune genes, CTLA4, PTNP, they were not present in the huge number. So certain genetic features which are associated with autoimmune disorders are also not seen, such as CTLA4 and PTN. Calcium sensing receptor gene mutation which is seen with familial hypopara is not seen in them. What we found interestingly was that there is a gene called GCM2 which is also associated with familial hypoparathyroidism, and we were thinking that we may not find this gene also in our cohort, but to our surprise, we found this gene in around 12% of our idiopathic hypoparathyroidism and none of the 600 controls which were tested, indicating that it is very specific to hypopara. But we will consider it as a first hit only because several of their relatives, they also had their GCM gene mutation, GCM2 gene polymorphism or similar mutation, R10W mutation, and probably so another hit is required. Maybe the compound mutation or multiple mutations are required for patient to manifest, and relatives are just surviving normally with one mutation of R10W. So it is a specific mutation, but it's not the all which give rise to hypopara. It's a functionally relevant mutation. I will not go into detail because it prevents the loss of bind. It's a transcription factor. GCM is a transcription factor, and if this is mutated, it doesn't bind to the DNA response element. So in our case also, this mutated gene was unable to bind with the DNA response element. So ultimately, if I have to summarize, 12% of our idiopathic hypoparathyroidism, they have calcium sensing receptor autoantibodies. 11% has GCM2 antibodies. There were no overlap in these two disorders, so they were separate disorders. So it becomes 2% had Apert syndrome because one patient has an LP5 antibody and only one patient had PTH. So altogether around 20-25% patient we have the etiology of idiopathic hypopara known, we can see. And currently now when we are not seeing any more scope, in 2 NGS has come from the Western society which has shown that calcium sensing receptor gene and PTH gene, these are only 2 mutations which are seen, but we might find different results in our population because by now among 300 cohorts we have 8 families where multiple family members are involved, and we are thinking of doing NGS for them. So we are in the process of gathering funds for this. If you see the symptoms, these are usual symptoms which all of you see. Lot of calcification in the form of cataract, basal ganglia calcification. Seizure is common. I will come to all of this in a short while. Usually in 30 age group, equal male-female ratio. Serum calcium can be as low as 3 mg/% and phosphorus can be as high as 12%, especially in children. They rarely can present. When 1992, when I first published a case report, it was a hypocalcemic heart failure in hypopara. Subsequently, we showed that even reversible neurological signs are possible. If you treat calcium, their neuropathy disappears. And very recently, we had a patient who came with paraparesis, and we are investigating. But when we corrected his calcium, his neurological function improved. So this kind of rarity you can see. There is a pulmonary alveolar hyperproteinosis, which is again an autoimmune disease, which can be associated. So these are rarity which can we see. But coming to the major part, other unique aspect which we have found. If you see hypopara patients, they mimic like ankylosing spondylitis, many of them. But it's not ankylosing spondylitis because they are HLA-B27 negative and they have a lot of syndesmophytes. If you can see, so and there is equal male-female ratio. So we should not confuse it with we call it parathyroid spondyloarthropathy. Bone mineral density is increased in them, and they can have a T-score of 4 or 5. But despite increased T-score, you will be surprised that they are prone to vertebral fractures, and it is in the 18% of the patients they have vertebral fractures compared to 4% controls in our cohort when studied. Cause of this vertebral fracture, we are not sure what is the cause of this vertebral fracture because there was no factor which we got associated in multiple regression. But when we did trabecular bone score analysis in them, which is a different measure than the BMD, we found that bone microarchitecture was not grossly impaired in them. It went parallel with the BMD. So that also doesn't explain. Maybe it is a very compactness of the mineral which make it fragile and brittle. If you keep on loading something into a bag, then again that bag will rupture. Maybe it has something to do with that, but nobody knows what is the cause of increased vertebral fracture in them. It's just like fluorosis might be. If you see the treatment of this, there are 3 types of treatment which you can give. They can respond to high doses of simple cholecalciferol. Alpha-calcidol is most logical because that's what is missing because of lack of PTH action. And 125-dihydroxy-D, if it is if you don't have alpha calcidol easily available, then you can give 125 dihydroxy D. Calcium carbonate is best, but if you have gastritis, then you can give calcium citrate because it also has 21% elemental. Otherwise, we start with the calcium carbonate and we give it in multiple doses because at a given time, 500 milligram percent is the usual which is absorbed from the food. You can go up to maximum 1 gram BD, but not 2 gram at a time. So you give in divided doses. Initially, this is a very important point for resident. I want to say this, that if patient comes to you with severe hypocalcemia, especially in the form of post-surgical hypopara where there is hungry bone syndrome, and if you give oral therapy, they will not respond. You will have to continue giving IV because enterocyte function and mitosis of the spindle, separation of the cell, and enterocyte proliferation is dependent on the calcium. So if you have no calcium, enterocytes will not be regenerated, or in fact they will be denudated, and person will not be able to absorb oral calcium. So you have to maintain IV calcium, that too not only for 1 or 2 days, but at least for 10 days when they start responding to the same oral calcium, and then you can wean off from the IV calcium. And we have a PhD student recently, Dr. Soma Shah, who did some interesting work. I will just take you through that. We were thinking that maybe alpha calcidol is not uniformly effective because the Western data has started coming where they show that PTH is very good for hypopara. And though there is not much basis in that, but then a lot of papers came which showed that teriparatide and netpara, they can be given for hypopara, and there's a lot of paper came which showed different advantages of netpara, but I'll come to that point. So we were in doubt whether our patient, we are correctly managing them or not, whether we are sticking to alpha calcidol and maybe we need to shift to PTH. But then with this logic, we audited our therapy of our patient. When we assessed our patient, only 30% patient, they had a good calcium control, that is ideal calcium control, 8 milligram percent. But then when we give that all therapy from our side, we purchase the medicine and we gave them each and every dose for 3 months, 100% got control. So it is not the problem with the therapy of alpha calcidol, it is a problem of the compliance, availability, of affordability of this patient. And the best thing we got was that when they got controlled, 41% of them could stop taking oral calcium. They could be just maintained with the alpha calcidol, which makes all the more sense because PTH is missing in them. And PTH should be responsible for making active vitamin D. So they could just, half of the patient could just be managed with alpha calcidol when we properly managed and when they took the drug. Average dose was 1.5 microgram per day of alpha calcidol, and if you have to convert into 125 dihydroxy D, you have to half the dose. If the patient is controlled on 1.5 microgram alpha calcidol, calcitrol dose will be half of this. And this is what actually we were not, this is another point, we were not showing what is the cause of variation in their daily dose requirement of alpha calcidol. Some people are controlled on 0.25, some people are controlled on 0.75, some require 2 microgram also. So we thought maybe it has something to do with the celiac, with the absorption, and celiac disease obviously came to our mind first. But these patients, they have prevalence of celiac disease just like that of normal people. They don't have increased prevalence. Maybe it is the inherent the requirement of the calcium or the level of PTH. When we actually compared alpha calcidol versus calcitrol, both are equally effective, and whatever is available to the patient, you can give it to that, provided the patient understands that the change in ratio of alpha calcidol to calcitrol daily requirement is half. If you give calcitrol, you have to reduce the dose by half. If you continue giving same dose, what you are giving 2 microgram of alpha calcidol should be 1 microgram of calcitrol. Many patients, they come to us that during menstruation they have hypocalcemic symptoms. Doctor, can we increase the dose? And we were also not knowing what to do. When we actually compared their calcium level throughout the menstruation period, and we found that there was no relationship between their symptoms and the so maybe it has something to do with the anxiety and some loss of blood, but it was not correlating with their serum calcium level. So we do not change the daily requirement of the calcium. But in the Western data, still there's confusion is going on, and in normal periods also, many normal persons also during menstruation, some people complain of hypocalcemic symptoms. So this issue is yet not settled, but in hypopara we didn't find any relationship between calcium level and. In the complications, Dr. Soma Shah showed in one of her paper that we all know cataract is very common in hypopara. There is nothing new in that. Everybody knows that 70%, up to 70% can have cataract. But what we didn't know, what happens to them post-surgery, whether they remain as beautifully, they can see as normal as other people, non-hypopara patients can see. When we compare 25 idiopathic hypoparathyroidism with 25 controls who had post-cataract surgery, for more than 2 years, we found that 75% of the hypopara patient, they required ND-YAG therapy for posterior capsular calcification. Against only 40% in the normal. Lens dislocation was common in hypopara, and so post-surgical also we have to take care of the patient control and tell the operative surgeon when we send the patient for cataract surgery that please do a thorough washing of the capsule left, otherwise they can have more. Nowadays procedures are there by which you can reduce the posterior capsular opacification. Patient with hypopara, they can have renal calculi, nephrocalcinosis, and in familial hypercalciuria can have renal stone. That is a well known fact. But in hypopara, we found that nephrocalcinosis is more specific than the renal calculi because prevalence of renal calculi in hypopara was same that as the general population. But nephrocalcinosis was seen 9% and it was progressive associated with the renal dysfunction. We also had a suspicion in our mind that whether we had 2 deaths due to coronary artery disease, and we got panicked whether we are missing coronary artery disease in them, and they were young patients because we have a cohort. Now these patients, they are in close contact. So at a gap of 1 month interval, we had two young people of 40 years of age. We lost them because of MI. So we investigated our group, whole cohort, for presence of coronary artery disease, whether we are missing and whether we should take timely action or not. But as you can see, it was there, coronary artery calcification was there in 21.5% when we did CT heart, but it was not in advanced form. Only 3.2% had clinical CAD when we screened our 194 idiopathic hyperparathyroidism patients and 48 controls from cardiology department who came for query coronary artery disease. So you can see that they have coronary disease, but prevalence is not too high in them. So maybe it was an incidental association with the MI which we saw in those 2 patients. With regard to management, but you have only 2 types of therapy, calcium therapy and vitamin D. So this is how you can adjust the therapy. If you have a hypercalciuria and low calcium, you can add chlorthalidone. But if serum calcium is high and serum phosphorus is also high, then decrease oral calcium. But if you have a serum phosphorus which is low, it indicates excess vitamin D action in hypopara because FGF23 takes over and that's how phosphorus goes down. So then you should decrease the vitamin D. So this is the principle we follow, that if we have a patient with high calcium and high serum phosphorus, it could be manifestation of disease, and then we decrease oral calcium to decrease hypercalciuria. But if phosphorus goes down, it is an action of vitamin D which is increasing FGF23. This is a clinical phenomena which for resident is good. Once hypopara patient has epilepsy, earlier we used to continue giving the anti-epileptic for several years and we were afraid of stopping their anti-epileptic. But this study showed that it can be easily withdrawn and without any recurrence of seizure if provided we maintain their serum calcium normal. There is a lot of data on PTS therapy, but up till now I will tell you honestly that there is no good paper which has shown any beneficial effect of PTH on renal calculi, any beneficial effect of PTH on vertebral fractures, or any beneficial effect of PTH therapy on basal ganglia calcification. But we know that the dose of oral calcium or vitamin D can be reduced by 1/3. But that we have already shown that when we carefully manage our patient by giving them each and every dose with our, and compliance is good, 40% of them can stop oral calcium in our cohort also. So what people are showing that these patients, their quality of life might improve if we give them PTH, but then quality of life will decrease also if they take injection. So I am not very sure what they are talking about when they say quality of life improves. We also have, I will come to that, we also have measured quality of life. It is a physical quality of life which is impaired in these patients, but if their calcium is maintained, their mental quality of life is all right. So I will come to that. This is the new data which has shown basal ganglia calcification and its mechanism. This is the unique data from our country. I will come to this, but I want to say the reason where basal ganglia calcification is seen is known to everybody. But what we noticed was that cortical region was never involved. If you see, it is the basal ganglia region and the dentate nucleus which are predominantly involved, but not the cortex. What makes the cortex free of calcification, we were not knowing. But in this clinical paper where we looked for calcification prevalence, we found that it is a phosphorus level, which was also associated with the basal ganglia calcification. So it is important to manage the high phosphorus level in hypopara also. Recently we have, because this was a question in our mind, why calcification in the basal ganglia region, not cortical region, and what is the role of phosphorus. So tissue is not available to us. Basal ganglia tissue is not available to us from this patient, and so we depended on the autopsy tissue. We took that tissue from the autopsy cases and we looked for the expression of the various osteogenic molecules in this cortex region and the basal ganglia region. We found that, this is a summary of the data we found. In normal patient, there is no basal ganglia calcification. Despite osteonectin present in the basal ganglia region, despite PTH being low in the basal ganglia region. This is based on the autopsy data we found. This was because there is high expression of carbonic anhydrase 2 in the basal ganglia, and that we also know from the osteopetrosis. When there is mutation, there is basal ganglia calcification. So this is what exactly we found in normal people. This I am not talking about autopsy. That normal people also there is high expression of carbonic anhydrase, and in the presence of normal PTH, carbonic anhydrase is dependent on PTH. So you have a normal PTH which keeps on removing calcium from the basal ganglia region. As a result, in normal people, you do not have any basal ganglia calcification despite osteogenic molecules being there, because there is a protective response in form of Ca2. But what happens when you have a hypopara? Phosphorus goes up, PTH is low, so calcium and carbonic anhydrase is reduced. So as a result, those two factors, orange factors, they are pro-calcigenic. So we have a loss of the defense response in form of low CH, and they are more prone to. So this model explains our basal ganglia calcification. Subsequently, one of my PhD students, Dr. Parmita Kar, she has made an animal model and proved all these points in animal model also. She cultured the rat she cultured the rat striatal cells for 21 days and added different amount of calcium and phosphorus and calcitriol in different combination. I will not go into that. And this is a type of nodule we see in red is the aligerine strain, which we see in the rat striatal culture in the hypopara milieu, because the media in which we culture rat striatal cells didn't contain PTH. So we increased the PTH level and used calcium-free media, which was a hypopara milieu. So as a result of Dr. Parmita Kar thesis, we can answer that, can phosphate enhance calcification? Yes, this we had shown in clinical also and experimentally also. What is the biochemical nature of calcification? It is calcium hydroxyapatite, just like the bony calcification you have. Which cells are expressed, which leads to such calcification? We have shown that there are stem cells which increase the conversion of stem cells into pro-osteogenic cells. And that's why the calcification happens in the basal ganglia region. Role of osteogenic molecules and calcitriol levels. Calcitriol can increase marginally, but not in all set of rats. So that also explains the variability in the, why we have variable progression of calcification. PTH decreases the calcification in the animal model. These calcification are also associated with lot of neuropsychological dysfunction, but they are not related to the volume of calcification. So there is a mismatch between the neuropsychological, and this we also know that hardly you see any neurological dysfunction. I will take only one or 2 minutes. We hardly see any neurological dysfunction in these patients. And why with this such extensive calcification there is neurological manifestation? This we found in this study. This is the Dotatex, this is a PET scan, FDG uptake and product scan, which measures the dopamine transporters. You can see the upper one, FDG PET. The blood supply, despite extensive basal ganglia calcification, was normal in the basal ganglia region. And similarly, the dopamine transporters, the scan showed normal levels compared to the patient without any calcification. Patient with and without calcification, there was no difference in the dopamine transporter. So probably it is a cosmetic calcification, and when it really becomes very severe, then only they start having neurological dysfunction. So just to summarize, we have given some idea about the pathogenesis our institute has given an idea about the pathogenesis of idiopathic hypoparathyroidism. 25% of them have some known etiology in the form of autoantibodies or mutation of the calcium receptor gene. And GCM is a specific mutation which we have found in our group. Associated autoimmunity is not great in them. There is no spread of autoimmunity unlike type 1 diabetes. Remission is rare. Spondyloarthropathy, we should not confuse with the ankylosing spondylitis, which they might have in 14% of the patient. High BMD, but no protection, and you have no buttock fracture in them. Post-cataract surgery complication should be kept in mind. Cognitive dysfunction 1/3, but doesn't correlate with the volume of calcification. BCG progression relates to both low calcium, high phosphorus. So we should take care of both. Now we know what is the mechanism of basal, some little bit about the mechanism of basal ganglia calcification. We need more 1 or 2 PhD to further sort out what remaining question. There is no resistance to alpha-calcidol. All patients respond provided they take therapy. Possible to withdraw anti-epileptic if they maintain their serum calcium. 40% can be managed with just alpha-calcidol without use of an oral calcium. These are some practical points which we follow in our clinical practice, and these are some new data which are given. Dr. N. Kochupule, who was our HOD when I joined DM in 1992, and Dr. Tevetia, I joined DM 2 times, and then first time in the Meerut and then Alna Institute. He is the HOD of Meerut Medical College, where DM endocrinology was being done, and he is Dr. Kochupule. I am thankful to both of them for inculcating scientific spirit. Thank you.
Thank you, sir. Thank you so much for that wonderful overview of hypoparathyroidism. The session is now open for questions, if any. Arijit, please. Okay, the mic is behind you. The mic is behind you.
Thank you, sir, for your excellent presentation. My question is there any difference of PTH level between post-surgical hypopara and idiopathic hypopara? Because in post-surgical hypopara, we expect the PTH level, all the parathyroid glands has been removed, so PTH level will be much more lower than the idiopathic hypopara. And if that's so, is there any difference of the management regarding the dose of calcium and vitamin D3 between these two?
With regard to idiopathic hypoparathyroidism, there is a huge spectrum. You can see PTH level from 3 picogram, and then you can also have partial idiopathic hypoparathyroidism, where you can have absolutely normal but still low calcium, which will be considered as a low calcium. In presence of low calcium, we should have high PTH. In post-surgical hypoparathyroidism, again there is a spectrum. What is the amount where 3.5 gland has been removed or all 4 has been removed? But as a general, once I was comparing data of how beautifully these patients are managed between pseudo-hypoparathyroidism. I have mentioned that in the very first slide that it's most easy to treat pseudo-hypoparathyroidism because they have some PTH left always. PTH resistance is there, but then it is not 100% in all. So it's the easiest to treat pseudo-hypoparathyroidism, followed by idiopathic hypoparathyroidism, and most difficult to treat is post-surgical. In fact, post-surgical, recently we have got 2 patients from Batra Hospital where despite giving oral calcium therapy post-surgery, they were unable to control. So we gave for 20 days IV calcium and then weaned them off from the IV and then put them on, then only, this is because the enterocyte function, as I told you, that it takes time to recover. So easiest to treat is pseudo and difficult to treat, most difficult to treat is, this is published data in the West, from the West.
Thank you, sir. If there are no further questions, for want of time.
I also want to thank the organizers, because usually I should have said that in the very first go, but I am thankful to all the organizers, Dr. Shubhankar and Dr. Goswami, and I may not be knowing name of everybody, but all the organizer team, I am thankful they have called me here, and thanks a lot.
Thank you, sir. Thank you. Thank you for coming. There has been a slight change in schedule, and we will move with Dr. Mohan Shenoy with his talk on empty cella. Immediately after that, we will have Tushar sir talk about aldosteronism. Dr. Mohan Shenoy comes from Kerala, Trivandrum, and we all know him as a very active member of Endocrine Society of India, rather the social media butterfly of Endocrine Society, and he will be talking about empty cella. Sir.
Thank you, dear organizers, for having me here. So it's my pleasure to have a role again in that Crescendo 2023. So I will have an update on how we approach through algorithmic approach. So I will touch into the newer aspects also onto this. So as you can see here, so my role is to simplify all those things into a single algorithm. So what does algorithm mean? Algorithm is a set of instructions for solving a problem by giving a task. So that is a computer generated task actually. So research is also one of the major things which we do these days. So for this I should be grateful to the wonder man of endocrinology, Dr. Om Lakhani. So he is the person who has helped me to prepare the notes, get the data, and also research ideas. So this is his website, endoai.co.in, and Notes Endocrinology is a dedicated app free of cost on Apple and on Windows. So all these things are useful for our endocrinology group. So moving on to this case, which has been seen recently, a 30-year-old unmarried lady comes with fatigue, menstrual irregularity, chronic headache. There is no history of galactorrhea. So always we look for some things of a clue. And when evaluated, she is found to be euthyroid, normal electrolytes, eucortisolemic, normal prolactin levels, no visual field issues. So we just checked everything in detail. And also because PCOS is one thing which we see. So 6 months of amenorrhea and fatigue, and these are all things happening parallelly. So headache is the one thing which she experiences almost daily. And neurologist has evaluated, ophthalmologist, nothing has been found, and they have come to us in our OPD. So imaging requested, as we know, is MRI, brain and pituitary, because whenever we do all the investigations, most of them have come normal, eugonadal, all these things, we have to check whether there is some issues in there. Usually we order a specific set of MRI because it's called dynamic MRI sequence with a cellular focused. We tell a brain, but if we tell only brain, the radiologist may not note the correct area which we want to focus upon. So dynamic contrast images and through proper pituitary focused areas we do ask. So this is what this lady had. This is a picture of radiological appearance. So this is the empty cellular syndrome. So it's a misnomer actually. It's also known as arachnoidocele. So it's a herniation-like feature. So it's a radiological finding of a flattened pituitary in a cellular space filled with CSF. So you can see that the pituitary is flattened and there is elongated stalk. Sometimes there may be stalk thickening in hypophysitis, but usually it is empty cellular, means that area is coming blank. So historically we can see it's firstly used by Bush in 1951, so almost 70 years by Indian independence, that time itself there was described, but it was usually an anatomical appearance and post-mortem they had been, because cellular turcica is one area which usually that is always checked when they are in the last part. So they found that incomplete diaphragm cellae, that is the roof area, and only a peripheral rim is there. And there is a small thin layer at the base that completes the finding in that original description by Bush et al. So when we order MRI pituitary in our patients, we usually ask for this in our picture. So this is how the usually appearance comes. The sagittal image T1, coronal T1, coronal T2, then post-contrast. This is very useful for the PG trainees. And post-contrast images usually seal the thing because sometimes, but in plain images only we can see there is empty or not. So cellular occupies a very important area in the pituitary architecture. So once we identify cellular turcica, then the epicenter of lesion, whether above or below, is found out, supracellular, infracellular, cellular region, so many things we send. We also send whether it is analyze the lesion, signal intensity, cystic or not, solid or not. So we find so many differential diagnoses also. So just want to teach a bit on this. So you can see this is the appearance of normal pituitary here, this picture. So this you can see here in that diagram how it looks like. So the yellow area is what chiasmatic groove, then there is a tuberculum cellae, then pituitary fossa and dorsum cellae. So in that saddle-like area we can find that pituitary is located. So the normal dimension is mentioned in textbook descriptions. It's very small structure in nature. So if you don't see in detail in MRI, we often ignore that area. So look at the size, pea-sized area in that. And this is how the empty cellular looks like, dynamic images and all you can see here. So there is nothing over that area. This is the first appearance. Physiologically we know it secretes so many hormones. It's so very ill described, so many things we know, but so many things are there in the pituitary, the receptors of thyroid, they stimulate. There are also prolactin-like structures, so many structures are there. So we can see posterior pituitary secretes ADH and oxytocin. And how to recognize empty cellular syndrome? Is usually by incidental discovery during the MRI or CT imaging for headache, endocrine or visual disturbances or neurological problems. Less commonly when people do additional imaging for abnormal cellular. So then they keep on checking, sometimes they identify. For study purposes more often they find. And some people referred from an ENT and all chronic intracranial hypertension because cellular remodeling happens, enlargement happens, then finally thinning of floor happens. And sometimes they present with CSF anorrhea also, because that is the emergency which usually we have to address. So at this stage, when I just asked my endocrine colleague, my radiology, how do you approach? So for him, the algorithm is different. So he tells that this is how they approach in their imagings when they see so many images. They check for the clinoid area whether it's eroded or not. If that is eroded, then more often they look for the tuberculum meningioma or craniopharyngioma. Otherwise, when cellular is enlarged, they sometimes think whether it is a pituitary adenoma which has got apoplexy or the empty cellular syndrome. So as I told you, it is a misnomer. It's a herniation of subarachnoidal space into the sella turcica or arachnodocele. It is primary or secondary to some consequent processes causing injury and shrinkage of pituitary. It's also classified as partial or central or complete when it is actually 50% or more than that. So this is the classical description in the radiographs. When we ask neuroanatomy people, they have different way of looking at things. So they always tell, we see the pituitary through the nose and we find the structure over there. When it is some problem, we are also using. So that is why they have to have a surgical neuroanatomy and a team approach whenever we find such an approach in our patients. So coming to pathophysiology, how does this occur? It usually by infarction, pituitary apoplexy or rupture of the intracellular cyst. And you have also got incompetent cellular, because sometimes in people who are post-pregnancy and some other condition, they have incompetent diaphragma cellae. And some people have got transient or constant elevation in the intracranial pressure, biliary intracranial hypertension. That also is a cause. Then anti-pituitary antibodies. These can cause shrinkage of pituitary gland. This can also contribute to empty cellular syndrome. So this picture is taken from Endocrine Society of Europe, which has beautifully summarized all the risk factors, and this shows you all the ways in which empty cellular syndrome is being described. So pituitary factors include those pregnancy, lactation, menopause, all those times when physiologically volume can be changed, hypophysitis where you can have stock issues, compensatory deficit to some other deficits. So these all things should be kept in mind before you find out this condition. Again, algorithm, Dr. Om has helped me in finding out. So the most common epidemiological risk factors for this are middle age, female sex, that is 5:1 ratio is there, that is primary empty cellular, multiple pregnancy, obesity, also we have seen arterial hypertension is one of the things. The largest study which has showed that multiple pregnancies contribute 58.3% of patients, those patients with women with primary empty cellular syndrome. This study was done 175 patients. Then obesity contributes to 50% in that case series. So this is what the summary of that set of things. Pregnancy may trigger the onset because of their own physiological changes, hormonal bundle. Then secondary empty cellular also occurs, that is spontaneous necrosis of pituitary adenomas. Then post-surgery, because some people we are seeing post-surgery also, this can be described. Post-radiation therapy also the tumor can have an issues. This is what the picture shows you, a post-surgery issue, secondary empty cellular syndrome. And then you have a regression of inflammatory lesions. Some people which had a previously lymphocytic hypophysitis or granulomatous, those can regress and later produce this picture. And some other causes are autoimmune or infective causes. This is one pineal gland tumor which has been seen, which has shown to have a secondary pituitary. You can see a pituitary area is empty, but pineal area in that area is showing, arrow showing, that is a pineal gland area. So how do they present to us? As I have told you, it is most often because of headache, endocrine dysfunction, visual disturbances. 80% of cause is most often headache. And 20% people have intracranial hypertension, visual disturbance, and even papilledema. So again, we will go to algorithm. Before that, we have to see endocrine dysfunction, what common it is. 10% or around that period have got a mild hyperprolactinemia. In our patient, it may be mild, but it is physiologically normal. And often due to increased stock pressure, those things can be seen. And as I have told you, stock integrity, rarely pituitary microadenomas can cause other issues, can be causing this primary empty cellular syndrome. So coming to the last part, it is the algorithm-based approach. I will show you 4 algorithms, how we have summarized the entire talk. So the first thing is symptoms of empty cellular syndrome are mainly to the tumor itself if it is there, or not due to this pituitary apoplexy or these things. Most commonly, visual anomaly is what we find. Arachnoidal adhesions, traction can be leading to headache. Endocrine symptoms are more commonly seen in secondary empty cellular syndrome than the primary empty cellular syndrome, and CSF rhinorrhea can occur due to shrinkage of the tumor, because that is one thing which we have to always watch out for. And second algorithm is whenever we have doubt, we have to screen them. So in ophthalmologist, they usually show the screening with the visual acuity, the blurred vision, diplopia, oculomotor nerve, papilledema. They are also checked for ultrasound features. They have got ultrasound A and B. They check for intracranial hypertension in that also. Endocrine aspects, we are seeing the glands here, menstrual irregularities, galactorrhea, gynecomastia, so many features are there, some syncope, sexual disturbance, infertility. Ask for these symptoms whenever possible. If hypopituitarism is confirmed through basal and dynamic test, then we have to go for the further test. And the neurological issues, headache, syncope, cranial nerve disorders, convulsions, they can be one of the presenting features. In ICU, we have seen so many people being incidentally diagnosed when they are admitted for some other cases. So whenever you have doubt, you have to do an imaging. So we ask for the proper imaging when the patient is stable. So we do the pituitary focused MRI as I have shown you. And when we find primary empty cellular syndrome, we are going to appropriately manage that. Secondary empty cellular needs only conservative or focused therapy. So it's often multidisciplinary management and follow-up. So third algorithm, we will see the treatment part. So usually the endocrine part, we focus on hormonal dysfunction. They have to be treated and followed up as per the available guidelines. So hypopituitarism should give supplementation with the cortisol hormones if required. Then if you have got some issues pertaining to the prolactin issues, we have to give a dopamine agonist. Then if you have neurological issues, we have to manage with osmotic diuretics and may need surgical treatment sometimes and follow-up. And we have got obesity patients or eating disorders patients, we have to give them motivation for weight loss, provide them psychological measures, sleep study if required, and give them a dietary. If later on, if required, only go for a bariatric surgery for that. So finally, we have to not forget to follow up. So whenever patients land up with us with primary or secondary empty cellular syndrome, some people do land up in so many issues without following up. So following it up required 6 to 12 monthly if ideally possible. So if any progression of symptoms is there, we have to appropriately treat them and often warn them, because sometimes there may be sudden rapid deterioration of vision. So that has to be screened and managed properly. And those with unlikely at initial level, we have to have a close, later on a gradual follow-up only. And there's a dictum again here, primary empty cellular tends to be a stable radiological degree, but secondary empty cellular tends to have a variable course of action. So last part on the surgical treatment. So surgery is very rarely considered. Only when patients are not responding well, then they will see. But when those are planned, when seen, they have actually got complete resolution also, as in this publication has shown. And only those patients, 85.3% showed complete resolution or responded well to surgery. And actually no patient with postoperative recovery has improved. So that's why we should always screen them preoperatively for visual field deficit also. So CSF rhinorrhea is a very important thing because that has to be tackled with the proper measures, and prompt surgical treatment is required as fistula rarely causes spontaneously, and these are the things we do. We ask them to do a complete or simple shunting, and if fistula is diaphragm cellular, then we should open them and pack them over the fascia. So this is how the surgery usually is seen. Visual symptoms in secondary cellular syndrome, they often go for it. The MRI demonstrate a descent of optic apparatus. Thinking of them, they do a chiasma pexy, and this is popping up the chiasma by transpenoidal approach, and then packing the cella with fat, muscle or cartilage. So finally, when you have finished everything, evaluation, we have to finalize, summarize how it is approached. So dear friends, empty cellular syndrome is usually a benign condition. Majority cases only need conservative management, except with those with profound symptoms like headache or visual disorientation. It is necessary to manage hypertension and suggest weight loss in obese patients. Hyperprolactinemia is one condition which interferes with organal dysfunction, should be managed very aggressively if required. Indications for surgery are very clear: visual disturbance and CSF rhinorrhea. And type of surgery depends on how they present on radiologically and radiological findings. So this is how finally we end up. The algorithm has told us that primary enterocellular is heterogeneous and often has got varied presentations. We have these risk factors like female sex, multiple pregnancy, obesity, arterial hypertension. These are all to be identified, as well as the benign intracranial hypertension. So I am part of the endocrine advocacy group. We actually have so many Facebook interactions, patient leaflets. So we are proud to have a lot of collaboration in this regard. So this is how we configure the problems and analyze it and communicate it to our patients. Because finally, whatever we learned in our books doesn't go to the clinic sometimes. So that is why we create awareness in the community. So the aim of my session today is not to teach you many things, but to teach the essential part of the things, that is primer non-nocere, because we should give them no harm to the patient by over-investigations. We have to give them proper evaluation, and algorithms like as I showed you will definitely help you in this regard. So I thank you for the kind listening. You are able to reach out to me, I will be happy.
Thank you, sir. And since Mohan sir has to catch a flight, I think...
Yeah, I was actually in a rush because of that. So there is some on the road. So I think if you have any questions, please.
One or two questions maybe.
Yeah, I just want to take it here only, yeah. Thank you, Crescendo team, once again for having me here.
If there are no questions, we will thank Mohan sir for his wonderful talk on empty cella once again. And we move on to our next talk by none other than Professor Tushar Bandgar sir from KEM Mumbai. Sir currently heads the Department of Endocrinology at KEM Mumbai, and sir will take us through primary aldosteronism.
Yeah, thank you very much. Yeah. Thank you, the organizers of Crescendo, for this opportunity. I am going to speak on primary aldosteronism. Where do we stand in 2023? And what I am going to essentially do is to give you updates about what are the pathophysiological aspects which we have understood now, the increase in prevalence, some new concepts of biochemistry, how do you subtype, because that's how you're going to decide the management, and some learning perks in management, as well as some updates in that, which I would try to showcase in this 20 minutes talk. The first part, pathophysiological aspects, I think it's one of the quite newer developments which we should know. For that, I would just showcase one patient which we have managed at KEM Hospital. She was a 33-year-old female doctor who had mild hypokalemia and no end organ damage. On biochemistry, you can see that the renin is suppressed. Aldo is 15. It's not that high, if you're looking at a young female with hypokalemia. So 15 is definitely high, but it's not that high. On saline loading, it is 7.72 of Aldo, and you do imaging shows a left-sided adenoma which is around 1 centimeter, but there is a small nodule of 0.3 millimeter on the right side also. So it doesn't really meet the classical guidelines of foregoing the AVS, and hence we did an AVS, and AVS showed that it is lateralizing towards the left, but it's not meeting the cutoff point of 4. So then we decided to really go ahead with medical management, and with this, patient is doing quite well. We did a genetics, it doesn't have any germline variants which are positive. So this case highlights the exciting new pathophysiological developments which we are supposed to know. So what we have been taught all these years about primary aldosteronism as a binary disease, where you have a unilateral adenoma with a young age, hypokalemia, severe presentation at one hand, and the other hand you have a bilateral one in the older age with milder kind of presentation, and it's not anymore a two kind of disease, it's more of a syndrome which we need to know, and it keeps on accruing over a period of life of an individual, where you develop these micronodules, aldosterone producing micronodules, and in one adrenal, and you can have bilateral adrenal nodules which are developing over a period of time. In few of them, they coalesce and they form a aldosterone producing adenoma or a Conn's typical lateralized unilateral adenoma, but maybe majority of them get into bilateral causes. So this has been shown very clearly by the CYP11B2 staining which is available to us in post-adrenectomy specimens, and they've shown that in patients who have unilateral adenoma proven by AVS, and you do these IHCs, you get not only adenomas there, but you may get micronodules and nodules which can be there on one side, or you could have bilaterally, you can have similar kind of picture, stating that you, for example, in the left side of the part, you have a clear-cut adenoma which is sitting there, and the right side you have a clear-cut unilateral hyperplasia which is there, and in between you have something where you may have all these nodules which are there, and it may lateralize or it may not lateralize. So always getting a lateralization is quite important there. So that's the pathophysiological update which we should know and treat it as a syndrome rather than only two kind of disorders in between. Epidemiological part, we all been taught since MBBS days that it's only 1% of your hypertensives, but it's all because most of the bigger centers or all the centers have not been able to screen patients, not more than 1 or 2% of actual patients who meet the criteria by Endocrine Society, and that's the reason we are missing so many patients there. And over years, There have been thousands of patients who have been really screened for PA. It's shown that the prevalence of around 6%, and as the severity of hypertension goes up, the prevalence goes to around 19 to 20%. Even so, more so that when a community was screened with oral sodium suppression tests, even 11% of normotensive patients had biochemically overt primary aldosteronism, which was picked up on biochemistry. So we are really looking at the good numbers, and they need to be screened. So what guidelines tell us that we are not doing now, and even more so that we know the numbers are more so, and so the experts, they say that in a life of a hypertensive patient, at least once in a lifetime you should screen any hypertensive patient with PSC and the renin activity, because you're missing them and you may catch them later when they come with complications. So what we did was, we did in our, at KEM OPD, we follow patients with diabetes. We had around 500 patients with diabetes in a routine clinic, where we evaluated for the prevalence of PA. So these patients, only 30% of them meet the classical criteria of screening, and 70% don't meet. And even in them, we got a prevalence of around 8% after confirmation. So that tells you that these patients are real, they are there, biochemical primary hyperaldosteronism is there, and we need to look for it. When we talk of biochemistry, so we've always been talked about screening tests as looking at ARR, that is the aldosterone by renin ratio, and we use various cutoffs depending whether it's plasma renin activity or DRC, whatever you use. But experts tell us that you should not look at the ratios as such, but we need to look at them separately. You should look at the aldosterone level and plasma renin activity separately. If your renin is suppressed, there is no business for aldosterone to be there. And any high aldosterone, more than 5 is there, that means that the primary aldosteronism is really ruled out. And if you look at ARR, it may not give you much answers there. We need to definitely confirm, and we use oral sodium suppression, IV saline suppressions, and there are newer updates in the cutoffs. If you do the assay by LCMS, then the aldosterone levels are on the lower side compared to that of the immunoassays which have been mentioned. The important part here is that there have been so much prerequisites, and the barriers to screen patients have been because of these prerequisites of upright posture, normalizing potassium, and liberalizing the sodium intake. Most important that physicians are really bothered about stopping the drugs, and that's been a major barrier. Here guidelines and newer updates say that you don't have to really stop the drugs. Please go and screen any patient on the drugs which are there, because most of the drugs are going to increase renin, like your MRAs and diuretics. And in that phase, if you get a renin suppression and a positive ARR, it means that definitely PA is there and you don't really need to stop it. But if you don't get that high renin which is suppressed, then you need to stop the drug for say about 4 to 8 weeks, depending upon what drug is there. And in the reverse way, if the patient is on beta blocker or on central sympatholytics, then your renin has to be on the lower side. In that phase, if you get a renin which is high, it means PA is rolled out, and you don't have to really stop it and still evaluate. To make things more simpler, they are just telling you to look at, in high-risk patients, to just look at renin suppression. If you have a renin suppression, there is no need for aldosterone to be high. If your aldosterone is less than 5, then you can say that, okay, PA is unlikely. But if it's more than 15, that means you're really dealing with a PA case. You don't have to confirm, you don't have to do anything. Just go ahead and localize it. Any time you don't want to go ahead with the localization or surgery, go ahead, go on mineralocorticoid receptor antagonist. So they are trying to be more inclusive. They're trying to draw our attention to the fact that a lot of this biochemical hyperaldosteronism needs treatment, and don't look at those numbers below. If it's more than 5, you need to be more proactive. Why they are trying to tell us is because if you look at aldosterone level, it is a very variable kind of assay, as well as the levels which is there. There are a lot of intra-individual variability even in patients with proven biochemical hyperaldosteronism. When you take multiple samples, then you can have levels as low as 5 nanogram per dl. Even when you do an AVS in a supine position, you may get a level less than 5. So more than 5 is a level which is what they have kept to say that you're not missing in hyperaldosteronism. If you get a higher level, it's fine, but if you get a lower level, then we need to be aware of it, that you might not miss it. To make it more strong, so that to increase your confidence for surgery and other management, then you may go for a 24-hour urinary aldosterone levels, which gives you an integrated value of 24 hours urine aldosterone, and it may give you more confidence to go ahead for a radical step of surgery or some other ablative therapy if you really think of biochemical aldosterone is a update on the biochemistry which is there. So we looked at change in pathophysiology, the epidemiology, biochemistry. Let's look at the most important part. How do you, when you have a biochemical confirmation, how do you subtype the patient, whether it's unilateral or bilateral? Classically, we've been doing that with imaging, CT-based imaging and nuclear medicine scans, but AVS is a gold standard. What we use at KEM is a sequential adrenal venous sampling with continuous co-syntropic infusion with intra-procedural serum cortisol confirmation. We use the standard cutoffs of selectivity index of more than 5, lateralization of more than 4, and contralateral suppression of less than 1. So it's been very classical and it's been quite used earlier. If you get lateral presentation, then you can go ahead for surgery. If it's bilateral, it's medical therapy, but it's not enough. There are a lot of updates where there are newer drugs which are there in the pictures for unilateral as well as for bilateral. There are so that needs to be looked at. Other part of the AVS is that there are various centers which are going slightly more ahead with that. They not only cannulate the arterial veins, but they try to cannulate the tributaries so as to get a super selective or a segmental selective AVS, so that you can find out whether the lesion is in the upper half, middle half, or the lower half, and you can go for partial adrenalectomies in unilaterals or bilateral. So more so it's important for bilateral PAs where you require these kind of surgeries. When you talk of invasive subtyping, AVS is known to be invasive. They want to have a non-invasive diagnosis to not only diagnose PA, but also lateralize that. And that's where LCMS steroid profile in AVS samples or in peripheral blood samples is helping clinicians to use it to confirm their diagnosis. So there are various steroid panels like 18-oxocortisol, 11-deoxycorticosterone in peripheral samples which can tell you whether it's unilateral or bilateral. There's a lot of data coming here. It's not yet validated. It's not come into guidelines. I think it will take some years to really get there. So when you talk of subtyping non-invasively, functional scans are really coming up now, and we need to know about them. This is gallium-68 pentoxafor PET-CT, which targets CXCR4. I would just show you our case, how that scan has helped us in our management. So this guy, 51-year-old fellow who has hypertension, hypokalemia, biochemically confirmed, we did an imaging. Imaging shows an 8 millimeter nodule on the right side, and we thought we should go for AVS, but he refused AVS. So we needed a confirmation. We went ahead with this gallium-68 pentoxafor PET-CT, which is picked up by those aldosterone-producing cells. And this got lit up, and we subjected the patient to right adrenalectomy with clinical and biochemical success post that. So this is a very exciting scan which is available in India, where it targets CXCR4, which co-localizes with this aldosterone-producing CYP11 beta 2 staining also, which has been shown with in patients with aldosterone-producing adenomas, while your non-functioning adenomas and normal adrenal tissue doesn't really pick that stain up. So there is a data which is published in 2023 where they have looked at 120 patients with these scans, and they have seen the sensitivity of lateralizing to one side of 92% with sensitivity of 94%. And there was a concordance of both these stainings of CYP11B2 versus CXCR4, suggesting that this non-invasive technique is going to come in future, is going to help us where AVS may not be available or AVS cannot be done, or maybe further more than that. Other one, metomediate scan is also coming a big way. It's a very specific scan. It targets CYP11B2, but also it targets CYP11B1, and that's why you need to pre-treat with dexamethasone for 3 days before going ahead with the scan. So in this study, what was done, they compared AVS versus metomediate, and what they have shown that the difference, the accuracy, and there was not much really significant difference between AVS and metomediate. They could pick up the patients there, but the important point was, out of 100 patients, approximately 60% of the patients could be picked up for unilateral surgery. So there was a subset of patients which were picked up by metomediate scans, which were not picked up by AVS scans. and with a good clinical as well as biochemical results, suggesting that these non-invasive techniques is going to add on to your AVS data or maybe equivalent to what is available with the AVS. But the issue with this is it's got a very short half-life. You need a cyclotron to produce this particular issue, and it's not available everywhere. So we've looked at subtyping. Let's look at the advancement in managements. Traditionally, we know that it's unilateral, you need to go for surgery, bilateral, you need to go for medical therapy. But there are newer advancements in medical therapy, then the ablations with radiofrequency ablations as well as ethanol-based ablations in unilateral and bilateral tumors. And also there is a role of surgical adrenectomy in bilateral primary hyperaldosteronism, which I am trying to showcase. So this is data of almost 5 to 6 studies in each arm, and they have shown that patients, there is improvement of almost 74% of clinical and biochemical success in both of them, which is slightly lower than that of surgical adrenectomy, which is around 90%. But still it has some role where your surgery cannot be done or patient refuses surgery or other indications. The role of bilateral surgeries in the bilateral diagnosis, bilateral primary aldosteronism, is highlighted by this case which we had managed at KM Hospital. So this lady was having hypertension for almost 15 years, and she was on 10 drugs for controlling her hypertension, but her hypokalemia was not really controlled, her BP was not well controlled, biochemically proven. We did an imaging shows that there is bilateral adrenals which are slightly bulky. Did an AVS lateralized it to the right side, and the left one was still a bit suppressed. So we subjected her to right-sided total adrenectomy, post which for 1 or 2 months patient was completely off antihypertensives. Renin had gone up with that, but after 2 months you could see that the BP started going up, patient required a few medications, and renin also started going down, suggesting that this was a partial remission in a case of bilateral primary hyperaldosteronism. So raising and giving us a confidence that this is a non-curative unilateral adrenectomy to attenuate the severity of disease. So with this patient we could reduce the drugs from 10 to 2 with no hypokalemias, and the BP was well controlled. We have not 100% cured, but we have reduced the severity, and that's the concept with which surgeries are done with bilateral primary hyperaldosteronism to help the patient manage their hypertension better. So this was the data published in end of this last year, where 56 patients have been operated for bilateral primary hyperaldosteronism either through a complete unilateral adrenectomy or one-sided adrenectomy and other-sided partial adrenectomy or bilaterally partial adrenectomy based on AVS, segmental AVS and CT scan, where they have shown almost 90% improvement in clinical as well as in biochemical parameters of PA. When you talk of newer medical therapies, we know about MRAs, we know about spironolactone and its androgenic side effects, eplerenone, which is also available in Indian market with no androgenic side effects, but with lesser efficacy compared to that of spironolactone. But a newer agent which is available in Japan now is esaxerenone, which is having more anti-mineralocorticoid activity compared to spironolactone and eplerenone. It is longer acting, 20 hours there, and it's doing quite well. It may come to India also. So finerenone is another one, non-steroidal mineralocorticoid receptor antagonist. Its data is more on type 2 diabetes and CKD, where its tissue distribution is equivalent to that in the heart as well as kidney, and hence the side effect of hyperkalemia is on the lesser side. There is not much data on PA as such, but I think there are studies which are been stated to give data on finerenone. Amiloride and trimethoprim has been old. It's used as an adjunct, but there is newer phase 2 data on aldosterone synthase inhibitor, baxdrostat, lorundrostat. These are specific CYP11B2 enzyme inhibitors which have been really used. Important part when you're using this MRA or the mineralocorticoid receptor antagonist, not only you have to normalize the blood pressure and normalize the potassium, but unless you normalize your plasma renin activity, then the cardiometabolic outcomes as well as mortality is not going to be that near to that of essential hypertension, and that's what we need to target. So when we do that, we may have some side effects of mineralocorticoid receptor antagonists, then the other drugs has to be lowered, or you will have to use measures to reduce your hyperkalemia which can come with that. One more management issue with the help of genetics can be solved by using genetic analysis to diagnose a case. This was a young male who was having hypertension, biochemically proven. Imaging did not show any lesions, so AVS we did turned out to be bilateral. But later on, we did on genetics, which turned out to be familial hyperaldosteronism type 4. So if we would have done the genetics earlier, maybe you could have foregone AVS by looking at it. But we should know that it's quite rare. It's not that common. And germline variants in PA has been known. There are almost 5 of them which are there. It's more of the somatic variants which are more common in primary aldosteronism. Almost 90% of the tissues which have been resected post-adrenectomy will have some form of somatic mutations. And they are genotype-phenotype correlations with that. They are trying to look at it. So in Asians, KCNJ5 mutations are really common. They are bigger tumors and they have diagnosed at younger age. They are more common in females. That's one of the genotype-phenotype with that. While your ATP-based tumors are more common in the males as well. They are smaller sized tumors. So they are learning newer kind of correlations with these somatic mutations. So to summarize, we know that it's not a binary disease anymore. It's a syndrome. It's a continuation. It's a lifelong process. Some people get into lateralization. Some people don't get into lateralization. It's very common. We need to screen all hypertensives with PAC-PRA. Renin and aldosterone as a value can be used for your safety. There are updates on AVS where you can have a super selective AVS, but non-invasive techniques like LCMS and nuclear scans are there, which are going to help us to manage our patients. Management-wise, there is role of ablative therapies in unilateral adenomas and role of surgeries in bilateral hyperaldosteronism, and there are new drugs which we are going to see with newer results. With this, I would like to stop and thank you.
Thank you, sir, for that wonderful talk. It's always a pleasure to listen to you. The forum is now open for questions on this topic of primary aldosteronism. Dr. Debmallo Sannal.
Debmallo always have a question.
We also have an emerging data with regards to the atrial fibrillation, which is a new addition by the European guidelines as well, with regards to screening in primary hyperaldosteronism. Probably something which is something we can think we need to be careful. And with regards to the newer aldose synthase inhibitors, any comments as well as with finrenone? Still now I don't think there is much of a role in spite of being more protective. Your comments.
So the earlier aldose synthase inhibitors were CYP11B2 inhibitors as well as CYP11B1 inhibitors. So there was adrenal insufficiency also with that. So they tried to shift over to get more specific CYP11B2 inhibitors. And so it's more of a data for around 3 to 4 months where they've compared with placebo, and they've compared with other drugs with lowering of blood pressure of around 5 to 8 millimeters mercury. But at present they are in all phase 2 studies where they're just trying to find out the efficacy first, and then they're looking at the other side effects of trying to look at accumulation of precursors and the effects and all that. I think over a period of time we should get our answers on that.
Sir, in today's algorithm of primary aldosteronism, sir, are we now done with the saline suppression test and the loading test and captopril test, all those dynamic tests? Is there any role of these tests left in diagnosis of primary aldosteronism?
I think we will still use our screening tests as well as confirmatory tests in our tertiary care institute. But what the experts are trying to do is to simplify the process and try to, while trying to be very good with the protocols and trying to give a diagnostic labels, and because of the complexity of the protocols, not even 2% of PAs are being screened, those who meet the classical criteria or 2016 guidelines of screening. So they just want to try to make it simpler, that you start initiating the dialogue with the patient, you start screening should be simple, you show the patient that there are some changes, biochemical changes which are there, and maybe once you go ahead further, at least if you don't want to go ahead with any surgery or procedure, go on mineralocorticoid receptor antagonist in a smaller dose. where you don't get side effects and give your kind of to treatment to the patient so that the complications are avoided. So as of now, we will definitely use it, but these are kind of views or updates so as to make things simpler, so that all physicians and endocrinologists are sensitized to screen and at least start treatment with medical therapy, if not surgery, because you will definitely require your confidence more to go ahead for an ablative procedure or surgical procedure.
And so why do you think we do not have an update on the Endocrine Society guidelines? We still use, and there is the last 2016 guidelines only. Why do you think the Endocrine Society is not moving ahead 7 years down with another set of guidelines?
I think we should expect them shortly, because last 5-6 years there's such sea of knowledge. I'm sure this year or next year you should get a guideline. It's almost 6 years now. You should get it.
So recently a patient was referred to our department, a 52-year-old lady with history of weakness with documented hypokalemia for the last 7 years, and she was recently has been diagnosed with hypertension, and she has been admitted in our ward, but we didn't find any hypertension by manual BP recordings. So we did a 24-hour ambulatory BP monitoring, and we did find that she had only nocturnal hypertension. More than 90% readings were more than 120/70. Yeah. And she was already, PSC-PRA was already done from outside, and the PSC was 14, PRA was suppressed, 0.78, and after saline suppression, this was, the aldosterone was 11 and renin was 0.38. So
it was 11?
Yeah.
After 11. Saline suppression, it was 11?
Yeah, PRA was, aldosterone was 11 and the renin was 0.3 something. So what should be the next step? Should we, she has a family history of hypertension, but that any of her parents or siblings did not had hypertension below 40 years of age. So there is only hypokalemia, nocturnal hypertension, and biochemically it looks like primary aldosteronism, and on adrenal imaging the adrenaline is normal.
Yeah. I think this is definitely a case. If you have hypokalemia, then all the more reason you should start on mineralocorticoid receptor antagonist, because it's a strong case of PA, biochemically proven with hypokalemia. Definitely your hypokalemia is going to get controlled, blood pressure is going to get controlled. If you want, if the patient is interested in going ahead further for localization, you may go ahead with the imaging and adrenal venous sampling to localize that part.
Otherwise, we should go ahead with spironolactones.
Yeah.
Thank you, sir.
Thank you, sir. If there are no further questions, we'd like to thank Tushar sir once again. A big round of applause for Dr. Tushar Bandgar sir. There has been another change in schedule to accommodate some travel schedules. We have for our next talk Dr. Madhukar Mittal sir from AIIMS Jodhpur, who will be talking about CTP BADX or corticotroph tumor progression after bilateral adrenalectomy. Madhukar Mittal sir.
Well, thank you to the organizers, Crescendo, for having me here. And I've been assigned to talk about what is commonly, or what we commonly refer to as Nelson syndrome. And this new terminology of CTP BADX. The BADX actually is appropriate to the extent of what the condition refers to. So it's corticotroph tumor progression after bilateral adrenalectomy. So I'll start with a case, 16 years male, presented to us with 1 year duration of weight gain, behavioral and mood alterations, easy fatigability, hypertrichosis, no proximal muscle weakness as such, no striae, hyperpigmentation there initially, no headache, vomiting, seizures, or visual field deficits, no history of any exogenous steroid intake. His weight was at the 75th percentile with height less than 5th centile, with his mid-parental height being at the 50th centile. Blood pressure significantly elevated, moon facies, facial plethora, buffalo hump there. Systemic examination was normal. So if you look at the values, this would sort of fit into the classical Cushing's, the low dose dexamethasone suppression, non-suppressed, ACTH dependent, plasma ACTH 112 picograms per ml. MRI brain was normal, so it's a fit case. You go ahead and do an inferior petrosal sinus sampling, where the lesion was lateralized to the left side centrally. The CT, thorax and the abdomen were normal. So this is an initial starting case which we had. Around 2003 the symptoms had started. April 2004 the patient underwent a transfonoidal surgery and the histopathology came as a pituitary adenoma. However, when the child followed up with us, there was no clinical or biochemical remission 1 year later. So in November, bilateral adenectomy was done with hydrocortisone replacement. Again, 2006 March, hyperpigmentation was there and an MRI was done, which did not show any evidence of pituitary adenoma or enlargement. And by April 2007, there was evidence of gross pituitary enlargement, adrenal, the tumor in the pituitary region with clinical symptoms. So this is the child and you can see the gross hyperpigmentation as compared to his father. Interestingly, in 2006, when hyperpigmentation was there and as compared to the MRI next year, you can see the significant expansion laterally of the tumor involving the cavernous sinuses. And during that follow-up, when we had advised him to undergo surgery and radiotherapy, by the time he came in September 2007, he presented with severe headache and bilateral complete external ophthalmoplegia. So that's how rapid the progression of symptoms was, and this was my, I think my first touch with Nelson's during my career of endocrinology. So talking about Nelson's, I'll take up how we define it. The definitions have changed over the years, its incidence, predictive factors, the diagnosis, how can we treat or even try and prevent it. So actually it's not a true disease per se, because if a surgeon doesn't intervene and doesn't do a bilateral adenectomy, you would not have a Nelson's. So for Cushing's, the treatment of choice we all know is a transfonoidal surgery, selective pituitary adenoma removal. And then for a persistent or recurrent disease, the treatment options in order of priority would be a repeat transfonoidal surgery, offering radiotherapy or bridge therapy in the form of medical therapy. And bilateral adenectomy is usually a last resort in Cushing's disease treatment when you don't have any other options available. But then why it is done? It's highly effective, particularly useful in life-threatening manifestations of hypercortisolism. So there are situations when this can actually save lives of individuals. There are cons to it. It leads to permanent adrenal insufficiency requiring lifelong steroid replacement, and there is always a risk of life-threatening adrenal crisis in these individuals if sort of they become non-compliant with their medications or during times of stress, if they sort of don't increase their stress dosings. So the initial definition started with the typical triad, that's why it's a syndrome: hyperpigmentation, elevated ACTH, and progressive pituitary adenoma after a bilateral adenectomy for Cushing's disease. And 60 years hence, since the initial report, it's still not so well defined. There are still caveats to a lot of things. The primary clinical problem, however, remains an expanding pituitary tumor, while the others, hyperpigmentation and the elevated ACTH, are sort of secondary. So this is the initial case reported by Don H. Nelson in 1958, where he reported this patient 3 years after bilateral adenectomy for Cushing's, and then was found to have a chromophobe tumor in the pituitary gland, which secreting large amounts of ACTH. But even before Don H. Nelson in 1957 from London, a case of deep pigmentation after bilateral adenectomy was recognized and reported by Alan W. Spence. So this condition was initially termed as the post-adrenalectomy syndrome. And then 1 year later, Robert M. Salazar reported the first series of 5 patients with progressive corticotroph tumors after bilateral adenectomy. And although Nelson syndrome is commonly used, it is actually the Nelson-Salazar syndrome which was initially coined. Then in 2007, corticotroph tumor progression was proposed by Assay et al. And now it's the CTP BADX. So the initial diagnostic criteria started with skin hyperpigmentation. In fact, there are studies where only skin hyperpigmentation was taken to sort of label it as Nelson's post-adrenalectomy. Biochemically increased ACTH, varying cutoffs with or without a pituitary tumor, in fact, initially. So if you look at the clinical definitions of hyperpigmentation, we know there could be varying causes. Added on, you could have visual field defects. But there are a considerable number of patients who have tumor progression even without hyperpigmentation. And if you look at hyperpigmentation alone, is seen in around 40 to 50% of patients. Visual field defects can range to up to 60%. They can be cranial nerve palsies, pituitary apoplexy, diabetes insipidus, or even uncommonly panhypopit and paraovarian and paratesticular tumors because of adrenal rest there. Coming to ACTH cutoff values, there have been no unique cutoff values, and the values have ranged in various studies. So if you look at the older ones, you had 600 picograms, 990, 370. In fact, we have data from PGI Chandigarh in 2020 where a cutoff or an elevation of around 113 picograms per ml has been taken to sort of predict Nelson's. But even if you look at the last one, the 1995 JCM one, you can see a considerable overlap even with the cutoff of 370 picograms per ml. So this has been because of the different analytical methods used, the unit variations, and the timing of the sampling which has been done, so blood sampling protocols. So what is important when we take into consideration ACTH is the serial measurements. Higher values are definitely associated with a greater tumor burden, but they are not a sine qua non for that. And in fact, important and interesting to note is that even the Nelson's adenoma or the hyperplasia tumor, high molecular weight ACTH is secreted, which sometimes cannot be detected even by the routine ACTH assay, somewhat what is seen with those silent corticotroph adenomas. Coming to the third component, which has gradually been added on, the expanding pituitary corticotroph tumor. Initially, we didn't have MRIs, CT scans, so skull radiographs were used, and there was an assumption of pituitary tumor progression based on cellular enlargement and distortion or thinning of the dorsum sella associated with clinical signs of tumor infiltration like visual field defects and others. Then we had the CT and subsequently the MRI coming up. And you had either a presence of a pituitary tumor, or there were even reports that microadenoma was considered by certain authors, macroadenomas were considered, even need for clinical intervention despite presence of a pituitary tumor, that was taken as a diagnostic criteria. But 2007 onwards, a significant tumor progression on neuroimaging with serial MRI or a new onset of pituitary tumor which has come up. So that's what is taken up. So Assay et al. I was referring to had put up this initially as the corticotroph tumor being added on to the ACTH values. But the current consensus is for the radiological evidence of a corticotroph tumor progression. So CTP comes from there or a new detection. And then you have secondary non-mandatory criteria of progressive increase in plasma ACTH levels and hyperpigmentation. So that's what we are following nowadays, and these are the European consensus guidelines. So with these varying definitions and criteria, the magnitude or the incidence of this condition is also varying, and if you can see this, initial ones had a mean value of 20% in the pre-tomography era, and after that it ranged from 8 to 53% in adults and 25 to 66% in children in various series. And that's also because besides the varying criteria, you had what was the duration of follow-up. So with different durations of follow-up, you had different incidences of Nelson's being there. So these are some of the initial reports which are there, and I've highlighted one where only hyperpigmentation was taken. So you can see all very varying criteria being used. Even subsequent to 95 and onwards, you can see the varying incidences ranging from 6 to 47% of Nelson's. So let's look at what sort of predicts the risk for developing Nelson's post-bilateral adenylectomy in a patient of Cushing's disease. We know this does not develop in all patients. It may also represent a natural history of the aggressive corticotroph tumor being present there. What we definitely know from data available is that sex, male, female, plasma ACTH concentration before adenylectomy, and pregnancy. These sort of do not assign any risk to Nelson's. So what are the risk factors? High ACTH levels post-bilateral adenylectomy in the first year. No threshold has been defined as such, but a rise in ACTH of more than 100 picograms per ml in the first year, or the Indian data sort of correlates nearby 113 picograms per ml. Presence of pituitary adenoma prior or a residual tumor prior to the bilateral adenylectomy. Younger age at diagnosis, a shorter duration of the Cushing's disease. High urinary cortisol levels, suboptimal glucocorticoid replacement, absence of adrenal remnant, so the surgery has not been complete, and certain markers of tumor aggressiveness. So this was one of the initial basis, one of the studies for the basis of this 35-year age cutoff, where 8 of 48 patients developed Nelson's. It was seen that all these individuals were less than 35 years of age and none above 35. So that's why this 35-year age cutoff has stayed. Expression of markers like E-cadherin, glucocorticoid receptor gene mutations, and markers of tumor aggressiveness like Ki67 index, mitosis, and nuclear PTTG all have been found to be associated with Nelson's. So this role of PTTG we know now in other tumors as well is for tumor invasiveness, recurrence and prognosis. It's a marker for aggressiveness of ACTHomas. It also is a predictive marker for Nelson's. So what about treatment? Once we are able to sort of get a case of Nelson's, it's a difficult condition to treat. Surgery remains the treatment of choice. So neurosurgical intervention, radiotherapy and drugs. So neurosurgery leads to rapid and long-lasting resolution, immediate results, minimal morbidity. Selective adenomectomy is now preferred over total hypophasectomy as compared to the previous year's therapies. This was data by Kelly et al., where median ACTH fall of 84%, 100% reduction in pigmentation, cranial nerve palsy improvement, no mortality, and 9 individuals developed anterior pituitary hormone deficiencies. Similarly, another one from European Neurosurgical Journal, where early neurosurgery offered better outcomes. And these are some of the remission rates from the different studies where surgical intervention was taken in Nelson's. So experts agree on this. Resection is the first line of therapy. Transsphenoidal approach is preferred. Remission rates vary from 17 to 80%. Intracellular tumors, better remission rates are there. And there are slightly more adverse events as compared to primary TSS. Radiation therapy here is less preferable. There's a change here with the use of gamma knife. We can expect better tumor remission rates of up to 90%. So if you look below are the conventional radiotherapy remission results. But as we go up, we find 60% with LINAC, proton-based almost 100%, and gamma knife again ranging from 82 to 100%. So that's an alternative option which is available nowadays. Prophylactic pituitary radiotherapy was started initially but currently not recommended, as data from previous studies has not been able to hold the test of time with regards to any benefits. Medical therapy is there, but no drugs as such have led to significant benefit. There are reports of temozolomide leading to successful outcomes, and it may be used on an individual basis. This is European registry, where over a period of time, surgical, medical, radiotherapy was offered, but only half of the individuals we were able to achieve corticotroph stoppage of progression. So close surveillance is required by imaging. What is recommended is every 3 months for the first 12 months, and then for the first 3 years every annually, and then based on clinical surveillance one can decide on the imaging. So to summarize here, diagnosis of Nelson's and has changed over time. The criteria, we must be aware of the risk factors. The management rests on the hands of surgeons, where gamma knife is sort of adding on to therapy. It's a challenging neuroendocrine condition with significant morbidity and mortality. And what is important with the modern imaging techniques, after bilateral adenectomy in Cushing's disease, one should no longer wait for the occurrence of Nelson's syndrome. Surveillance is the key, with early detection which can help favorable outcomes. Thank you.
Thank you, sir, for this wonderful and in-depth detailing of the topic. So before concluding the session, any question and answer from the audience?
Yes, Dr. Satyaraj, sir.
Yeah, a nice sum up, thank you. I just wanted to know, I came a little late. What's happening to the incidence of Nelson's over the years? Are they dwindling?
Yeah, so actually I showed it my data even in the newer data results which are there. So 2020 we had data from PGI Chandigarh where the incidence was 40%. So that's sort of pretty recent as what we can, this is Indian data. Even from outside we are getting ranges, 47% was there in 2021. So as such, what is happening is probably we are not doing so many bilateral adenectomies because we have better options, therapeutic options being available. But in the numbers where we are doing bilateral adenectomies, the percentage is not changing as such for Nelson's.
Thank you.
Any questions from the audience? Thank you, sir. So next session is by Dr. Alpesh Goel, and the topic is pitfalls in bilateral inferior petrosal sinus sampling.
Good afternoon. At the outset, I'd like to thank Team Crescendo for inviting me to this wonderful academic conference. So the topic for me is diagnostic pitfalls in bilateral inferior petrosal sinus sampling. And as we all know, once we have made a diagnosis of endogenous ACTH-dependent Cushing syndrome, the differential diagnosis into Cushing's disease versus ectopic ACTH syndrome is a clinical challenge that we often face. We do have tests such as MRI, pituitary, and some dynamic endocrine tests, but they have their own pitfalls and they have their own false negative and false positives. So bilateral inferior petrosal sinus sampling comes up as a gold standard in the differential diagnosis, and we know that inferior petrosal sinuses, they drain the pituitary venous affluent into the internal jugular vein via cavernous sinuses, and BIPS involves catheterization and sampling of both IPS and peripheral veins simultaneously before and after CRH stimulation. So first question that comes up is, why do we use inferior petrosal sinuses and not superior petrosal sinus? It's because IPS is larger and it's contribute majorly to the pituitary venous drainage compared to superior petrosal sinus. Also, IJV has been tried as a convenient sort of sampling in centers where IPSS is not possible. However, it falls on sensitivity because in IJV you have dilution by non-pituitary venous drainage, and hence you get lower ACTH levels and lower gradient, so it falls down on terms of sensitivity. Why do we employ CRH stimulation? It's because we know that ACTH secretion can be intermittent and you don't want to sample at the time of nadir, and that's why you want to maximize ACTH secretion from the corticotroph tumor and thereby improve the sensitivity of the procedure. The indications for performing inferior petrosal sinus sampling have been variable. So there are experts who have recommended a more rational approach. So the first 2 points which indicate patients with ACTH dependent Cushing's and those who do not have a clear lesion or do not have any lesion or a lesion of less than 6 mm, or patients who have ACTH dependent Cushing's and discordant biochemical findings. For example, you have HDDST and peripheral CRH stimulation which are discordant, or you have discordance between biochemistry and imaging. Those are the kind of patients where it was recommended. Now, some experts have also given radical recommendation of performing BIPs in all patients with ACTH dependent Cushing's, and now we have an international consensus based recommendation which was published in 2021 in Lancet Diabetes and Endocrinology, which clearly states that all patients with ACTH dependent Cushing's should first undergo a pituitary MRI. If there is a macroadenoma, it can be presumed to be Cushing's disease and you can directly go ahead with transphenol surgery. You do not require any further test. But if you are dealing with a negative imaging or a lesion which is less than 6 to 9 mm, essentially a pituitary microadenoma, possibly all such patients require inferior petrosal sinus sampling unless you have a non-invasive strategy in place which is still to be validated, still in progress, work in progress. So basically you require inferior petrosal sinus sampling in all patients with Cushing's disease, in all patients with ACTH dependent Cushing's, and you do not have a convincing macroadenoma as per this international consensus. In order to understand the diagnostic pitfalls of BIPs, we need to understand the basic steps in interpretation. So it should only be performed in patients with confirmed ACTH dependent Cushing's. It should not be used to confirm the diagnosis of ACTH dependent Cushing's. If you perform it in patients with pseudo Cushing's, you may get a false positive gradient. Patient should have active hypercortisolism on the day of procedure, and this is to ensure that normal corticotrophs are suppressed in basal and stimulated state, and any sample that you obtain from the sinus is essentially coming from the corticotroph tumor. You take an informed consent. You have to use labeled EDTA tubes and serum separator tubes. Pre-chilling is important. Sample processing, transportation. We know that ACTH is a heat labile peptide. If you have issues, pre-analytical issues, you can have false positive or false negative results depending on whether the numerator is affected or denominator is affected to the greater extent. We use a bilateral femoral vein approach, and it's a crisscross approach where right femoral vein is used to cannulate the left IPS and left femoral vein is used to cannulate the right IPS in order to distribute the number of bends. Use a systemic heparinization, and you do simultaneous sampling and obtain a venogram to confirm correct catheter placement. Use baseline samples, and then you use CRH or desmopressin, or also shown to use AVP or lysine AVP. And then you calculate the IPS to peripheral ratio. If it is more than 2 or more than 3, it is suggestive of Cushing's disease. However, if both ratios are less than 2 and less than 3, it doesn't always indicate ectopic. You have to rule out false negatives, and this is something which I will discuss in more details in the later part of my presentation. Intersinus ACTH ratio, it has been proposed, but it falls down in terms of accuracy. Accuracy is only between 68 to 74%, and we know that this could be because the drainage could be asymmetric or the tumor can be midline. So this is an example of a patient with Cushing's disease with pituitary microadenoma to the left side, and you can see that there is a clear gradient which is visible not only in the basal state but also in the stimulated state. Also the peripheral CRH stimulation is showing more than 100% ACTH rise, and the final diagnosis was Cushing's disease. Now this is another IPS where you can see that there is no gradient at all, neither in this basal state nor in the stimulated state, and this could be suggestive of ectopic Cushing's. However, we need to rule out false negatives, so we confirm with the radiologist. The radiologist confirms that catheterization was successful, and you also look at the prolactin gradient, and if you see the prolactin gradient is clearly maintained, you can see there is a prolactin gradient of more than 1.8, and so this IPS is suggestive of ectopic ACTH syndrome, and final diagnosis in this case was ectopic ACTH due to bronchial carcinoid. Now, in order to understand the diagnostic pitfalls of BIPs, we need to understand that the sensitivity of BIPs will be determined by number of false negative IPS result in patients with Cushing disease. And a patient with proven Cushing disease who is having a BIP suggestive of ectopic Cushing's, and specificity will be determined by number of false positive results in patients with EAS. That is, a patient with EAS who is showing a central to peripheral gradient. And the gold standard for defining Cushing's or EAS is often histopathology. So this is a slide which is showing sensitivity and specificity of BIPs through various studies. This is not an exhaustive slide. There are multiple other studies. There are 2 studies from India which are also listed. So 2 important takeaway points. The sensitivity is higher with CRH stimulation. As you can see, without CRH stimulation, sensitivity varies between 68 to 95%, but it increases to around 90 to 100% post CRH, and specificity varies between 67 to 100%. Also, it is interesting to note that initial studies showed very high sensitivity and specificity estimates, but it fell down in the latter studies, and the 2 studies marked in red are what I will discuss in more detail. So this was the original, the landmark study by Oldfield et al., which showed 100% sensitivity and specificity for BIPs in determining the source of ACTH. This study involved 278 patients. However, the final diagnosis was only achieved in 246 patients, and 32 patients were excluded from the analysis. So what happened to those excluded patients? The final diagnosis was not known, and this essentially was tested in this further study by Swearingen et al., where they included patients with final diagnosis after IPS, and they found that there occur false negatives. There were 8 patients who had false negative, and this amounted to a sensitivity of 90%, and there were 2 false positives which amounted to a specificity of 67%. So this is how the sensitivity and specificity estimates, which were initially shown to be higher, they came down when the final diagnosis was traced in patients with occult ACTH source. Coming on to the causes for false negative IPS, there could be various causes, including technical regions such as failed catheterization, anatomical regions such as hypoplastic IPS, anomalous venous drainage into vertebral venous system. If there is a case of cyclical Cushing's disease and you are sampling the patient during the off phase and the surrounding corticotrophs are still suppressed by prevailing hypercortisolemia, you can still get a false negative result. You can get low responsiveness of tumor to CRH, or there is poor potency of CRH, then also you can get a false negative result. And if there is an incorrect ACTH sample processing and it is affecting the numerator more, then you can get a false negative result. So this is an analysis of 501 patients by Dockman et al., where they found that false negative results only in 0.8% patients. And all of these 4 patients had hypoplastic or plexiform IPS, and as you can see in the upper panel, this upper panel shows a bilateral symmetric IPS, while on the lower panel, when you have a contrast angiogram performed on the left side, you can see that right side IPS does not light up and it does not fill up to the IJV, which is showing that the right side IPS is hypoplastic, and so you could have missed the gradient ipsilateral to the side of adenoma, and this led to delay in curative transsphenoidal surgery by up to 31 months. Now, in order to reduce false negatives, we have discussed that you want to check sinogram, and you can also use prolactin as an index of pituitary venous effluent, because prolactin is the most abundant pituitary hormone, and it's unlike TSH and growth hormone, it is not affected by prevailing hypercortisolemia. So this is a diagnostic algorithm which has been suggested by Sharma and Neyman, where they have suggested that if you encounter a negative result, you check the venogram, check the prolactin gradient, and if needed, you check the prolactin adjusted IPSS to peripheral ACTH gradient. So what they suggest is that if you have a gradient of more than 2 or more than 3, this is diagnostic of Cushing's disease, you can proceed for transsphenoidal surgery. However, if gradient is less than 2 and less than 3, this could either be ectopic ACTH syndrome or a false negative Cushing's disease. So in such instances, you should check the venogram and check the gradient. If gradient is more than 1.8, this does indicate successful catheterization, and you are confirmed that the diagnosis is ectopic ACTH syndrome, and you can go ahead with localization. However, if gradient is less than 1.8, possibly you are not in the correct place and you need to account for the dilution, and you can use prolactin adjusted ACTH ratio, which in a small series of 29 patients was shown that if it is less than 0.7, it is likely to be ectopic. Between 0.7 and 1.3 is gray zone, but more than 1.3 could be suggestive of Cushing's disease. This is not infallible. You need to, more validation of prolactin adjusted ACTH ratio is needed in future studies as well. Other clues for false negative gradient include CRH stimulated ACTH response of more than 35%, as was shown in the study by Swearingen et al., where all false negative cases had an ACTH response. So you should also rely on your peripheral CRH stimulation test reports. And a peak IPS ACTH levels of less than 400 picograms per ml, which again shows that you are possibly not in the correct place, which was again shown in an analysis of 500 cases by Wind et al., of which 10 had a false negative result. False positive IPS means you are dealing with a patient with ectopic, but you find a central to peripheral gradient which is suggestive of a pituitary source. Now this could happen if you have an ectopic Cushing's, but you are sampling the patient during non-hypercortisolemic phase, which means that the normal corticotrophs are not suppressed and there is generation of a central to peripheral gradient. So this could occur in cyclical EAS, this could occur if there is cortisol lowering treatment in ectopic Cushing's, in a rare scenario of CRH producing ectopic ACTH syndrome, and if very low peripheral ACTH levels. The last point has been taken care of because we do not use it in patients with ACTH independent Cushing syndrome. So this is a case series of 2 patients where due to cyclical hormonogenesis, as you can see, there is presence of bronchial carcinoid, but there is positive IPSS gradient central to peripheral. And in both these instances, patient underwent unsuccessful transsphenoidal surgery and was later diagnosed to have bronchial carcinoid. So the take-home point is that hypercortisolism should be ensured around the day of procedure. Otherwise, you can get false positive results in patients with ectopic ACTH syndrome. Similarly, a challenging case of ectopic CRH syndrome has been described where a patient had severe ACTH dependent Cushing's, positive plasma ACTH and cortisol response to CRH, cortisol suppression on HDDST. This is something we can expect in patients with CRH secretion, normal MRI SELA. And you find that there is a positive gradient, and this is because CRH production is preventing corticotroph suppression, there is corticotroph hyperplasia, and there is presence of gradient. Again, there has been unsuccessful transsphenoidal surgery, and later the patient was found to have a 2 centimeter retropancreatic mass, which was resected, and patient had clinical and biochemical remission, and this mass had immunohistochemical staining positive for CRH and ACTH. So this means that if you have a rare scenario of ectopic CRH secretion, you can get not only a false positive BIPS, but also false results on dynamic testing, which can suggest a diagnosis of Cushing's disease. So this is my final slide. To summarize, bilateral inferior petrosal sinus sampling has emerged as the gold standard in differential diagnosis of ACTH dependent Cushing syndrome, but the accuracy of this procedure is far from 100%. There are pitfalls to BIPS. False negatives are more common as compared to false positive, and we should be wary of it. We should understand that in a patient with ACTH dependent Cushing syndrome, a positive gradient confirms the diagnosis of Cushing's disease, but if you have a negative gradient, you should rule out false negatives. It is also important that the proper patient selection is made. You select patients with ACTH dependent hypercortisolism, with active hypercortisolism on the day of procedure or around the day of procedure, and you also take care of seemingly minor issues such as pre-chilling of the tubes, pre-labeling of the EDTA tubes, and proper sample processing, transportation, and analysis. Thank you so much for your kind attention.
Thank you, Dr. Alpesh, for that talk on bilateral inferior petrosal sinus sampling. The session is now open for questions. If there are any.
Alpesh, very nice talk. Now, I have 2 queries. Number one, that how much difficult is the procedure, as IPSS is very challenging. Yeah. So, how much is the percentage where the radiologists fail to achieve the correct catheterization?
So, sir, procedure is technically challenging. So, the success rate will actually depend on the expertise and experience of the neuroradiologist.
In your institute?
So, in our institute, the failure rate is less than 10%.
Less than 10?
Yeah.
Oh, that's great.
So, the described failure rate is between 15 to 20% overall. But as I said, it may depend on the experience
concern.
and also depend on the learning curve. Once the radiologist becomes experienced, the number of false negatives or because of catheterization issues, they do come down.
The second part is that we sometimes, it is very difficult to ascertain the diagnosis, say, obese patient with pseudo-Cushing having a, pituitary incidental of less than, say, 9 millimeter of surgery size, 9 millimeter size. And it is very nice that you have said that any patients below 10 millimeter should undergo IPSS, though it is very difficult to do in many setups, but that's a good to understand. Now, question is that how much is the benefit of doing IPSS in a patient pseudo-Cushing? Is there really very sensitive in pseudo-Cushing cases when we face an pituitary micro, say 6 millimeter size?
Sir, I think we should not be proceeding with IPSS if we have any suspicion on the diagnosis of Cushing syndrome itself. So if you have a suspicion that this is pseudo-Cushing state, we should not be proceeding with the diagnostic IPSS, because even this has been shown in NIH studies with normal volunteers and with pseudo-Cushing's patient, it has been shown that you tend to get a central to peripheral gradient because corticotrophs are not completely suppressed. And once the corticotrophs are not suppressed, you will get a normal gradient as in a normal individual.
I have a question. We have been doing IPSS in our institute at SSKM Hospital. There has been one thing which I've observed in the so-called failed cases which we do. We take samples at 0, 5 and 10 minutes. Sometimes it happens that the ACTH level comes high as expected for a central source. Maybe 0 is high, 5 then goes down, and then 10th value is again high. And we don't know what's happening. We have witnessed the procedure ourselves with the intervention radiologist, and they keep saying that, look, the catheter is in place. So what actually went wrong? And we process ACTH samples in our own lab, so the cold chain thing is, I think, taken care of.
So I think it is very difficult to explain, and that is why if you, at any point in time, you get a gradient, then you should not doubt your diagnosis. That is the first thing. That is why it is and or, that if you get a gradient at any point in time, you should be fairly confident of the diagnosis. As I said, once you are investigating a patient with ACTH dependent Cushing's, your pretest probability of finding Cushing's disease is high, and so you question your negative result more as compared to a positive result. And the possible etiology could be catheter misplacement. Intermittent catheter misplacement can occur because we are not doing, we are doing angiogram at the beginning of the procedure or maybe at the end of the procedure and maybe monitoring intermittently. But there could be intermittent misplacement of the catheter.
Thank you. Thank you, Dr. Alpesh. Thank you for that talk. A big round of applause for Dr. Alpesh Goyal. We now quickly move on to the adrenal section of our conference today. And for the first talk on adrenal, we will have Dr. Anurag Leela. Dr. Anurag Leela is from the endocrinology department at KEM Hospital, Mumbai, and he'll take us through how we probably manage a patient of Cushing's disease who has failed sphenoidal surgery. Dr. Leela, please.
Yeah, so I thank the organizers. The topic today given to me is Cushing's disease in a patient with a failed transsphenoidal surgery. So when I joined the department in 2007, my thesis topic was the use of cabergoline in a failed transsphenoidal surgery patients. So I have to recruit the patients, so I started recalling all the patients of Cushing's disease which were managed in our department. So at that juncture we had around 110 patients I could recall, and 20 patients were enrolled in the cabergoline study which I did as my exam thesis. And now we have around 30 patients per year, so we have 450 to 500 patients of Cushing's disease being managed over a period of time. So I'll be trying to share our experience at KEM, what we have been managing and how we have been managing these cases over all these years. So Cushing's disease with a failed TSS, whenever such a patient is referred to us, we have to ascertain the primary diagnosis first. So sometimes, like we discussed, the diagnosis was not Cushing's disease. It may be an ectopic Cushing's which was missed and underwent surgery. It was a pseudo-Cushing which underwent surgery. It was an adrenal Cushing which may undergo surgery. I'll show you some of the cases. So the first thing is to ascertain the primary diagnosis. So whenever a patient comes after a failed surgery, we have to relook at all the previous case records and investigation, see the surgical notes, look at the biochemistry. Was there a significant DEX suppression? Was there a central gradient? Was there a peripheral CRS stimulation there? Is there adenoma? Is there histopathological evidence? Was there a remission or decline in the cortisol load after the surgery? All these will give us a clue. No, we were dealing with a Cushing's disease and it is a failed Cushing's disease surgery. You look at the neurosurgeon's experience, the MRI, the radiology, and everything. You have to relook and question the diagnosis before calling it a failed surgery. Was your diagnosis correct? And we will evaluate it always like a de novo case. So we have burnt our fingers many a time when the IPSS was not available, the CRS stimulation was not available, the techniques were not right. We may have not got a right diagnosis in an unstimulated IPSS, and we have done surgeries, and later on we turned out to be ectopic Cushing's. But with the CRS stimulation, these things are less likely. So today we would not miss a diagnosis of central versus ectopic, but in the past when the things were not very easily available, things were difficult. At our center, I would say failed IPSS is very, very rare, sir, as it was asked. The radiologist usually could cannulate it. It is never that we are not able to cannulate unless the anatomy is at fault. Second question was a missed Cushing's disease. If you have operated a pseudo Cushing, you are not going to get a remission. So this patient who underwent a surgery, if you look back at the results, the LDDS was suppressed at baseline. So this was the UFC, the midnights, the LNSE, ODS, everything will be high. Everything will be like endogenous hypercortisolism. But an LDDS suppression, or in such a case, you have to do a LDDS CRS stimulation to understand whether it is a pseudo Cushing versus an actual Cushing's disease. So such patients undergo surgery, and then that could be a reason for a failed Cushing's disease. It's very surprising that we can miss an adrenal Cushing, and this is a case from PGI where a microadenoma was seen. ACTH was 15.8. It was labeled as a Cushing's disease. Patient underwent surgery, and on follow-up it was noticed that it was an ACC which was mislabeled as a Cushing's disease. So why it happened? The ACTH was 15.8, so you are in a gray zone of 10 to 20. So ACTH is less than 10, 10 to 20, and more than 20. And in our own series of adrenal Cushing syndrome, we have experienced that 7 to 8 patients in our series with Cushing syndrome and ACC or adenoma have a ACTH in the range of 20 to 40. So why this ACTH is in the range of 20 to 40 in cases of adrenal Cushing syndrome, maybe because of ACC or an adenoma, is largely dependent on the assay. So if you are using a Roche platform, you are less likely to make this mistake. But if you are using a diazorin or a Imulite, there is going to be a positive bias. So the same ACTH sample, which is 14, can be as low as 9 in a Roche platform. It can be as high as 32 in a Liaison platform. So if we follow an algorithm, we can go wrong, and this has to be taken into care when we are dealing with Cushing's and labeling them. So then how do we establish persistence and a recurrence of a disease when this was a true diagnosis of a Cushing's disease? So in our own series of 230 patients, the remission rate was around 65%. So this is how we counsel. Out of 10, 7 will go into remission, 3 will remain persistent post-surgery, and few of them will recur. So ultimately 50% of the patients will require a second-line treatment on follow-up. And how do we define persistence and recurrence? As early remission is anything less than 5, day 5 cortisol value. But if the cortisol is more than 5, few patients may go into delayed remission and others may remain persistent. Any cortisol value more than 5, we will do ODS on a follow-up to define recurrence. The most important thing we have learned from our patients on follow-up is the sensitivity of these tests, which would not be seen. We don't see a mild Cushing. You see them following gradually in a post-op surgery period when they recur. And you understand that the late night salivary cortisol is the most sensitive, followed by ODS cortisol, and UFC is the last. Now the problem when you have to choose between late night salivary cortisol and ODST, the LNSC has a very high inter-individual variable. You do it today, it will be normal, tomorrow it will be very high, so you cannot depend on it. So, but ODS is one test which is the most reproducible test, and it is very consistent. If you repeat in the same time period, it will be same value you will be getting. So we depend on the ODS cortisol to define recurrence. Time to recurrence. So usually if you read some articles, they say after 10 years you can discharge the patient from your care. That they are in remission, or you can call them cure after 10 years of follow-up. This was one of our earliest patient in 2006. And then what we see, the recurrence has happened till 2017, you can see the ODS was suppressed. And when she comes in 2019, she has recurred. So this is a patient where it has recurred at 13 years of follow-up. So you cannot discharge a patient from care. So she was a religious patient who had done the cortisol values, was following religiously on an annual basis. And she underwent radiotherapy. At this juncture, the microadenoma was not well visualized when an MRI was repeated, and she underwent radiotherapy for the same. So the treatment options we have we can repeat a transfemoral surgery, a radiotherapy, adult surgery, or a medical therapy. These are the 4 treatment options we have to manage these cases. So this case where on follow-up you see gradually the LDDS cortisol has gone up and the microadenoma is visible. I would like to say that the microadenoma always comes at the same site. So if you look at the previous scan, it's some cells which remain behind and they come back. So this is one disease which teaches, at least I have learned perseverance from this disease. Some cells will remain and they'll regrow and they'll come back one day. And this patient underwent a second surgery. He's pan-hypopet after the surgery, requiring multiple hormones and replacement. So second TSS, the cure rate are dismal, lesser than the first TSS surgery, because again the anatomy is disturbed, the microadenoma will not be well visualized, but this is one of the options in our hand. White tumor comes at the same site as there are some cells which remain behind and they are stuck to the dura. The cells which are near the dura or involving the dura or a larger tumor size is likely to remain behind, and so there is a concept of in toto resection or a pseudocapsular resection in these cases to get good results. Coming to radiotherapy, as I was saying, in 2007, when I was trying to enroll the patients for my cabergoline study, what I felt, the patients who have received radiotherapy in the past are the happiest lot. And they have gradually, first TSS, second TSS, RT, and now she's following and she's good till the last follow-up. Even she has followed this year also and the levels are consistently good. So radiotherapy is a good treatment in case of Cushing and a persistent Cushing's disease. That's what we realized. And then we looked at the world literature. We could see 2 series, one from Spain and Italy. This was our R series. And the response rate is 80%. Time to response is 2 years. Relapse rates were not seen when we did the study. And the pituitary deficit will happen, that is acceptable. In a pediatric series, we are more worried, can we give radiotherapy? The answer is yes. The response rate is good, time to response is lesser, relapse rate was not there, and the pituitary deficits were not there. So in a pediatric age group, if you give RT, somehow those other axes have some stem cells which remain unaffected because of the radiotherapy, and the long term their growth and puberty is not affected as against a lay person would think of. So these are the examples. This is one of the child who have received RT in 2004, And he's grown up post-RT, he's not required any growth hormone, any pubertal support, and he's doing good in growth and puberty. Second question comes post-RT. When we send the patient, the radiotherapy people will counsel them against that you will have failed puberty and other failed reproduction. So this patient who has undergone 2 TSS after RT, now she's mothered 3 kids after remission of Cushing's post-RT. And even if it is, if the FSH-LH axis fails, it can easily be replaced with a WHO grade 1 infertility protocol. So this should not be the deterrent for not giving radiotherapy in these cases. Second tumors, when I ask all my seniors, have you ever seen a second tumor after a radiotherapy patients in any pituitary case? Answer is no. But it is always quoted that it will lead to second tumors. If at all it leads to second tumor, it's a meningioma and the treatment is RT again. So that's again, the fear is very, very expanded. Cerebrovascular accidents, yes, we agree that the radiation in the surrounding vascular areas will make it brittle. The chances of cerebrovascular accident will be higher, but if you don't treat the Cushing, patient has to survive to get that CVA. What is the actual concern is a neurocognitive decline, because the surrounding areas of the temporal lobe and will receive some radiation. So there comes the role of stereotaxis to give minimum radiation to the surrounding areas. Second thing is gamma knife better than the proton beam better? So whatever is new may not be always great. So what we have understood is the response rate is very similar with all the techniques. And what we understand, the gamma knife, because again the area covered would not be the whole cella, the relapse rates are there, and all and none phenomena can lead to optic nerve damage. And for the proton beam, also initially when there is a learning curve, there are cases of temporal lobe necrosis and seizures. So we still go with the conventional conformal, so we call it modern conformal rather than the conventional form of RT. Hypofractionation is again now being tried, but we still stick to 25 fractions because it is time tested. So as I said, there was no relapse after RT. This was the first patient of ours who had relapsed after radiotherapy. So then we tried to look at our data, and then we got 5 to 7 patients who had relapsed in that area. So post-RT relapse was not reported. We got post-RT remission and relapse. And then when we collated all the data, we could attribute it to the use of cabergoline in my study when these patients were put on cabergoline. So cabergoline acted as a radioprotective agent, and we don't use cabergoline nowadays. And I say that just when it comes to a practicing endocrinologist, they have something to offer, that is cabergoline, to a patient of any pituitary tumor. It may do some harm. If it is working, then it should be used forever. But if it is not working, don't use it for the sake of using it. That's the bilateral adrenal surgery, adrenal crisis. Nelson was discussed in detail, but practically whatever you call it, there is no predictor for it. Which tumor will go for Nelson, we don't know. For somehow, it was always promoted in north and south part of India. In western part of India, we were always apprehensive about this procedure. Maybe our tumors were more different from the other parts of the India, and invariably we see Nelson syndrome in our patients whenever we have done it. Maybe we have used it as a last resort. In the worst tumor pathophysiology, we have used it. And over a period of follow-up of 15 years, many of them have not survived. And then again we required a RT, third RT, fourth RT to contain them. We had this case, interesting case of Nelson Cushing's because of an adrenal remnant. So undergo adrenal surgery, there was a growth of the tumor there, and the adrenal remnants were seen. One was at the site of the adrenal gland and one was at an ectopic site. So there is spilled adrenal gland and there were adrenal remnants. So even after bilateral adrenectomy, it is said that 25% of the patients will be eucortisolemic. So please check before replacing them or prednisolone. And some percentage may be hypercortisolemic again. And again, you have to resort to RT for the final answer. Medical management, we have a list of drugs. We were part of the paclitaxel trial also, but there were 2 patients from our center in this drug, but it had a very fluctuating kind of diabetes, and it was very difficult to manage those cases. Results were also not great. Cabergoline, again, very minimal results. Temozolomide, we use it in last case scenario for aggressive tumors where you have nothing to offer, you add it. Other new drugs are there. Ketoconazole have been used well. It works differentially. You don't know who will respond or not, but there's no harm using ketoconazole. The fear of hepatitis and other things are transient and it settles if you monitor it well. Metiropon used in 1 patient only, not easily available. Etomidate, yes, it's a good drug in cases of ectopic Cushing's who comes in a very bad shape. It helps us. And we can use it in a minimal dose and use it even in the ward and monitor it. You don't need an ICU backup always, which may not be available in our settings easily. Mitotane is another drug which we have used. So the drugs we have used commonly were cabergoline, not very good. But mitotane, yes, helps in a smaller doses. Again, the cost and the import thing comes into place. The drugs which are highlighted in red are the ones which are approved drugs for the disease. Cabergoline, the response was mild and was seen in only 5 out of 18 patients, and it was transient, and then again they had a relapse. Ketoconazole works in 50% of the patients worldwide. Even the L-ketoconazole also work in the same efficacy. It's a new molecule and you have trials in that. Oscillodrostat is a good drug, CYP11B1 inhibitor. It reduces 80% of the cases respond in the terms of UFC. But again, you're blocking it, you're creating hypertension, hypokalemia, adrenal crisis, then block replace treatment are being used. But if this drug is available in our country, it would be good because it could be used in many of these cases where we have no answers. And a real life scenario, like we have to use everything, it's not one. Like this patient who have undergone first surgery, second surgery, cabergoline, ketoconazole, radiation, mitotane, I will call it medullary adrenectomy and bilateral adrenectomy. I have to follow her up for Nelson for life. So 6 monthly ACTH and yearly MRI would be done to look for development of Nelson. And Cushing's, we always make mistake. We have done surgeries for ectopic Cushing's, which turned out to be ectopic after the first failed transfemoral surgery, so you cannot say the surgery has failed. We have operated pseudo-Cushing's, which we realized were pseudo-Cushing's. So those mistakes we have made, but with the newer techniques and the biochemical test, we are more, I would say, knowledgeable, and we will try to do those mistakes lesser. And I thank the department for learning over this period of time. I thank for patience listening. Thank you.
Thank you, Dr. Anurag Lila, for that illustrated, comprehensive presentation of Cushing's. The forum is now open for questions and discussion. I think I have a comment regarding what you've said that, sir, Imulite is a little problem with the ACTH assay. In our institute also, recently we've seen 3-4 cases of possible or nearly confirmed cases of adrenal Cushing where the ACTH values came between 15, 18, 20, and when they were repeated on a COBAS platform, they turned out to be less than 1. So this Imulite thing is notorious for giving the false positive or elevated ACTH levels, which could, because sometimes we end up doing the cellular MRI also, where we may find something.
Yeah, thank you.
If there are no questions, we can call this session. Thank you, sir. Thank you so much. We now move on to our next session, to be delivered by Dr. Deep Datta. Oh, there you are. Dr. Deep Datta is an alumnus of our institute and also a very illustrated figure in Endocrine Society. He will be talking about growth hormone therapy, the present and the future. Deep Datta, please.
thank you so much for the kind words, dear Pankaj. It's a big honor to be back to my home institute, the conference organized by IPAGMER Department of Endocrinology, where I learned my entire endocrinology and even more in the larger perspective of life. I am grateful to the entire department and all my colleagues and seniors and juniors here. So in the next 15 minutes, my job is to highlight the present and future of growth hormone therapy. I just added a bit of past also because knowing the history always makes us wiser and perhaps help us in improving our future also. So the story of growth hormone starts pretty long back, 1958, when this researcher, Dr. Rabin, amazing work he did from extracting growth hormone. He went on to extract growth hormone from cadaveric specimens and purify it, and he was able to use it. Of course, it was so difficult to get even a small amount of therapeutic dose of growth hormone, and he was able to show a difference in children living with severe growth hormone deficiency. The next 20 years was all about extracted cadaveric growth hormone, which often had problems of reactions and so on. This is the beautiful journey of evolution of growth hormone in the last 70 years or so. Some major figures name are there. Was really lucky to meet Professor Zvi Laron, after whom was named the Laron dwarfism, who had come down to India before the COVID pandemic, the syndrome of growth hormone resistance primarily. 1985 was the game changer when recombinant human growth hormone was available for all of us. The cost of therapy did come down significantly, and hence the indications where we could use growth hormone also kept on increasing progressively. Then it took another pretty long time till 2021. Now we have the long-acting growth hormone analogs available, which are once weekly preparations. Again, a game changer because nobody loves pricks, especially the kids don't love pricks even more. So just 4 pricks a month. There's a lot of data coming up showing that they are really good in managing not only growth hormone deficiency in kids, but also with adults with growth hormone deficiency. I shall be sharing some of the literature. So the future is all about a long-acting growth hormone, which is likely to replace the daily injection in the next 10 to 20 years. So the problem with cadaveric extraction of growth hormone is this huge problem of Prions disease, the Creutzfeldt-Jakob syndrome, and it has been noted not only 10, 12, even 28 years after the use. So since 1985, nobody is using those bio-extracted form of growth hormone, but the problems are there. More than 200 reports of CJD has been noted in France and England, and even more reports from other European countries and America. Thankfully, we are not facing this anymore. If you look at the basket of recommendation of growth hormone therapy, we know it's growth hormone deficiency either alone or as a part of multiple pituitary hormone deficiency. Chronic kidney disease as a recommendation came pretty high up long back, if you see here, 1993, but the results are really not great or encouraging, but still it's there. Of course, even a few centimeter gain really does make a difference in those people. Adult growth hormone deficiency has also been there for a long time now. We have Turner syndrome, which is a state of a physiological growth hormone resistance. Also, we need a higher dose of growth hormone in them. Then small for gestational age. Idiopathic short stature is perhaps the biggest basket or biggest pool of patients where growth hormone therapy is being used. Knowing very well the outcomes are very tempered and very mild. Even if you can cause a 5 centimeter height gain, that would be really remarkable in these kids. But they form a huge, in terms of volumes, they are the largest in terms of all the etiologies for growth hormone use has been recommended. Of course, there is the SHOX gene deficiency, Noonan syndrome. Now there's data from even X-linked hypophosphatemia. They have used growth hormone to improve height outcomes. So let me share one paper we published long back during my residency days at Safdarjung Hospital, Delhi, where we looked at our entire cohort, around 130 odd kids with short stature, how they were doing 1 year height outcomes. Were we able to make a difference? This slide is just to highlight that treating growth hormone deficiency is really gratifying. Even after 1 year sincere use of growth hormone, we were able to show a plus 2.4 standard deviation score improvement in the height. That's remarkable. The only other condition where we can see such good improvement in height is perhaps untreated hypothyroidism in children. So these two conditions, the height outcomes are great. Of course, CDGP, we do nothing. These kids catch up. They have awesome outcomes. Other than them, be it familial short stature or ISS or small for gestational age or all those skeletal dysplastic syndromes, it's really disappointing in terms of improving the height outcomes in these children. I'm not going into the diagnosis of growth hormone deficiency. That's again a separate lecture on its own. But key to highlight is oxology, oxology, and oxology. Please keep plotting heights. I think we have improved. Our pediatrician colleagues have also picked up. We are routinely plotting more often the height and weight in the growth charts. You can use whatever chart you want. That's again another discussion. As a rule, we used the Agarwal charts developed from the urban Delhi kids during our DM times, and nowadays we are using more and more of IAP charts, which is a modified version of the WHO consolidated growth charts. So biochemical evaluation of IGF-1, biochemical evaluation of IGF-BP3 in kids less than 5 years of age, or doing growth hormone stimulation tests are primarily supportive for diagnosis. Oxology, monitoring of the heights, looking at the height velocity remains perhaps the gold standard investigation in terms of diagnosing growth hormone deficiency. So laboratory diagnosis, we have different stimulation tests because none of the tests are perfect. We are comfortable using clonidine stimulation test. Knowing well, we tell the parent the child might feel groggy, the child might be sleep off, and we check the blood pressure also in them, very important. And priming is very important for girls more than 10 years of age or boys more than 11 years of age, because the priming helps in improving the growth hormone levels. You can use testosterone in boys or estrogen replacement in girls, because we don't want to over-diagnose. We don't want to expose the kids to unnecessary use of growth hormones, because this is a drug which has its own share of side effects. Insulin tolerance test, gold standard, but we are not using it because of the risk of severe hypoglycemia, especially in kids with multiple pituitary hormone deficiency. Typically, we say any growth hormone level more than 10 nanograms per ml rules out growth hormone deficiency. If you have a value less than 7 nanograms per ml after stimulation in kids, that's strongly in favor of growth hormone deficiency, and less than 3 nanograms per ml in adults is considered to be supportive, not diagnosis, supportive of the diagnosis of growth hormone deficiency. Single testing is not reliable. We may have to repeat after 3 months or so. In Delhi, we do get a lot of parents and kids, what we call is the aspirational short stature, or we often say is the parent concerning short stature. These kids come say that I am the shortest in my class, and we plot their height on the growth chart, it comes around 50th percentile, even 70th percentile. So I think with the increased aspiration of a society, everybody wants to be tall, taller, and tallest perhaps. These are not the places where we should be using growth hormone. We are going to cause a lot more harm. There's no point of even evaluating for growth hormone deficiency in a child with height percentile of say 30, 40, 50 or 60th in the chart. It makes no sense. And provocative test a bit we have discussed. Idiopathic short stature is the biggest basket. Again, oxology has a major role. We see that these kids are short, they are not gaining height over 6 months, at least 1 year of follow-up. The height velocity is falling apart. We may consider growth hormone, discuss with the parents, keep their aspirations down to as low as possible, and if they can afford it, you can try it for a short time. Like in growth hormone deficiency, we say at least 10 centimeter height gain should be there after 1 year of growth hormone therapy. If you are not able to achieve that after 1 year, seriously something is wrong. Either the patient is not compliant, or maybe we should revise our diagnosis. In ISS, I think even a 5 centimeter height gain would be great after 1 year of sincere growth hormone therapy. So responsible use of growth hormone therapy is the present of growth hormone therapy. Irrational use does happen in our society. There is a lot of off-label use of growth hormone in gyms, in bodybuildings, in cocktails they use growth hormone. So those are to be strongly discouraged. It's a responsibility of us to make the society aware of the side effect of this otherwise a great molecule. So a successful treatment of growth hormone is determined by diagnosing the condition as early as possible and using the medication in the lowest possible dose for the best outcomes with minimal side effects. This is perhaps the most important slide of the entire presentation, which shows the different conditions where we are using growth hormone, and this gives us the outcome, the likely height gain in the last, you see the column. So growth hormone deficiency and Prader-Willi syndrome are two conditions which are exquisitely sensitive to low dose of growth hormone, so great outcomes. In Prader-Willi, we primarily use for metabolic benefits also. The sleep apnea improves, the muscle mass improves, the fat mass just go down. I think chronic renal efficiency is the worst outcome. Even in these kids, we have a 2 centimeter height gain in 1 year. That's awesome. Typically, even after 5 years of growth hormone use in chronic renal insufficiency, you hardly get 4 to 5 centimeters of height gain. Turners is a state of physiological growth hormone deficiency, so they need a higher dose of growth hormone therapy, so the cost of therapy also goes up exponentially, and the height outcomes are also slightly more tempered. And of course, the small for gestational age is also a condition where everything is small in the child, but yes, a growth hormone therapy, if they can afford, does make a difference to some extent in these kids. Dosing strategies, nothing is perfect. You can go for the auxology based dosing or the IGF-1 based, trying to keep the IGF-1 between 58 to 100 percentile range, or you can use the prediction models. None of them are perfect, so use your whatever your department, your institute is comfortable with, stick to that and generate your own data. That's the way forward. Use of GnRH analogs to delay the closure of epiphysis and growth hormone therapy. I think now we have enough data to show that in idiopathic central precocious puberty, 2 years use of sustained use of GnRH analogs with growth hormone does make a difference in terms of improving the final height by around 4 to 5 centimeters. But like in idiopathic short stature or SGA, there is no role of giving GnRH analogs with growth hormone. It doesn't make any difference in the final height outcomes. Other drugs, aromatase inhibitors, there's some data to show that it works good with growth hormone, especially in young boys with short stature. And oxandrolone, there is some data in young girls living with Turner's syndrome. Side effects, pretty diverse and non-specific. Edema is the most common side effect seen in the initial few months of use of growth hormone therapy. Sometimes these kids may complain of headaches. You should rule out papilledema. You should think of pseudotumor cerebri, more commonly seen in chronic renal insufficiency and also people with growth hormone deficiency. Skeletal deformities, spinal deformities are more common in people living with Turner syndrome, and worsening of hyperglycemia or mild dysglycemia is again common. Many times we may have to give a break in treatment and you can restart later. So these drugs are not free of side effects, and hence we should be using them in the lowest possible dose. So start early, start low, monitor well, counsel the patients, don't tell them have sky high expectations or the disappointment will be very high a few years down the lane. So I think idiopathic short stature we have discussed that the outcomes are very much more tempered. Where not to use in any patient with active cancer, no role of growth hormone. At least 5 years of remission or cure of so-called cancer should be there and should be clearance from the oncologist before we consider growth hormone therapy in them. Not to be used in metabolically decompensated patients like extreme obese kids or uncontrolled dysglycemia. There is no role of growth hormone. Again, severe sleep apnea is the contraindication for use of growth hormone, and of course any underlying psychiatric disorders we should not be using growth hormone. Prader-Willi syndrome, we just told you that it has a lot of non-height benefits in terms of improving the body composition parameters, the muscle mass, reduces the fat mass in them. Small for gestational age, yes. These kids, I think they need a good auxology monitoring, and we can try growth hormone. Again, keeping the expectations slightly lower. The outcomes are slightly better in small for gestational age as compared to kids living with idiopathic short stature. This is a good paper coming from France, which showed that in kids with small for gestational age, 25% of the kids could achieve their final target height when they received growth hormone for at least 4 to 5 years. Russell-Silver syndrome, again, this is a condition where we may see a high level of IGF-1 at baseline, and they have also a variable response to growth hormone therapy. I think CKD we have already discussed, need very high dose, and outcomes are really blunted in these kids. Outcomes are better post-transplant than we give growth hormone in the pre-transplant, but many kids have to wait for a long time before they get the appropriate transplant. So moving on further, this is a child with Schacht's insufficiency or Lady-Well dyschondrostosis, where the features of Turner's, but it's not Turner's because they have 46XX, but the Schacht's gene is not working. Off-label use in the FX gene mutation or hyperphosphatemic osteomalacia, there is good data coming up. Even juvenile idiopathic arthritis, growth hormone does help in improving height outcomes. Now the adult growth hormone deficiency, I think this is the area where we're missing a lot of diagnosis. Typically any child who has lived with growth hormone deficiency, they move on to adulthood, they deserve a growth hormone replacement, but the doses are much lower, so the cost of therapy does come down significantly. And when we are thinking of adult growth hormone deficiency treatment, we are thinking of preventing dyslipidemia, maintaining a good muscle mass, giving good quality of life, perhaps improving the cardiovascular outcomes, perhaps improving the bone health outcomes. So height is not a factor, it is the other metabolic things, improvement which we are primarily looking at. This is the huge basket or the etiology of adult growth hormone deficiency on its own. So these are the benefits what we have been talking of: reducing insulin resistance, reducing the burden of metabolic syndrome in these adult individuals. Diagnosis again is no clear-cut. IGF-1 levels are much low because we use age-specific values. Typically 84 nanograms per ml considered to be the normal range. It varies from the whatever machine or kit you are using, the instrument you are using. Again, stimulation tests are important. The stimulation tests in adults are different from what we use in kids. So clonidine doesn't work. You may use a glucagon stimulation test or macrorenin stimulation test, but we don't have that available in our country. Of course, ITT works everywhere, but it's a dangerous test, so we are not commonly using in our practice. Yes, so whenever we are thinking of replacing an adult with growth hormone, please rule out papilledema. Fundus examination, very important in them. MRI, very important. You may consider bone health assessment because there is some benefits on bone health outcomes, and CV risk assessment is again important. Dosage, very low dose, only 0.1 to 0.2 milligrams per day is the typical dose requirement. We monitor by looking at their glycemic profile, the lipid profile, their metabolic profile, changes in body weight, and of course thyroid. Thyroid function and cortisol monitoring are very important, whether it's an adult with growth hormone deficiency or a child, because growth hormone therapy may mask subclinical hypothyroidism and subclinical hypocortisolism also. So that's very important. Yes, so and very important in pan-hypopit patients, we are told since our training days that first correct hypocortisolism, then correct secondary hypothyroidism, and the last thing which we correct is the growth hormone deficiency, because if we go the other way around, we may precipitate an adrenal crisis. Duration of growth hormone therapy in adults, how long can we use? We have good published data for even 20 years use of growth hormone in adults with no adverse impact in terms of cancer. Risk of cancer does not go up. The safety is there for more than 20 years use, and the metabolic effects are pretty durable in adults at extreme low dose of use of growth hormone. So the future is the long-acting growth hormone. So let's see what the data is there for the weekly long-acting growth hormone. There are 4 or 5 preparations available. The somapacitan developed by Novo Nordisk group is perhaps the most well-studied preparation, both in adults and kids. We published a meta-analysis on the use of LAGH, the somapacitan in adults with growth hormone deficiency. Good data showing that yes, it does have a beneficial impact on different metabolic parameters. It is as good as daily growth hormone injections. There was the initial fear of growth hormone stacking with long-acting preparations, but it doesn't happen in the clinical trial and in the real-world scenario. And the quality of evidence, the grading was pretty good, moderate to high, if you see here. So I think slowly, once the cost also comes down, it is going to replace the daily growth hormone injections. Similarly, we have many RCTs, even meta-analysis published on the safety and efficacy of long-acting growth hormone preparations in children living with growth hormone deficiency with very good outcomes. This is the 18-month outcome of growth hormone replacement in adults with growth hormone deficiency and bone health. The interesting thing, the first 6 months of growth hormone therapy, the BMD actually does come down by a few 0.00 gram per centimeter square, and then it starts to go up. By 18 months, there's a good accrual of new bone, and the benefit again is primarily seen at the spine, the trabecular bone, and to a lesser extent at the hip joints. Growth hormone and aging, just published last year. So we always think, is it the elixir of youth? Is it going to promote longevity? A Good Clinics North America article showing that, sorry, I was disappointed that there is still no hard evidence of routine use of growth hormone in adults without growth hormone deficiency. It does not improve survival. It does not improve longevity or quality of life. I came across a very interesting article in people, just 2 more minutes, in people with cirrhosis, which is the cachectic state, and they have used growth hormone to improve the muscle mass, the energy levels, the quality of life does improve. But the 1-year survival, there was no difference when growth hormone was used in people with advanced cirrhosis. There's a nice systematic review of use of growth hormone in more than 6,000 children with craniopharyngioma used within 2 years of remission of surgical, so-called cure or remission of craniopharyngioma, showing a good height outcomes, average of 4.9 years of growth hormone, maximum even 9 years use of growth hormone, and they could show a good improvement in height outcomes without any increased risk of recurrence of tumor. So a very nice important paper published recently. Growth hormone and IVF. Now, different IVF centers, they use growth hormone as a part of their cocktail therapy to improve fertility and pregnancy outcomes. This is a Cochrane review way back in 2009. They showed us that they found that yes, growth hormone does improve the pregnancy outcomes, but they couldn't specify who are these women where growth hormone does make a difference. Now in 2023, we just have a paper which show that in women who are more than 40 years of age, who are subfertile with standard therapy, if you use the growth hormone based therapy, it does improve the chance of fertility, pregnancy, and pregnancy outcomes. And this is the same thing. Good systematic review on use of growth hormone, LAGH, in kids with short stature. And priming, yes, a nice article came in Clinical Endocrinology 2 days back showing that yes, there's a good data that priming does make a difference to rule out those unnecessary patients who don't have growth hormone deficiency. So it really does, we should routinely use priming in teenagers or young kids to rule out growth hormone deficiency. This again a very nice paper came in Lancet just last year. We showed that kids who were small for gestation age, who received growth hormone for 8 to 10 years, when they were 30 years of age, nearly 12 years of follow-up, the SGA kids, 120 odd kids who received growth hormone and 219 kids who did not receive growth hormone, there was no long-term adverse impact. There was no increased dysglycemia or dyslipidemia or any metabolic abnormalities. So good safety data of use of long-term growth hormone in people with small for gestational age. Idiopathic short stature, I think the outcomes are tempered, hardly 4 to 5 centimeter height gain. That's the message coming from this systematic review. We already told about the X-linked hypophosphatemia, and this also highlighted there is no role of GnRH analogs with growth hormone in idiopathic short stature. Only in idiopathic central precocious puberty we should be using it. And I think the bone outcomes are, there is no role of growth hormone in osteoporosis. There are good studies show that when you give without growth hormone deficiency in osteoporosis, the bone health does not improve. So it is an anabolic agent, but it is not a bone forming agent. So this is a good paper we should all read because this has a data of more than 80,000 kids with growth hormone deficiency, nearly 46% with growth hormone deficiency, 10% Turner's, 10% ISS, 10% SGA, showing good safety outcomes and variable response outcomes. Very nice paper published in JCAM last year. So I think I would just like to end by pragmatism is the word. Use low dose but use as early as possible. We should avoid treating aspirational short stature, and I think the future is long-acting growth hormone therapy. Thank you so much.
Thank you, Deepta, for that excellent talk. And the forum is now open for discussion. Honorable sir.
Deep, thank you. Very nice presentation. Now, in one of your slides, you showed we are discussing that the contraindication regarding the growth hormone therapy as obesity. Now, my question is that if somebody has got a growth hormone deficiency, kid with growth hormone deficiency and obesity, is it a contraindication to start growth hormone therapy?
No, absolutely not, sir. A child with obesity and growth hormone deficiency, we should rule out diabetes, if metabolically stable. We should encourage the child to lose weight, knowing that if we are going to use growth hormone in them, obesity causes some degree of physiological resistance of growth hormone at the level of liver. The child may need a slightly higher dose for the same metabolic benefit, and the risk of side effects also slightly higher in those kids.
Yeah. So in deserving candidate, just mere presence of obesity cannot be a contraindication?
Absolutely not. It's not an absolute contraindication. True, sir.
The second point I would like to ask you that while you are treating the adult growth hormone deficient subject, now as far as the stimulation tests are concerned, are you going to stimulation test as we do in case of the children, say for example Sheehan syndrome? If you start the growth hormone replacement therapy, do you really need 2 stimulation tests or you can just do with 1?
So in Sheehan syndrome, if you have 2 or more pituitary hormone deficiency, we may not even do a stimulation test. Why stimulate in those patients? So we go for the clinical phenotype. We look the imaging of the pituitary is just there's an empty cella.
Empty cella.
There's no point even in stimulating in those patients. Absolutely, sir.
Thank you.
Deep, again a very nice talk. With regards to patients, children with cancer, history of cancer. So what should be the optimum time? Because again there is a lot of controversy, some 2 years earliest. And do they need to be means totally documented to have, or if they are continuing any form of maintenance, because a lot of them come with maintenance chemotherapy as well. Any insight to that?
Yeah, there's a lot of...
And how long means to monitor, and what should be the IGF-1 in these patients?
So I did look into it. I couldn't find any clear-cut answer. The issue is perhaps the child is losing years, the child is worried that parents are worried the child is not going to gain height. So we are really pressed to use, and there's a medical legal aspect. If something goes wrong, are we going to be sued for that or not? So typically clean discussion with the treating oncologist, getting it written that we can safely use is very important. Document, keep a copy of the paper with yourself. As I could find some guidelines showing that 5 years of remission of the tumor without any recurrence can be a very safe margin. Of course, 2 years data is also there, but I think 5 years is a really safe margin where we can happily use. But yes, now I think perhaps the guidelines will evolve, perhaps it will become lesser in the coming years.
Deep, excellent talk as usual. One practical issue we face, parents ask us, how tall will my child grow? They are spending so much of money. So you have to give them an answer. So on what do you base this, your calculation? How do you go about it?
Yes, that's why it's very important to be very clear what are we expecting, because it's very costly. The monthly cost of starting therapy is around 10 to 12,000, and if the child weight is higher, the cost also goes up exponentially. So typically in growth hormone kids, I tell them, see, at least 10 centimeter height gain in 1 year I'm looking, so at least 5 centimeter gain in 6 months. So let us review initially 3 monthly for first 6 months. If you're not gaining 5 centimeter, we have to again take a call whether it is worth treating it or not. So that's for clear-cut growth hormone deficiency, which is a small fraction of patients. The other fraction is perhaps the idiopathic short stature, where the outcomes are even more blunted. So they are even if a 2.5 centimeter gain in 6 months or 5 centimeter gain is 1 year is considered to be good enough.
Yeah, it's okay if we tell them about the short-term growth, but what they actually want to know is what final height would they expect. So
I think we have to calculate the predictive adult height. We need to write it down, document this we are expecting. The auxological monitoring which we are doing, we shall keep on doing. We shall try to document the change. So I think instead of giving a final concrete answer, a re-evaluation of the treatment every 6 monthly is the best way, the safest way to go forward.
Thank you.
Yeah. Thank you, Dr. Deep. Just to add to the discussion on the gap we should give for a cancer or a craniopharyngioma. So typically the 2016 guidelines said 1 year is good enough as long as the tumor is stable. So indeed, like for craniopharyngioma, we are more concerned because we see a lot of patients with craniopharyngioma with the concomitant growth hormone deficiency. Indeed, at one recent EJE statement, if you look at, so it said that if there is a compromised adult height, especially severely compromised adult height is predicted, you can start even after 3 months. So very recently in 2023, this month or previous month, one more nice article has come in JCM. They are recommending around 6 months. So probably depending on the situation, you not have to wait for 2 years.
Thank you so much.
If there are no further questions, we'd like to thank Deepta again for coming down to give the talk. Thank you, Deepta.
Thank you. My pleasure.
Big
Thank
round
you
of
so
applause
much.
for Deepta, please. We now quickly move on to our last talk in the adrenal section, which will be delivered by Dr. V. Srinagesh from Hyderabad. And he will be taking us through management of congenital adrenal hyperplasia and update. Dr. Nagesh.
Good afternoon, respected doctors, and before I begin, I'd like to thank my friends, especially Soumik and Partha for inviting me here. It's good to be back at Crescendo. The next 20 to 25 minutes, I'm going to give you a brief update of what's new in congenital adrenal hyperplasia. This is how it's going to be, the scope of the problem, current scenario, what's new in screening, diagnosis, management of CH, and subfertility aspects of CH, which is most important for the adult. This is perhaps the most common genetic endocrine disorder which is seen in the population. It's an autosomal recessive disorder which mainly impacts your adrenal steroid synthesis. It is the most common cause of genital ambiguity in 46XX infants. Usually you get a 46XX infant. Unless proven otherwise, you are looking at a case of CH. More often than not, 90% of the cases, it will be a 21 hydroxylase deficiency. It leads to a variable dysfunction of cortisol secretion and aldosterone secretion. That is why they will present with an adrenal crisis as well as hypokalemia and hypernatremia in addition to the androgen excess. This is how a typical patient will present with CH. More often than not, you got a classical salt losing presentation of CH. Rarely you can have the next most common one is a female who presents with ambiguous genitalia. It can be as severe as somebody having a PRAD-F5 presentation where you will have a typical male genitalia-like presentation but with no descent of gonads. If it is a male with CH, you can present with a male isosexual precocious puberty, usually presents after 6 months of age. Slightly milder cases, the so-called non-classical CH can present with no ambiguity in the genitalia, no salt-losing crisis, presents with premature adrenarche, that is development of pubic hair before the age of 8 years. And rarely in the adult age group, they can present with infertility, and hirsutism and acne are very common in CH. This is one of the commonest differentials for polycystic ovarian syndrome. Especially a lean PCOS, unless proven otherwise, we need to look for major causes like CH. More often than not, this is the typical presentation and typical way in which you diagnose this. You do a serum cortisol. In the salt-losing variants, especially after day 3 of life, the cortisol levels will be low and the 17-hydroxyprogesterone levels will be high. It is generally not recommended to test for this in the first 72 hours of life because these are acute phase reactants. The stress of pregnancy causes a rise in ACTH. The 17-OHP can be high. Potassium is typically fairly high in the first 2-3 days of life. This might be a false positive for CH. And cortisol might be elevated in the first couple of days of life because of a rise in ACTH. Serum testosterone might be elevated, but this is more of a secondary evaluation. At diagnosis, DHEAS might be high, but later on in life, as we keep treating the child with corticosteroids, glucocorticoids, the importance of DHEAS does go down. Confirmation, especially in the borderline cases, we tend to do a short synactin test. And the one true test we have for salt losing determination is a plasma renin activity. And androstenedione is one test which is coming up in a major way as far as the management of CH is concerned. I'll be discussing later about it. Karyotype, of course, is mandatory in all women, in all female patients who present with an ambiguous genitalia. And genetics is now again picking up a lot of times. We don't do genetics the right way in CH. I'll be discussing it slightly later. And this is how a typical case would present. Initially, you start people with a high dose of hydrocortisone and fludrocortisone, give them some extra salt in the feed, look for hypoglycemia. The first year of life, gradually lower the fludrocortisone dose, increase the hydrocortisone dose slightly, and growth is not a major problem in the first year or the first couple of years of life. Toddler, again, you slightly lower the hydrocortisone dose, try to make fludrocortisone once daily, and look for hypoglycemia. As you grow older, especially in the childhood, this is where the impact of glucocorticoids and height starts coming in. It has a negative impact on the height velocity, less risk for hypoglycemia, and you just have to give them enough glucocorticoid to ensure that you have a control of CH and at the same time you don't compromise growth. Once you hit puberty, again the hydrocortisone and the fludrocortisone requirements increase. The morning dose timing becomes very important because slightly later, and this can have a major effect on the ACTH rise. And managing children of this age group is easy in one hand because they know how to treat their emergency. It is difficult on the other hand because of the teen angst. Most of these people are unlikely to take their hormone doses. So these are the common goals. If you are looking at a child, your main priority is preventing a crisis. Preventing a precocious pseudopuberty. Initially it can be heterosexual in a female. It is usually a false precocious puberty. Later on it can be a true precocious puberty. You have to prevent growth failure. Girls, time the genital corrective surgery. More often than not it is done at around 3 years of age before these children join school. And also look at the psychosexual development. As you grow older, especially in an adult, fertility comes into the picture. Growth and puberty are no longer a concern. You just need to maintain glucocorticoid therapy, and it is this maintenance which becomes very difficult, because as you grow older, your requirement of glucocorticoid comes down, you are less likely to develop an adrenal crisis, and children and these adolescents and adults become very lax with therapy. Quality of life suffers because of this. These people start having some amount of osteoporosis and osteopenia, even though that's not very significant in an adult. Tumors can be a possibility, especially testicular adrenal rest. That is also something I'm going to deal slightly later. And the biggest problem is fertility, because both males and females will suffer from subfertility in CH because of multiple reasons. This is how the traditional management of CH has gone in. Identify at birth, determine CH, confirm CH, start with hydrocortisone. Once they have reached adulthood, lower the dose of hydrocortisone and continue with the treatment for life. But unfortunately, as all of us who have treated CH know, this does not yield a lot of results. Many people don't follow up very well for CH even in their childhood, and once they reach adulthood, it's almost impossible to get them back for management. And in the last 70 years, ever since hydrocortisone was discovered, this is how CH has been managed. The question, what is new in the management of CH, reminds me of a poem from Longfellow. I shot an arrow into the air, it fell to earth, I know not where. This is how the routine management of CH has been. Neonatal screening is one area where we fail in a lot of situations, because unlike in the West, screening is not properly done in India, and screening is very ambiguous. In a premature infant, even the first week or the first couple of weeks of life, 17 OHP can be high. And this can stymie your screening. We have absolute threshold cutoffs which are not very useful in the management of CH, and that is why recent guidelines actually determines stratifying 17 OHP threshold levels by birth weight or gestational age. You got some Western data, but Indian data on this are still lacking. Wait for at least 44 hours before you get a sample. Many hospitals have this habit of doing a sample immediately after birth. This doesn't work very well. And method used. Many people actually use CLIA. CLIA is a very wrong method of actually screening for 17 OHP. The best is doing either a gas chromatography or a liquid chromatography and a tandem mass spectrophotometry. And most important, there are multiple metabolites which are seen in a typical steroid pattern. And just doing a simple 17 OHP is not going to give you a lot of field. If you can afford it, if you got the facilities for it, doing a ratio of 17 OHP versus 11 deoxycortisol can help you screen and pick up more cases of CH. Biochemical testing, how many of you screen only by 17 OHP in this hall? What is the commonest test you do for 17 CH? Many people would actually do it only with 17 OHP, which has its own limitations. More often than not, 17 OHP alone or androstenedione alone is not a very reliable test for CH, and that is the reason why we started going ahead with what is known as an androstenedione testosterone ratio. We have a lot of downstream as well as upstream metabolites in CH, and now that steroid panels and metabolomics have come into the picture, we are getting to know more about this. There's still a bit of a novelty in India. Measurement of progesterone, especially in women with subfertility, and urinary gas chromatography, tandem mass spectrophotometry, steroid metabotyping is the way things are going to happen in the next 10 to 15 years. In an adult, if you go only by 17 OHP, even a very well managed adult can have very high 17 OHP levels, and it is not a very good parameter for monitoring CH. 17 OHP levels vary all through the day. In fact, many guidelines actually recommend doing a morning, afternoon and an evening 17 OHP, which is not practical for reasons of phlebotomy as well as reasons of cost. DHA is a very good metabolite for diagnosing CH, but once you have started treatment of CH, even in very poorly controlled CH, the DH can be suppressed and it cannot be used for monitoring. A lot of times testosterone is used for monitoring, but in women can have a concomitant CA, concomitant PCOS. If you go by Hickham's dictum, a patient can have as many diseases as he or she wants to have. It is very likely, especially in this era of obesity, that somebody can have both a CH as well as a PCOS. And looking at testosterone levels in this setting is not going to help us a lot. We have a lot of upstream and downstream metabolites, especially progesterone. A very lesser known entity called as 16-hydroxyprogesterone, 11-beta-hydroxyprogesterone and 21-deoxycortisol, which is perhaps the best metabolite you can do for neonatal screening, because there is only one source of 21-deoxycortisol, and which is the adrenal gland. All of these factors will come into the picture. Most importantly, in the last few years, we've started looking at what is known as the androstenedione-testosterone ratio. In a normal woman, the usual ratio of androstenedione to testosterone is 2:1 because most of the androstenedione comes from the adrenal. If you look at a woman with CAH with concomitant PCOS, the testosterone contribution to this goes up because there is some amount of testosterone contribution from the ovary, there is some amount of androstenedione from the adrenal, and you get a 1:1 ratio. In an uncontrolled CAH, the androstenedione goes up, whereas the testosterone is not very high because women do not have the enzymes which convert androstenedione to testosterone, so the ratio is 4:1. You do this ratio, anything approximating this will give you an idea that whether you're dealing with a poorly treated or a well-treated CAH. In males, normally most of the androstenedione produced from the adrenal is converted to testosterone. The usual ratio is to the tune of 1:5, never more than 2:5. In an uncontrolled CAH, the androstenedione starts going up, testosterone remains stable, the ratios come down, and if you are looking at a ratio of 1:2 or less, you are dealing with a very poorly controlled CAH. This is a very good, reasonably inexpensive test to monitor CAH. And genetic testing. I have seen this mistake commonly done by a lot of people. Many pediatricians actually do an exome sequencing or clinical exome sequencing or a whole exome sequencing. If you are looking at 21-hydroxylase deficiency, where there are a lot of downstream regulators which influence how your CAH is, you are unlikely to get a very good result. This is how a typical CAH gene would look like. You got the CYP21A2 gene and a CYP21A1 pseudo gene. Both these genes have a significant amount of recombination, and it is this recombination between these two genes which determines what kind of CAH you have. And that is the reason why the best gene panel for CAH is actually doing a targeted gene panel with deep penetration and an MLPA, a multiplex ligation dependent probe amplification. Many of the cases of CAH are actually compound heterozygotes. It's difficult to find a homozygote. 90% of the cases will be a compound heterozygote. And that is why if you do a proper genetic evaluation, you will have a good genotype-phenotype correlation. In fact, in one of the recent studies, this was how they had a correlation of the various genotypes. The null group, where you did not have any intrinsic 21-hydroxylase activity, these were all the various deletions. The A group, which had a very severe genotype with less than 1% of the wild type activity. The B group, which had moderate amount of 21-hydroxylase activity, which are the so-called simple virilizing CAH. And the C group, where you had significant amount of wild type activity, which is what contributed to the non-classical CAH group. If you do a proper genotype, you can actually do a correlation of the genotype and phenotype, and in almost all cases, a properly done genotype will give you an excellent correlation with the phenotype. But this cannot be possible if you do only a whole exome sequencing. And there was one recent study published just a couple of months ago which actually tried to classify CAH patients depending on urine gas chromatography mass spectrophotometry into three metabotypes. Metabotype 1, undertreated, metabotype 2, which was well treated, and metabotype 3, which was over-treated. They could just get it from one drop of spot urine, a bit like the three zones of Goldilocks, the three bears of Goldilocks, where you had a very hot porridge, cold porridge, and a porridge which was just right. This is a simple method of classification if you got preset metabotypes. This is still experimental. I think it will be a decade or two before we start using this kind of metabotypes. As far as management is concerned, this has always remained the traditional management. Hydrocortisone 5 to 10 mg thrice daily. It is a mild to moderate intensity therapy. Initially, we do not give a nighttime dose in children. As you grow older, you probably have a reverse circadian kind of regimen. Sometimes this might not be enough to bring down the ACTH which rises in the night. Then you add a prednisolone dose at bedtime to counteract the early morning ACTH rise. If this does not work, the next intense therapy is giving them twice daily prednisolone, which is moderate intensity in people who are not controlled at all by hydrocortisone. Subsequent to this, you have the very intense dexamethasone dose. This is actually seen in people who don't respond and people who are in their teenage. Most of my patients, once they hit 11 to 12 years, are not well controlled with hydrocortisone. We have to go on to one of these hybrid regimens, and very rarely we have to put people on dexamethasone. And in boys with testicular adrenal rest tumors, the only good method of suppressing these tumors is using dexamethasone. Sometimes you got a moderate dosing, especially in girls with non-classical CH who do not have suppression of pubarchy. We give them a single small dose of dexamethasone at bedtime, which is more than enough to suppress these androgens just enough so that they have normal growth. And very rarely in very mild non-classical CH, we can even give them 0.25 mg of dexamethasone alternately. This is the varying intensities of glucocorticoid therapy in CH. And this is how these are how the various graphs look. In a healthy individual, you will have a rise of ACTH, then rise of cortisol, it falls again towards the night. In somebody who is on hydrocortisone, this is how it goes. Morning dose, afternoon dose, night dose. Twice daily hydrocortisone, you got a morning rise and an evening rise. Prednisolone is slightly different. You get one small peak in the day and one larger peak somewhat throughout the day. And dexamethasone, you get a single very large peak throughout the day. This is how the various patterns are, and you can actually see that none of these are physiological. Nothing is replicating the pattern in the healthy individual. All these regimens are only cop-outs. We do not have a physiological method of replacing hydrocortisone as of yet. And this is where the role of newer therapies have come in. This is something which we've been hearing for the past 10 years without any actual benefit. Plenadren was a dual-release oral hydrocortisone preparation which was designed as an immediate release or an extended release coat. It was approved by the European Medical Agency for primary adrenal insufficiency, but overnight ACTH remains high, and that is the reason it has not been approved. Something new is the use of Chronocort. Chronocort is something, another usual suspect. We've heard about it for the last 10 to 12 years. It is a double-layered capsule which is oral delayed release and a sustained release tablet. The peak cortisol secretion occurs at around 6 a.m. when it is given in the morning. Then, because you have an afternoon adrenal surge, you got a second dose which is given in the evening. Given twice daily. In adrenal insufficiency, it is given once daily. In CH, it is given twice daily. 2/3 in the evening and 1/3 in the morning. And this has been approved for CH by the EMA in end 2021. This is perhaps the first novel therapy which has been approved for CH. This is how it basically looks like. You've got an inert core, then you've got a hydrocortisone layer, sustained release layer, entry coated to prevent it getting digested in the gut. This molecule again is an adjunct to therapy with the glucocorticoids. It's a CYP17A1 inhibitor. Initially used for prostate cancer, but it has found some use in management of CH to decrease androgen excess in female and prepubertal children with classical CH. Other newer molecules, we've got nevanibib hydrochloride, which is an ACAT1 inhibitor, reduces adrenal androgen production, which is glucocorticoid sparing, but the problem with this molecule is it is toxic to the adrenal cortical cells when used in higher doses. Lower doses, it is ineffective. Tildacerfont and crinecerfont are CRF1 antagonists which aim to reduce the ACTH levels acting at the level of the hypothalamus and the pituitary. These are still in evolution. And coming to the last part of the talk, subfertility is the factor with which we are maximally concerned when we are looking at adults. The biggest problem for male is what is known as a testicular adrenal rest tumors. These originate from the adrenal cortical primordial cells in the gonads. Because they are typically located bilaterally near the rete testis, if they grow to a larger size, they cause compression of your testicular tissue and obstruction of seminiferous tubules and blood flow, and can lead to the atrophy of the testis and death of the Leydig cells and the Serotoli cells. Typically, it was described more commonly in salt-losing forms of CH, and it was conjectured that it was poor control of CH which actually led to this kind of picture. But as our understanding of genetics has gone up, we have now understood that it is this group, the null group with 0% of native gene activity, which suffers majorly from this kind of testicular adrenal rest tumors, and this is where genotype-phenotype correlation has a major role in the management of CH and prevention of TARTs. More often than not, it is conjectured that it is because of an in utero rise of ACTH which predisposes to the genesis of TARTs irrespective of the kind of treatment you get after you are born. This is how a typical testicular adrenal rest tumor would look like. Testis, you find small tumor-like masses, and the only way of detecting is once you start hitting your puberty, do an annual scrotal ultrasound. Treatment for this is very simple. Intensify the glucocorticoid therapy. More often than not, you have to use dexamethasone. screen these children starting from adolescence, differentiate from Leydig cell tumors so that you prevent them from having an unnecessary surgery, because this condition does not require a surgery. And the last part, female fertility, is what concerns a lot of us in endocrine practice in adulthood. These women have chronic anovulation and endometrial dysfunction. Estrogens produced from the adrenal androgens by aromatization are what cause this clinical picture, along with increased rise of progesterone, which is upstream of 17-hydroxyprogesterone. This rise, a lot of times, the only situation where we actually see a progesterone report in a person with CH is when we order 17-OH progesterone and the lab does a progesterone instead. But in adults, we generally don't have a role for progesterone in CH, but in an adult woman, we might have a role for progesterone. We might need to intensify the glucocorticoid therapy. Ovarian adrenal rest tumors, which are the cognomen of adrenal male testicular rest tumors, are very rare in women. Treatment for this again remains intensification and optimization of glucocorticoids. Metformin can be used to some extent. Many of the fertility regimens actually incorporate use of clomiphene and gonadotropin or GnRH. Extreme cases as a salvage, you can do a bilateral laparoscopic adrenalectomy, but that again brings into the picture rise in ACTH and a future risk of Nelson syndrome. Many a time, this is what fertility people do. They do an IVF under the cover of glucocorticoids and maintain the IVF slightly later into pregnancy so that there is good blastocyst implantation and you can progress well with pregnancy. To conclude, CAH is a common pediatric endocrine disorder. It is perhaps the commonest inherited pediatric endocrine disorder. Treatment has not changed much ever since hydrocortisone was discovered. It still remains the mainstay of therapy, but you do have alternatives. Many people had this misapprehension that dexamethasone was a very bad molecule. People had this impression that dexamethasone is 120 times as potent as, is 30 times more potent than hydrocortisone, and you have a tendency to overtreat these children. But this is an equivalence which has been borrowed from anti-inflammatory properties. As far as suppression of ACTH is concerned, it is much more potent. It is almost 120 times more potent as compared to hydrocortisone. But it does not cause the amount of side effects which it is known to have, and you should consider switching over from hydrocortisone to a new molecule. And if you are monitoring children, once they are in their teens, you have to switch either to prednisolone. You will need it in most cases. And if you are monitoring only by 17-OHP or by DHEAs, you are going to miss a lot of your undertreated cases of CH. And they are going to end up both with a shortened height as well as later subfertility problems later on in life. We have a lot of newer regimens. All of these can be used as a mix and match. They can be individualized. Because 50% of my patients who are over the age of 10 years are now on dexamethasone. The rest of them are in a combination of hydrocortisone and prednisolone, because hydrocortisone alone just does not work in a lot of patients. We have newer regimens also and newer molecules also, but I don't think we are not going to get Chronocort in the next few years in India because of its cost. Metabolomics is here to stay. We already have steroid panels. Many people, I think, are working on steroid panels, but a better way of doing it is metabolomics, because steroid panel is done with liquid chromatography, which is still not a very good method of picking up all the metabolites. The best method is doing a gas chromatography, which is available only in a few Western countries. We do not have individual native protocols, and we do not have phenotypes for or genotype-phenotype correlation for metabolites, but if we start doing it at a larger scale, we can perhaps formulate our own protocols for urine and blood metabolites. Commonly used is urine because of convenience. Genetics, again, many people make this mistake of doing an exome sequencing. That is not the way you go ahead with managing a CH. For 21-hydroxylase, you always have to do a specific 21-hydroxylase probe and an MLPA. If that is negative, to look for other variants of CH, you can then do an exome sequencing, but that should never be the first line test. Because if you do that, you are going to miss out a lot of cases of CH. And we have a lot of novel therapies under the pipeline, but the most important thing in managing a CH is you should be clear of your goals. The patient should be compliant with therapy, and you should be aware of the newer options and the problems which are commonly encountered in the routine management and the routine biochemical evaluation of CH, which is just about inadequate. That's it. Thank you. And if you've got any questions, I'd like to take them.
Thank you, Dr. Nagesh, for that clear-cut overview of CH and what we can look forward to. I believe there must be some questions from the audience, the delegates, the residents.
Sir, very nice talk. I would like to know about what should be a screening protocol in cases of preterm infants, or like at what day of life should we screen? Because we had a complicated case at our clinic a couple of weeks back.
No, basically if you're looking at preterm infant, especially if the infant is sick, has sepsis or is admitted, immediately at birth, unless and until you got clear-cut suspicion or you got an ambiguous genitalia or a marked hypokalemia, it's not a good idea to be screening them for CH. You might perhaps wait for a week or wait till they reach at least 2 kg of weight. In Western countries, there are actually a couple of studies which have looked at day-based nomograms for 17 OHP, but we do not have Indian data. You can perhaps look at the Western data.
Okay, sir, actually this case I'm talking about was born at 34 weeks. They had a DBS value of greater than 20 immediately after birth. So they actually, suspecting this to be false elevation, they repeated the test at 40 days of life.
Yeah.
Even then it was greater than 20 on DBS, and on normal blood testing they found 24, 17 OHP. So any interpretations, there was no ambiguity at all in the patient.
If there is no ambiguity, then it's very unlikely that this would be of matter. There have been some reports and some studies where non-classical CH, was this a female or a male?
Female.
And sometimes female infants with non-classical CH can manifest high 17 OHP in the first couple of months of life. It settles down and they can present with premature pubarchy later on. Right now, if there's no ambiguity and there is no electrolyte disturbance, I don't see any reason to do anything further.
So,
and secondly, a lot of times people can have maturational defects of ACTH. They can have maturational defects of the other steroid hormones because the adrenal cortex does not become fully functional in a neonate till the 21st day of life. This has been extrapolated from mice models.
Okay.
So in this situation where you do not have any consequences of adrenal insufficiency of CH, you don't need to look further, you might just keep the child on follow-up. Okay. And if she really has a CH, she is going to present at 6 or 7 years of age with a pubarchy.
Okay, thank you very much, sir.
You have given some cutoff of testosterone to androstenedione ratio as a monitoring tool.
Yeah.
So is it valid across all ages of CH or only after the ovarian function sets in?
No, it is valid across all ages and also for men. So because it is valid across all ages because you are looking at a ratio.
Okay.
If you want to, I can just go back. You are looking at the basic theoretical principle is you are looking at a ratio. If your adrenal hyperfunction is more, you will have less testosterone, more androstenedione. If your adrenal function is good, you will have less androstenedione, more of testosterone in a male. If you are looking at a female, it remains the same. And if you get a pubertal female who also has PCOS, then in that case the testosterone level is going to go up because you are getting increased testosterone from the ovary. Because you are looking at a ratio, this is applicable across all stages of life. In fact, it can be done even in a woman who is in the reproductive age or who is menstruating. There is no hard and fast rule that this can be done only during the follicular phase. You can even do it during the luteal phase. And secondly, this ratio in a few studies has been done at any time of the day. You can do it in the morning, you can do it in the afternoon, you can do it in the evening because both androstenedione are going to decrease, testosterone are also going to decrease. That is the advantage of doing a ratio.
Thank you.
Sir. Hello.
Yeah.
Hello.
Yes, sir.
Please enlighten us something on the more confusing entity, non-classical CH in both male and female.
Sir, male non-classical CH is not a major problem. At best, they are probably going to be more hirsute and they might present with early male pattern baldness. It's not a problem in the male. The only situation where you would have a problem is if a male with non-classical CH marries somebody with another patient with CH. Male who is unaware that he has CH marries somebody with CH and you get a compound heterozygote with very little native enzyme activity, they can have a child with classical or salt wasting CH. In a female, presentation is usually of two forms. One, they'll either present early in life with hirsutism, what is typical presentation of a premature adrenarche, or later on in life they can present with a PCOS-like picture and decreased fertility. Please remember that in non-classical CH, many a time, they will not have any problems with conceiving. The main problem comes with recurrent pregnancy losses. It is not as major a problem. Fertility and conception are not major problems in these women as opposed to somebody you'd see with a classical PCOS. It is the fetal loss which is more important. IVF also, you don't actually, except in the very severe cases, you don't need a lot of intervention with IVF.
The other situation where they have a problem is, these are some of the classical presentations of what is called the so-called lean polycystic ovarian syndrome. Many of the lean PCOS are actually not lean PCOS. They are CH, and it is very difficult to pick this up if you depend only on a 17-hydroxyprogesterone. This, for all practical purposes, is the least problematic of all the variants of CH, and that is why we don't speak much about it, because it's not life-threatening.
Thank you, Dr. Nagesh, for that engaging discussion. Big round of applause for Dr. Sri Nagesh. We now move on to our next section of discussion and talks, which is the adolescent clinic, and I'd like to request Professor Ashraf Ghani.
Good afternoon, everybody. At the outset, let me express my gratitude to the organizers for inviting me to this beautiful city and very new auditorium. I have been assigned the topic of deliberating on adolescent PCOS. So we know polycystic ovary disease is now commonest endocrinopathy globally, and there is an epidemic of this disease in the country. But there is still a lot more to be learned despite of a lot of research papers coming on this. The PCOS is described as a generic disorder. It has a broad spectrum of presentations from metabolic to reproductive dysfunction to abnormal ultrasound, and it has been variously named. There are so many names which have been given to it, but still it is PCOS. It is actually not a new disorder. We know that it has started in 1844 from Charu's description through Steen and Leventhal's description. So, the lot of research papers which have been dedicated to the PCOS condition have come up after Steen and Leventhal in 1935 described it as a reproductive dysfunction. So there are almost 200 million hits on the web of science today on this disorder, because from pediatrics to geriatrics, if you can see, dermatology, gynecology, endocrinology, diabetology, cardiology, geriatric, every department, psychiatry, every department sees these cases depending upon the presentation, depending on the stage of life patient comes in. Although there is predominant symptom in reproductive dysfunction or cosmetic dysfunction at younger age, but as life goes on, you have a lot of metabolic dysfunction. So acne, acanthosis nigricans, androgenic alopecia, and even infertility are usually the initial presentations. Even the ultrasonographic findings bother lot many young women. But as we go on, we have significant metabolic dysfunctions. So I would like to actually tell you that in adults we have three sets of diagnostic criteria: NIH criteria, Rotterdam, and AEPCOS. But as you see that NIH needed only two things to be present: oligoovulation and hyperandrogenism, while as Rotterdam said we should use ultrasound also. AEPCOS said no, we should have both, two of the three, but hyperandrogenism is a must. Now if you see how it differs from adolescents, a lot of people have come and tried to modify in adolescents. First was Charles Sultan, who said that you should have two out of the three criteria. So he included insulin resistance and suggested even polycystic ovaries. But subsequently scientists criticized this, and an international consensus by pediatric and adolescent societies said no, we should not use ultrasound. However, we should differentiate it between the physiological changes of adolescents. That means you should have menstrual cycles more severely affected than what is the normal presentation in the pediatric. So the Pediatric Endocrine Society says that you should have, if you have abnormal uterine bleeding, after the age of 1 to 2 years, if you have hyperandrogenism or if you have severe hirsutism, severe acne, then you should consider it as PCOS. But the problem is, if you take menstrual cycles, for example, this is a recent, very nicely written review by one of the important groups. In menarche, it is very difficult around menarche to make a diagnosis, but if you are just 1 or 2 or 3 year post-menarche, you need to have presentation of menstrual pattern and clinical or biochemical hyperandrogenism to make a diagnosis. Ultrasound is not required in adolescents. So if you see the interval, menstrual interval of 21 to 45 days, 3 years post-menarche, or if you have primary amenorrhea 3 years after thalarchy, or if you have irregular cycles more than 90 days longest interval, then you should consider it as PCOS. And if you are little more than 3 years of age, then the interval of less than 8 cycles may go like adults. What I would like to tell you here, actually in adults, we say that more than less than 8 cycles per year. Also we need to revise because sometimes the lower limit of cycles, less interval is not included in most of the criteria which have been published globally. So similarly in hyperandrogenism and biochemical hyperandrogenism, there have been significant leads in the recent data. In fact, our own publications, we see that it is not going to actually be universally acceptable. And menorrhagia also is very important thing in young women, and more than 33% women have been shown to have in hospital admissions and they actually have PCOS. Now we have to look for early signs of PCOS in these adolescent girls, then only we can think of having criteria. We know that oligomenorrhea, hirsutism, acne or weight gain with features of insulin resistance should be actually considered, and they can be early signs and you should follow these people. Accordingly, you people have suggested that you put them at risk for PCOS. So the younger girls who do not qualify the criteria, adult criteria, you put them at risk. For example, if you have isolated menstrual irregularities, no signs of hyperandrogenism, you should consider this as at risk. If you have hyperandrogenism and regular menstrual cycles, means only one form, or if you have both, but they are in the first 1 year, all these 3 categories, they are at risk for PCOS. Now, if you have 1 to 3 years post-menarche, then if your cycles are between 21 and 45 days, but you have hyperandrogenism, this is at risk. Again, if you have metabolic syndrome and then some menstrual, these are at risk. Otherwise, if you have menstrual cycle irregularity with hyperandrogenism, they qualify the criteria. So we, in our clinic, most of you must be seeing this type of population coming to us. So, at-risk population needs to be followed, and there is no significant research available with us today. If you see, this is what is our own cohort of 6,000 PCOS women, where we have almost 2,000 adolescents enrolled. And if you see the PCA analysis shows that there is a category, this green category is what we have labeled ourselves as pre-PCOS. This data is this time with clinical endocrinology. It is going to be published soon. And what we have shown that actually these monosymptomatic farmers, or we can say partial phenotypes, are the women who actually they are more common in the adolescent age group. And they do not qualify full criteria, but they have a lot of metabolic abnormalities. So these are the women who need to be followed for full-fledged, full-blown syndrome of PCOS. So accordingly, if you see what are the current criteria for diagnosis of PCOS in adolescents, so if you see, there are some considerations which have to be taken into when we see elevated testosterone and free testosterone, or if you have bioavailable testosterone or free androgen index, or sometimes you have other androgens like DHEA and androstenedione, you need to have very high quality assays available. So chemiluminescence or electrochemiluminescence most of times creates a lot of issues. LCMS is now today considered to be the gold standard. So if we are using LCMS here, then we may think of having these criteria as better. Another thing is if you clinical hyperandrogenism, you know the problem of hirsutism scoring. There is a lot of subjectivity in this. There is ethnic variation, and people have now suggested that you should have a hirsutism score of more than 8 in the Caucasians. And suppose in Chinese women they have taken more than 4. Some people have taken 6. So the most of the populations have between 4 to 6, and we need to take ethnic specificity into consideration. Then another thing, the oligoannulation, which is more than 35 cycles and less than 8 cycles, there is good enough for adults. But when we see ourselves, our own data, this is also needs to be seen, because this is highly suspicious of PCOS, but sometimes you may not have this correct, because some PCOS women may have even regular cycles. So their progesterone level should be taken as a support for this. Then ovarian morphology, we know now, we have methods, we have the transducers who have higher frequency, and we have transabdominal versus transvaginal. So if you are using transvaginal with a 8 megahertz probe, more than 8, then you need to take a cut of 12 follicles rather than 20 follicles rather than 12. In fact, some people suggest we should have a 24 cutoff. But what I feel that if you are using a transvaginal probe, in that case, and you have transvaginal probe and you have a transducer frequency more than 8, this is very common, 20 follicles. The volume has not been changed by people, but I think when transvaginal probe is used, even volume changes. So these considerations have been taken in adults, and when we come to adolescents, this story becomes a little more complicated. Now, 2018, the Australian group published guidelines. They call it as international consensus-based guidelines, evidence-based guidelines. But if you see that when they saw the evidence, a lot of data was available on PCOS, but it was a very low quality data, especially in adolescents. It cannot be made as a plank for the evidence base. So what I mean that we need to have new data generated in them, in adolescents, taking these variables into picture. For example, even hirsutism spectrum, even a spectrum of acne, then these probe variations, then variability of ultrasounds, and so many other variables which come into ethnic specificity into picture. We need to have a lot of data generated in adults as well as younger population to generate the curve, what is called RS scoring system, or we need to ROC curve for taking the proper cutoffs. But the problem with us today is, if you see the all global data, whatever data is available, it has a significant variability. And the studies available are very small. The cut-ups used are different, assays used are different. The subjectivity has also entered into this problem. So we know that PCOS is itself otherwise complicated, because when you make a diagnosis, it is a diagnosis of exclusion. So on one hand, you have to rule out so many disorders. It is not only these 6 conditions which we say: hypothyroidism, Cushing's, non-classical CAH, androgen exposure, or even hyperprolactinemia. No, there are many other conditions you can see which have to be seen and ruled out before you make a diagnosis of PCOS. And when it comes to making a diagnosis of PCOS, at that moment you have to use very uniform and robust clinical, biochemical, imaging, hormonal methodologies. So we at ICMR are trying to circumvent these issues by using this multicentric uniform protocol, uniform methodology into this studying the PCOS across at least in our country. So we have this time currently 20 centers enrolling PCOS. We have tried our best to maximize the uniform methodology. We have trained the staff, we have put the proforma there, we have tried to keep same ultrasounds, we have kept single hormonal assay method, and with also taken those cut-ups. So probably this data, which will be available in it will be in public domain in next few months. And I'm sure with their data, at least in our country, we'll be able to see what should be the normal menstrual pattern, which should be the normal FG score cutoff, what should be the ultrasound follicle number, what volume should be used to make a diagnosis, because we have taken a control arm also, we have taken the PCOS arm also. But here I would like to tell you one important finding. I have not deliberately shared our data this time because it is under publication and scrutiny. I didn't want to share it. But I would like to tell this time, we have seen significant number of people, at least 5 to 7% of women who do not fit into PCOS criteria. Any of the classical criteria, whether it is Rotterdam, NIH or PCOS, but when we see these women are not normal, they have significant metabolic or biochemical abnormalities. So that alarms us. So that condition this is an intermediate group which is being missed out by current criteria. This is probably what we call as pre-PCOS, and this is a group which, at least in our country, in India, we need to have a method of picking up those women so that they are not missed all along till they have very advanced metabolic dysfunctions. So we know the reproductive abnormalities. We know many problems are there: hyperinsulinemia, glucose intolerance, dyslipidemia, obesity, hyperuricemia, NASH, subinflammation, hyperhomocysteine, procoagulant, mitogenesis. So these problems do happen in all adults, but if you talk in adolescents, they are very in a very unmanifest or unrevealed way. You need to have very robust method of picking up these abnormalities. You have obesity. It is not very common in India. We have, although very lean women, but we have a very exaggerated insulin response to glucose. We have very high glucose intolerance in adults. Almost 50% of women have glucose intolerance. Vice versa, diabetic women have high prevalence of PCOS. And what is very important is our women have high inflammatory markers. And these inflammatory markers are very common, higher in vegetarian women in the country. So we have also seen, one of my DM students has shown that we have higher NASH in these adolescent girls. And I think Dr. Shamanti is here only. She presented this somewhere. So we have also seen that there is NASH seen globally, and our prevalence is almost similar to this. We have seen urinary albumin leaking at a younger age in these adolescents where your glucose is normal and you have markers of cardiovascular dysfunction and you have psychiatric abnormality. You must be knowing already that these are there, and most of these problems are actually displaying a phenomena of tip of iceberg. And this means that if you have a 200 million women having PCOS in this country, that means you have majority of them are not coming to the clinical attention. So some people have tried to phenotype PCOS women recently into reproductive and hyperandrogenic category. I just wanted to tell you that this is other way of thinking at seeing the abnormality in these PCOS women, and this phenotypic may be very clinically useful for the gynecologists or endocrinologists. There is a variation in spectrum. I will not talk about those. There are the metabolic dysfunctions even in the male members. We call it male PCOS. So even fathers and sons have metabolic dysfunction. So horizontal transmission is there, vertical transmission is there. And because of these comorbidities, we have high burden on the economy on PCOS, and when PCOS, I consider PCOS as other form of diabetes. So the diabetes epidemic in this country is possibly closely related to PCOS. It is not that diabetes is caused by PCOS, but what I feel the transgenerational risk because of PCOS, the babies which are born to these mothers, whether male or female, both have metabolic traits of PCOS and they turn diabetic later on. So regarding management of adolescents, we know that management today is done because we do not know the cause of PCOS. It is done problem oriented, whether you have hirsutism, whether you have acne, whether you desire pregnancy or you don't desire pregnancy, accordingly treatments are there. You know, all of you know that. But what I here want to stress on is Indian phenotype, little differences which we have observed. What is that? Globally, this is a recent review in the Lancet, which was published by Helena Teed et al. So they, as well as endocrine's international guidelines, which they published in 2018, as well as Endocrine Society of US, all these societies, including the gynecological societies, suggest that oral contraceptive pills are the treatment of choice in PCOS women who desire pregnancy, who don't desire pregnancy, and especially all adolescents. So we have a problem there. We say that the lifestyle, whether it is in the form of physical activity or whether it is in the form of nutrition, remains the first treatment in PCOS, and whether omega-3, whether fenugreek, whatever diet modification is, cinnamon, symbiotic juices, and other issues have been shown to modify the gut microbiome. I will not go in detail. All these things should be the primary treatment in adolescent PCOS rather than giving oral contraceptives. Now, oral contraceptives are used almost 1/3 of teenage girls in US. Now, long-term benefits versus adverse events, there is very little data. Cochrane review on this issue shows that oral contraceptives may increase HDL but do not change any other thing. So they say that oral contraceptives are first drugs of choice because they want that the unwanted pregnancies, premarital pregnancies in adolescents with irregular cycles in US is very common. So it also decreases the hair growth, it also decreases acne, it regularizes cycles, and satisfaction rates with these women are very high. So they give it as a drug of choice. But there is a concern with us. What is that? Our own 3-4 publications, you can see, we showed that all the inflammatory markers, all the procoagulant markers like ICAM, TNF-alpha, MCP1 and many other markers get increased in women with PCOS, and when you give them oral contraceptives, they go very high, and that actually increases the risk of both arterial and venous embolic phenomena. So this risk is not related to the genetic polymorphisms. It is just because the drug is causing it. And if you see, the Cochrane review does not include studies. They have not studied inflammatory markers. They have just studied hyperandrogenism. They have just studied cycles and acne. So because of that, even then they say that we cannot conclude that OCPs versus metformin or versus other anti-androgenous OCPs have more risk. But the data which I just showed you, this one, it is a little alarming because it might cause the increased arterial events, it might even cause a risk of various malignancies to go up. Unfortunately, a consensus has been given by our Indian group. They have said there is a consensus, and they said oral contraceptives are drugs of choice. But the consensus is just because some experts have said together, and there is no data, which they have not included our data in this consensus. So if you see, Endocrine Society says that you use metformin only in people who have glucose intolerance or diabetes, and they also say that you don't use metformin for those people who have dermatological manifestations. Now if you see AEPCOS, Androgen Excess PCOS Society also says almost same thing. They say that if you have bariatric surgery for more than 40 BMI, and they also say that you don't use metformin for the dermatological manifestation. But if you see metformin, many publications have come in metformin in PCOS. In fact, a country like UK, there is a off-label use of metformin has gone very high. You see, because the metformin has a benefit on metabolism and insulin resistance, so it has gone very high. This, one of our papers which was quoted in NEJM, a commentary was written on that. We saw spironolactone and metformin having equal benefits on insulin sensitivity as well as hyperandrogenism. Same way, thiazolidine dionuns in metformin intolerant can be better. And anti-androgen, especially spironolactone in low dose, also improves insulin sensitivity. So, there are other drugs like N-acetylcysteine, inostols, but if you see the recent meta-analysis shows that metformin is superior to many drugs, and anti-androgen is also superior. If you combine them together, they are better, and oral contraceptives cannot be first-line drugs in adults and PCOS as of now, today. So we need to generate more data, we need to have more trials to say whether we recommend OCPs as first-line in Indian PCOS. So I would like to conclude that PCOS we know is the commonest non-communicable disease. It is not different from diabetes, coronary disease. It has a phenotypic spectrum. We should not ignore those partial ones who have just monosymptomatic presentation. These women need to be followed, and only time will tell you whether they have full-fledged PCOS. The metabolic complications, long-term metabolic complications need to be seen. These women need to be on surveillance always, and although it is difficult to follow these patients, but we should have a mechanism to see that after they conceive also, they complete family, they should still be on follow-up. In treatments, PCOS, adults and PCOS should not actually be put on long-term on oral contraceptives. If you use oral contraceptives, short-term courses may be better, and we need to have evidence rather than consensus on this issue. Thank you very much.
Thank you, sir, for the illustrative and this session. Now, the question answer forum. Any question from the audience regarding the topic?
Since we have the PCOS man of the country, can I make a couple of comments?
Sir, please.
Yes. One is about hypothyroidism needing to be excluded. I feel if its hyperandrogenism is part of my diagnosis of PCOS, I don't feel the need to exclude hypothyroidism, my comment. The other part is the relationship of hyperandrogenism with acne. I do understand we signify by this the more severe forms of acne, but still I feel hirsutism remains a more honest representative of hyperandrogenic state than acne. This is just my comments, maybe your take, quick take on
Very, very well taken, sir. Absolutely. Hypothyroidism, unless it is very gross hypothyroidism, I think subclinical hypothyroidism is very common with PCOS. So, and we have also seen one paper in fertility sterility, we have shown that subclinical hypothyroidism does not impact anything except some insulin resistance may increase. That's correct. Any other? Yes, sir.
Sir, hypothyroidism need to be excluded because it can cause secondary PCO. So we need to rule out hypothyroidism and treat first and see that whether the morphology of
PCO morphology in the ovaries. PCO morphology in the ovaries, but not PCOS if I include hyperandrogenism as part of my spectrum.
Sir, you have seen that, you have said that the prevalence of PCOS is in reproductive age group is growing day by day. So what could be the reason other than the genetic reason and the phenotypic and the lifestyle factor?
Yes, correct. We feel that PCOS, we are now studying, we have taken a new phase for PCOS through ICMR. We are studying how the reasons of PCOS, actually pathogenesis. Genetic component is definitely there. So if you must have seen in your clinics, if a mother, father comes for diabetes, you check their children. They will have, both male as well as female, will have same traits. Daughter will be having PCOS. We generally do not look towards those components, especially males. They have androgenic alopecia, their semen count is low, they have gynecomastia. And if you see their metabolic function, that is low. So genetic component is definitely there. But now, what is the environmental factor? This is very important. Changes in gut microbiome have been documented. We think the endocrine disruptor chemicals, use of plasticizers, use of hormones in chicken, in our food, adulteration is one of the dominant features. Of course, our eating pattern, sedentary lifestyle is additional, but what can be done, modifiable factors have to be identified. So we are studying gut microbiome, we are studying endocrine disruptor chemicals now. It is more common in our country. PCOS is very common. Chinese paper came, they have shown a prevalence of 6% by Rotterdam criteria. In America and Europe it is between 4 to 6%. Now our data which we are now compiling, it will not go less than 21% by Rotterdam. And that means every fourth woman has a PCOS, which we say by international criteria. The way we are seeing that these partial forms are there, the percentages will go up. So we need to understand the pathogenesis. Thank you.
What is your take about the role of myoinositol in PCOS?
Sir, thank you very much. We deliberately skipped those papers. There is a meta-analysis on myoinositol, dihydroinositol versus metformin. They are not superior to metformin. They are also having insulin sensitivity. There are 2-3 problems with them. One, they have to be taken in high dose. Second, they are expensive and they cannot be the first. So, berberine, myonostols, NAC, all these are third line drugs after metformin. If there is a metformin intolerance, I think glutazones will take second place, then these will take third place.
I have another question. So, with regards to AMH level, is it just a biomarker for PCOS or it has some role in the pathogenesis as well?
Yes, now some papers are coming up that AMH may have a role. Yes, it is actually the polycystic ovarian morphology which is coming up. It has a role there, but it does not have a role in the metabolic dysfunctions the way insulin has. We also don't know whether insulin is the cause or effect of this whole pathogenesis in PCOS. But insulin is a very important player. But the AMH may have a role, but only about altering the morphology of ovary.
Sir, your comment on DDT as one of the causative factors rather than the plasticizers as the causative factors for PCOS, because given the fact that India is the country with the largest prevalence of DDT usage.
I couldn't get your question.
DDT, sir. Rather than among endocrine disruptors, the role of DDT in the causation of PCOS. Because we are the world's largest producer of DDT and DDT and its metabolites have major aromatizing effects.
Yeah, I think DDT is supposed to be banned in this country, but it's still being used. No,
we are the only country which has banned.
Yes, it is actually banned on this. So, Endocrine Society of Europe as well as Endocrine Society of US put endocrine disruptor chemical research as the top priority. United States Scientific Task Force also has put it as top priority. Unfortunate thing is that the endocrine disruptor chemicals, we try to make a network of studying this. There are more than 300 types of chemicals. Then there are genetic variants in those enzymes which are involved. Then there are these chemicals, they have various modes of Thomas. So from pesticides to plasticizers, so many things. So DDT also has many metabolites. It is not DDT itself, it is metabolites. What has been studied commonly is bisphenol. Not many other things have been studied. Actually studying them is a very huge task, but what is important is just curtailing their use. The market, it is a corporate, it is a tussle with corporates. It's very difficult. Government has to do something for this. Policy planners have to come and do something, because you cannot do research. We made a network and we got a negative, some feedback to forget about, don't do this type of study. It was a government agencies told us, because there are many conflicts with the corporate world. So DDT is one of them. Somebody who's marketing it is not being banned. Thank you very much.
I think there is no more question from the audience. Thank you, sir. So the next session by Professor Dr. Nilanjan Sengupta, and the talk is how case-based approach to delayed puberty.
A very good afternoon. At the outset, I thank Dr. Parthapratim Chakraborty for giving me this topic to deal with, that is delayed puberty. So this type of patients we come across quite often in our endocrine practice. A 15-year-old boy being brought by the parents with the complaints of non-development of secondary sexual characters. He is also shorter than his peers. There's no history of any chronic illness or chronic drug intake. And he also has a family history in that his mother had delayed menarche. What actually are we dealing with? Is it really delayed puberty? First we have to decide. After we have decided if it is delayed puberty, where is the lesion, where is the pathology, and what's the etiology, and then comes the management. So, just to refresh our knowledge, what is delayed puberty? How do we define? It is diagnosed when there is no testicular enlargement in boys in this case, or breast development in girls at an age that is 2.5 standard deviation later than the mean age of that ethnicity. Traditionally, the working diagnosis would be 14 years. So this boy, 15 years of age, with no pubertal signs, definitely is suffering from delayed puberty. Now, puberty occurs due to the effect of certain hormones, right from GnRH, the gonadotropins, and the testosterone. And in a boy, the problem can lie anywhere in this hypothalamo-pituitary gonadal axis, so that pubertal delay occurs. Coming to central delayed puberty, there may be developmental defects of the GnRH neurons where very many genetic transcription factors are implicated. There may be problems with GnRH secretion, Kallmann syndrome being an important cause, the prototype. There may be GnRH resistance, even that may have a genetic basis, and defects in gonadotropin secretion as well as gonadotropic function, and here also very many transcription factors may be implicated. So, pubertal onset in boys, apparently puberty occurs at around 10.8 years in Indian boys, and gonadarchy around 10.9 years. We must note, unlike in girls, being overweight can be associated with pubertal delay in boys. On the other hand, obese girls attain puberty maybe 6 months to 8 months earlier than their non-obese counterparts, and here leptin may have a role to play. So how do we understand that the child has indeed entered puberty or has not entered? These are the important discriminating features: a testicular length of more than 2.5 centimeter or a testicular volume more than 4 ml, a serum testosterone concentration exceeding 50 nanogram per deciliter, a pubertal LH response to GnRH stimulation, and a pubertal pattern of LH pulsatility. Now coming to the etiology. This pubertal delay can be caused by hypogonadotropic hypogonadism or hypergonadotropic hypergonadism. Indeed, it is not much difficult to differentiate between these two entities, as I will show you. But when it comes to hypogonadotropic hypogonadism, the possibilities may be 3 broad groups. The commonest being constitutional delay in growth and adolescence, then functional hypogonadotropic hypogonadism, or permanent or congenital hypogonadotropic hypogonadism. Again, when it is functional hypogonadotropic hypogonadism, that is associated with certain chronic illnesses, chronic debilitating illnesses, the diagnosis may be writ large on the patient. When it comes to certain intracranial SOLs, history of pituitary irradiation or cranial irradiation, the diagnosis is pretty straightforward. But this is an exhaustive chart of the common and uncommon causes of hypogonadism, including certain syndromes like the Chart syndrome, then also Barrett-Biddle syndrome. Syndromic causes also are rather easier to find out because of the constellation of the abnormalities. And of course, we have the primary hypogonadism typified by Klinefelter's syndrome, and also the functional causes. Now, having said all this, what an endocrinologist really faces a dilemma in is to segregate cases of CDGP from idiopathic hypogonadotrophic hypogonadism. And separation of these two, or proper diagnosis, is also important at the same time because the treatment approach would be a little bit different. But I must admit that at the present moment, I cannot offer a single test that can reliably distinguish between these two rather common clinical entities. Many a time, therefore, when you are entertaining a working diagnosis of constitutional delay, masterly inactivity with watchful expectancy would be the best therapeutic strategy. Maybe in this child, following up the patient up to the age of 18 years, because we can expect a delayed pubertal growth spurt and catch-up growth, and you may not need to do anything further. But on the other hand, if you find that the child is approaching the age of 18 years and the testicular volume has not increased, then you have to entertain other alternative diagnosis. So what is constitutional delay in growth and adolescence? It has been traditionally described as a variant of normal growth pattern, the extreme of growth at the extreme end of the spectrum due to maybe what is called a lazy pituitary or a delayed maturing axis. Males seek medical assistance more often than females. Family history may be present. If you plot the height actually follows the fifth or the third percentile. It is parallel to it, and the growth rate is normal for the bone age. Interestingly, onset of adrenarche here is also delayed in contradistinction to hypogonadotropic hypogonadism, where adrenarche may occur normally. But is it really a physiological normal variant or something else needs be examined? Because first thing, this problem may start from early childhood, but it is most manifest during the early teens because of the absence of the pubertal growth spurt, when the difference from the peers becomes most prominent. There is usually a delayed pubertal growth spurt and a catch-up growth true, but the ultimate adult height in many cases of CDGP is actually less than that predicted by parental height. On the other hand, isolated hypogonadotropic hypogonadism also affects males. The height may indeed be taller if this hypogonadism is untreated or there is delay in initiation of treatment. This child may eventually turn out to be tall with unicoidal body proportions, which is unlike the case in CDGP. Adrenarche can occur at a normal age, and if you can document anosmia, things become easier. And here we should also look for associated malformations like single central incisor, cleft lip, cleft palate, or other morphologic abnormalities, or certain abnormalities pointing to certain syndromes like Bardet-Biedl. So this is a useful chart differentiating CDGP from functional hypogonadotropic hypogonadism and permanent or congenital hypogonadotropic hypogonadism. Mind it, bone age doesn't help much because in both CDGP and FHH it may be delayed by 2 years. Family history is present in CDGP. One important test, GnRH stimulation test, also will be not of much help. It can only denote whether the child is approaching puberty or not, but a test that has been recently proposed, which may have some value, is either the inhibin B on its own or a dynamic test that is FSH stimulated inhibin B. A threshold of 116 picogram per ml probably has 100% sensitivity and specificity for denoting pubertal onset. As I was telling, the long-held belief that CDGP is a physiological normal variant of growth pattern, but recently certain genes have been implicated in the causation of CDGP. So it may not be actually a physiological variant, rather a subtle pathologic entity which we are yet to pick up. But time has not yet come, probably, for blanket genetic testing if you suspect CDGP, but in near future the things may change. But for other diagnosis, if you entertain, like Kalman syndrome, you can take recourse to genetic testing. Yesterday we heard very eloquently from Dr. Sarda about how can we order genetic tests, appropriate genetics tests to help our clinical diagnosis. There are other transcription factors like leptin gene, TAC3, GnRH, FGF receptor 1, and so on and so forth. I won't go into the details of genetics here. Now, this is a busy slide. You may not be able to view it properly, but this is a very useful slide for the beginners. What are the workup schedule would be for a case of delayed puberty, starting with looking at the growth pattern, the Tanner staging, looking at the gonads, the bone age, the baseline biochemical investigations in gonadotrophins, then of course going for sophisticated dynamic tests, as I have mentioned, where necessary, and even genetic testing. These are two algorithms. I think the second one is better. So if you get a child like this, as I have discussed, you start with a basal serum LH FSH, because that can discriminate between a hypergonadotropic hypergonadism from hypogonadotropic hypogonadism. And if you have suggestions of the Klinefelter syndrome, you proceed further with appropriate investigations. Now, if you entertain a diagnosis of hypogonadotropic hypogonadism, again, you try to find out the cause, and I told most of the time we endocrinologists will end up trying to differentiate between idiopathic hypogonadotropic hypogonadism from constitutional delay in growth in adolescence. Now the question would be when to go for neuroimaging, when to go for detailed genetic testing. As I have said, if you have a high priority diagnosis for CDGP, you can wait and watch and observe the pubertal development and then take a decision. Now, what are maybe the objectives of treatment of delayed puberty? First, you have to determine the site and cause of abnormality. Then you have to induce and maintain the secondary sexual characters. A pubertal growth spurt is necessary for the short boys, those who are short. Prevent the potential psychological problems that may be associated with delayed puberty and short stature. Ensure normal libido and potency, and eventually attain fertility. Now let's come to the difficult part of CDGP management, whether to do nothing or do something. Many cases we may not do anything, but if the child, or more importantly his parents, are psychologically distressed by the pubertal delay, absence of pubertal changes, this boy can be offered a short course of testosterone therapy for about 3 to 6 months period, following up with the testicular volume. When you find the testicular volume has exceeded 4 ml, you can stop the testosterone replacement and allow the child to enter and proceed through the phase of normal biological puberty. On the other hand, if despite, testosterone replacement, the child shows signs of puberty but the testicular volume doesn't increase, then you can repeat a course of testosterone replacement for another period of 3 to 6 months, but not more than that, maybe totally a period of 1 year. Then you have to take a call, and if you think that the patient is not responding adequately and he is most importantly approaching 18 years of age, then you have to search for alternate diagnosis, and this child may need a long-term therapy. Coming to management of hypogonadotropic hypogonadism, of course, if you find a cause, that's good. If you do not find the cause, you have to go for testosterone replacement. It is always prudent to start with a smaller dose and gradually build up to the adult replacement dose. The commonest mode of testosterone replacement in India, the most popular one, is testosterone esters like testosterone enanthate, cypionate, or a combination of testosterone esters, because that is the cheapest and the easiest way to replace. Though in the United States, testosterone gel is more popular. It gives a more physiological testosterone level following administration, and there is less chance of increase in hematocrit on long-term use. However, in a tropical country like India, these testosterone gels may be messy. Since it calls for daily administration, there may be compliance issues and is definitely costlier than injectable testosterone esters. When it comes to hypergonadotropic hypogonadism, again, you have to replace with testosterone, and like in permanent hypogonadotropic hypogonadism, the replacement must be a lifelong affair, and you have to also keep in mind the bone health of such patients. To conclude, therefore, delayed puberty has a diverse etiology. Constitutional delay in growth and adolescence is probably the single commonest cause of delayed puberty. Unfortunately, we still do not know the exact cause. Well, while we still maintain that is a physiological variant, but subtle pathologies must be there, and this may have a strong genetic basis. The main challenge is to differentiate CDGP from idiopathic hypogonadotropic hypogonadism, and I reiterate, no single test can differentiate between these two clinical conditions. Observation with masterly inactivity not going beyond 18 years may resolve the conundrum in many cases, fortunately for the physician and the patient, because as Dr. Ashraf Ghani has pointed out, that PCOS is essentially a diagnosis of exclusion, so also the commonest pubertal delay abnormality in a boy, that is CDGP, is actually a diagnosis of exclusion. Other permanent causes of hypogonadism, be it central or peripheral, warrant long-term replacement therapy based on standard protocols. Thank you for your patience. If there are questions, I may take.
Thank you, sir, for this wonderful talk. Before coming to the question and answer forum, I would request, as we are going short of time, we can allow only 1 to 2 questions. Any question from the audience and from the delegates?
Arjun. So Arjun will be having difficult questions. Okay. Carry on.
Is there any subjective way of differentiating between CDGP and reversible hypogonadism? There is the entity of reversible Kalman syndrome or reversible hypogonadism. So, So you have rightly said that we need to follow up the patient till 18 years of age. Unless the patient becomes 18 years or older, we cannot establish a patient as a CDGP. So is there any way to differentiate between these two conditions early so that we can treat and intervene?
Yeah, as I have said, first you should be guided by your clinical impression. So you can go for the genetic testing if you have a high test probability of Kalman like hyposmia or anosmia even at the bedside, then you can go for the targeted genetic testing, and if you get a gene abnormality, that solves the issue. And again, if you diagnose also Kalman may also have a reversibility. It's not because of CDGP. Kalman itself may have a reversibility. So that's it. Or if you have suggestions towards any intracranial pathology, then you can do imaging if you are rewarded by certain plausible diagnosis. The point is that if you do a neuroimaging randomly, you can come up with a pituitary microadenoma and you get more confused than you are clarified. But if you get, suppose, an incidental diagnosis of a craniopharyngioma, that helps you to take a decision and even explain to the parents.
Thank you, Nilanjan, for very beautiful talk. And regarding CDGP in males, you have raised a point of some trial therapy with testosterone or mustard inactivity. And what about the female counterpart? If there is CDGP?
My brief by Partho was male, so I didn't. But in female, as I said, the females actually do not seek medical attention so much as males, and they are not that much disturbed by their delayed menarche. But again, there you can also, if you think as per delayed puberty or delayed menarche, you can give an estrogen challenge and estrogen supplementation followed by estrogen progesterone with a withdrawal bleeding. You can initiate that, but I think in my practice what I find, those who solicit treatment means if we get 5 cases of boys with delayed puberty and 5 cases of girls with delayed puberty, it is the parents of the boys who are more concerned and they solicit a temporary therapy rather than the girls. But you can also try for menstrual induction.
Yeah. There is failure in the first time the estrogen menstrual.
No, then you have to think whether the child is genuinely hypoestrogenic, what may be the cause, and you have to go with a further workup. And of course, local causes there also you have to keep in mind. Maybe local anatomic abnormalities of the urogenital tract.
Thank you.
So, thank you very much.
A big round of applause for sir. So the next session in adolescent clinic is by Dr. Anirban Majumdar, and the topic is endocrine monitoring in transgender youth. Over to you, sir.
I convey my sincere thanks to the organizer, and my topic is to endocrine monitoring of transgender youth, and this is my agenda. So when I looked into the topic, I thought that let me think first about whom I am going to talk about and who are the youth. So the definition of the youth, there is no any universally accepted definition across the globe, but this is the definition from United Nations, that the age range between 15 to 24 are actually youth. So I will limit my discussion between this age range, but at the same time let me tell you that I have very little or almost no understanding, no exposure of treating or managing between the age group of 15 to 18. So it means that my talk actually basically for people, those who are between 18 to 24 years. So if I look into the presentation of the transgender people in our clinic, which we have published, the Malo is here, which we have published long back. So we found that the age of presentation is around 25 years. So basically, most of the patients whom we treat we monitor is between the age group of 20 to 30 years mostly. Now, having said that, I must tell you that this is the quite late as far as presentation is concerned in our hospital. But if you look into the other parts of the world, actually the age of presentation in most of the situation is around 13 or 14 years. Now, since we have established this transgender clinic in our hospital in 2014, we have found there is a progressive rise in the transgender population in our hospital or in our clinic. And even after this, in 2023, we have looked into the age of presentation. It remains almost the same, 23, 24 years as far as the transgender people are concerned. Now, coming to how we treat the patient, so we go through the 5 successive stages or approach: psychotherapy, followed by changes gender role, followed by hormone therapy, surgery, and then the ancillary treatment. Now, today I am going to talk about this hormone therapy part only. This is not working. This hormone therapy part only, but not the hormone therapy, but I will discuss about the monitoring aspects of the hormone therapy. So, what is the objective of monitoring? Now, this is the Endocrine Society guideline. It suggests that the hormone therapy is to suppress the endogenous sex hormone secretion determined by the person's genetic or gonadal sex and maintain sex hormone level within the normal range of the person affirmed gender, and very, very importantly, it should be safe and effective. So, basically the objective of endocrine monitoring is to see whether the therapy is effective or not and whether this therapy is safe or not. And for this, we actually follow the guideline across the globe. We have different guidelines available to us, but mostly I use this Endocrine Society guideline. We have very recently the WPATH guideline, and few years back we have published our India specific guideline in 2020. Now, coming to the first part, the endocrine monitoring of the male to female. And when we are talking about monitoring means clinical monitoring, biochemical monitoring, and the long-term monitoring. As because my focus of attention between the age group of 18 to 24 years, the long-term monitoring is not an issue here. We mainly concentrate on the clinical monitoring and biochemical monitoring. So, looking into the different preparation we use for the feminizing hormone therapy, we have lot of options. But the issue is there is 2 important factors which is basically tells us about the preparation we are supposed to use. One is the side effect, that is the possibility of venous thromboembolism, and second, whether we can measure the estradiol level when you are using some estrogen preparation. So these are the 2 basic driving factors as far as choosing the agent we use in our transgender population. So nowadays we basically use either of the 2 preparation, the oral estradiol validate and the 17-beta estradiol. Now, transdermal estrogen though is possibly the best one, but is not easily available, and I have no experience of using the transdermal estrogen in our transgender population. Now, when we are looking into the clinical monitoring, we have to understand that the effect of the hormone therapy comes over a period of time, and we have to actually wait for 3 to 6 month period of time before we can see any visible change. And that is very difficult to convince these people that we have to wait for 3 to 6 month period before we get some benefit as far as the feminizing hormone therapy is concerned. So a lot of benefit we can expect with the use of feminizing hormone therapy, but we mostly are concentrated or mostly very interested, and also the patients are very, very interested as far as the breast growth is concerned. So if we give a estrogen therapy with an adequate dose for an adequate period of time, we can expect that there is a significant development of the breast. However, this is not universal. So many patients do not respond, And if we look into the data, that the stage 4, stage 5 development of breast growth occur only a small fraction of the patient, maybe 30%, 20%, something like that, varies from study to study. So it means we need to understand that some of the patient will not respond even though you are giving the estrogen therapy for a period of time, and if you actually follows the particular schedule as far as the estrogen replacement therapy is concerned. So when we are monitoring, the WPATH guidelines suggest us that we have to do the clinical monitoring and biochemical monitoring every 3 months during the first 1 year or 2 year of therapy, when you are actually progressively increasing the dose of hormone. And when you have already reached the maximum level or the target level of the hormone, and you are just maintaining the estrogen hormone replacement, then you can actually follow up every 6 months or every once in a year. So this is both for the clinical as well as the laboratory monitoring of the patients. Now for the laboratory monitoring, we need to evaluate the serum testosterone and serum estradiol level, though we do not have any universal cutoff value or universal target value across this world, but this is the cutoff, this is the target value we have discussed as far as our consensus meeting is concerned, and we have found that this is a quite acceptable range that we are supposed to achieve with the use of the feminizing hormone therapy, the serum testosterone less than 55 and estradiol between 100 to 200 picogram per ml. So when you are using this hormone therapy or cross-sex hormone therapy, not only we have to measure the testosterone estradiol, but we also measure the prolactin and the liver function test. There are many other things that we also monitor, but these are the 4 which is quite common, which usually conventionally we monitor when we are treating the feminizing hormone therapy. Now when you are treating the feminizing hormone therapy, we need to understand that we are taking some risk as well. The most important risk is basically thromboembolic diseases. Now apart from thromboembolic diseases, the cancer, coronary artery disease, all these actually happens over a long-term follow-up, and as because I am considering the patient between 18 to 24 years, I think the most important concern in front of us is the thromboembolic diseases. If you look into the literature, there is lots and lots of evidences as far as the increase in the prevalence of thromboembolic disease among the patients, among the transgender people, those who are receiving feminizing hormone therapy. But this recent meta-analysis has actually pointed out that the incidence rate is 2.3 per 1,000 person year. So it means that the absolute clinical risk is very low, and actually for the last 15 years I am treating the transgender people and I am yet to see a single case of venous thromboembolism. Having said that, I must tell you that many of my patients actually don't come for follow-up, so I don't know a significant percentage of the patient what happens to them, or whether they are still continuing the replacement therapy or not, or whether they have developed any complications or not. But we need to understand that the use of the tobacco, advancement of the age, obesity, estrogen formulation, especially if you are using the ethinyl estradiol or a mode of administration oral, this actually increases the possibility of venous thromboembolism, and therefore we need to discuss about those issues with the patient. So every patient we advise not to use the tobacco, not to gain weight. So these are the important risk factor for the development of venous thromboembolism. Now this is a very recent study which is published, and they have looked into the long-term effect of the estrogen therapy among the people who are receiving the feminizing hormone therapy, and they have pointed out that the venous thromboembolism, stroke and meningioma, these are the 3 important risks we have with the feminizing hormone therapy. There is a possibility of breast cancer, and there is possibility of fracture, and the cancer from the other organs is also possible. But as I have told you that my talk is between 18 to 24 years, so these are the issues which needs to be evaluated on a long-term basis, including this prostate cancer and osteoporosis. One of the most important challenge which actually we face in our patients is the loss in the follow-up. So as you can see, 25% of our patients, those who are, though it was published long back, so 25% the data possibly remain the same. 25% patient actually lost in follow-up, and therefore we don't have any idea that what happened to them when they are no longer coming back to our clinic again. So the second part is the endocrine monitoring of the female to male, and again it actually involves the clinical monitoring and the biochemical monitoring and also the long-term monitoring. And when we are actually treating these patients with the testosterone therapy, we found that the benefit of the therapy is very, very obvious, and it comes much before than the feminizing hormone therapy. And we have a lot of preparations. Just now Nilanjan was talking about different preparations of the testosterone which are available to us. And again, I don't have any experience of using oral testosterone, neither I have any experience with the testosterone gel, because it is not readily available in our country. We use the injectable testosterone, though different injectable preparations are available, and as I have told you that the testosterone is very, very effective, and it is very satisfying for the patient also to receive the testosterone, because they get the benefit within say 1 or 2 months of the therapy, and the maximum benefit we expect to happen between 2 years to 3 years period of time. So therefore the patient remain very satisfied, in contrast to the feminizing hormone therapy, where the patient is not much satisfied, because you can see that the breast development, which is the prime concern in front of them, happens only in a small fraction of the patient. On the other hand, when you are giving testosterone therapy, almost 100% patient remain quite satisfied with the testosterone therapy. Now when you were talking about the clinical and biochemical monitoring of the testosterone therapy, it is again of the same frequency, that is every 3 months during the first 1 year of the therapy, and followed by we actually do it once or twice in a year, because testosterone therapy is not slowly build up. Testosterone therapy, from the very beginning we start at 50% of the dose, and within a few months we give the full dose of the testosterone, and therefore by 1 year period of time actually we give the patient the full replacement dose. Now physical monitoring involves the weight, blood pressure, breast regression, facial hair growth and phallic size, but most important issue is to monitor the weight and blood pressure. Looking into the biochemical monitoring, we need to understand that we have to achieve a level of testosterone after giving the testosterone therapy, and that is between 300 to 1000 nanogram. Again, there is no any universal accepted target range as far as the testosterone therapy in trans men is concerned, but this is, we thought, is a quite acceptable range as far as different data and the guidelines available to us. Now, when you are looking into testosterone level, it is very crucial to understand when to measure the sample. Now, if you are using the testosterone enanthet or cypionate, then you have to measure the testosterone in between the two injections, in the midway. But if you are using the testosterone undecanoate, then the testosterone sampling should be done just before the next injection. And if somebody is receiving the transdermal testosterone, then it should be measured at least 7 days of continuous application. Conventionally, we don't measure estradiol routinely in our clinical practice for the trans men. Now, apart from testosterone level and the physical monitoring, we need to understand the risk associated with the androgen therapy, erythrocytosis, hypertension, and liver dysfunction. These are the 3 issues which need to be monitored in the transgender youth, and the cancer and the coronary cardiovascular disease are the long-term effects, which is beyond the scope of my today's lecture. So, we have to understand that the testosterone therapy in most of the situation associated with side effects. On the other hand, if you give estrogen, the venous thromboembolism possibility is very low. But androgen therapy in almost all patients will cause the erythrocytosis, some degree of hypertension, and liver dysfunction in some of the patients. So therefore, it is very important to screen the polycythemia very regularly, and hematocrit should be maintained below 0.54 liter per liter. And when the hematocrit rises, we have three options in front of us. Either we have to reduce the dose, or we switch over to transdermal, which is not available to our country, and the last is a phlebotomy. Now, routine cancer screening, again, as I've told you, is not a topic of my talk. It is not for the long term. When the patient is more than 25 years, then and then only you have to monitor the cancer issues. Otherwise, it is not necessary below the age of 25 years. Now, this is our observation that some of our trans men also don't come for the follow-up, but their percentage is very, very low. So my understanding is that the trans female or the trans women are actually a bit reluctant to continue with the journey. But on the other hand, trans men are very sincere. So I think it is a trait that the girls are more sincere than the boys. So that is why. So they are quite sincere as far as the treatment protocol is concerned. So regularly come for the follow-up. My last part is to talk little bit about the fertility preservation. Now, in this spectrum, when we are going to talk about the fertility, we have to talk about the fertility before we start the hormone therapy, or at least before the gonadectomy has been done. And there are many options for the fertility preservation in trans women, either sperm cryopreservation or testicular tissue cryopreservation. For the trans men, we have embryo cryopreservation or oocyte cryopreservation. So these options must be discussed before starting of the hormone therapy, but at least before the gonadectomy operation. Now, last part of my talk is little bit about the psychological health, which I consider is very important during the monitoring. You know, the literature is flooded with the possibility of anxiety, depression, and self-harm behavior among the transgender people. We don't have much data from our country, and this is the data we have, which was published few years back in a psychiatry journal. And you can see that the attempted suicide at least once before 20th birthday is among the 15% of the patient, and suicidal attempt rate in transgender person is 31%. So that is a very, very scary figure, and we have looked into our data. We had a cohort of 120 patients when we have analyzed. We have looked into the possibility of suicidal issues among our transgender youths, and we have found their average age of first suicidal attempt is 16 years. So very, very scary figure. So many people must have died before coming into our clinic or any clinic across this country. So we have the data of attempted suicide among those who have survived and who have attended our hospital. We don't have the data who have successfully committed suicide, neither we have any statistics. So with this, I would like to tell you that all transgender youth needs to be monitored as far as the psychological health is concerned, especially the suicide. And it occurs more during the early part rather than the later part, when they are already well established, when they have already going through the hormone therapy, then the possibility is much, much less. So I will conclude by taking that few take-home message. Although the hormone treatment in transgender youth is generally considered safe, the risk of complication should definitely be carefully monitored. Venous thromboembolism, though rare, remain an important consideration in monitoring transgender youth receiving feminizing hormone therapy. Erythrocytosis, hypertension, and liver dysfunction need close monitoring among transgender youth receiving testosterone therapy, and transgender youth should be counseled on reproductive issues and should be offered the option of the fertility preservation. And lastly but not the least, transgender youth of India is highly susceptible to suicidal behavior and needs continuous monitoring. With this, thank you very much for your patient listening.
Thank you, sir, for this wonderful talk, giving insight of the topic. So before coming to the question and answer forum, I would like anyone from the audience to have any question. Please.
You are fortunate enough to deal with only post-pubertal persons with gender dysphoria soliciting treatment. So I think you don't have to use GnRH analog for suppressing puberty. But that apart, when you are doing gender affirmative hormonal therapy with appropriate gonadal hormones, in how many cases you have to additionally give GnRH analog to suppress the other undesirable hormones?
If you ask me that I would love to give GnRH analog to almost all patients. But the question is that the patient can't afford it. As because the patient can't afford it, I have found some of the patient, even we discuss, they agree to start, then they take it for 3-4 months period of time, then there is scarcity of money, they stop. So with this experience, I discussed with them from the very beginning, if you really want to give it, you should give it till you undergo a gonadectomy operation. Otherwise, there is no point of giving GnRH hormone therapy. Don't take it for 3 months or 2 months period of time. It is useless. It is a complete wastage of money. So if you look into my data, you will find only 20% of my patients from male to female transition receives the GnRH. Usually GnRH is not necessary for the female to male. Only testosterone therapy is quite useful, but you can give. As far as the pre-pubertal people or the less than 18 years, I don't use any puberty blocker because puberty blocker has got lot of disadvantages. Apart from your cognitive function, then your bone, then your the penile length will be shorter, so the surgery will be difficult, and we don't know many other issues which may be associated with gonadal blocker. So I do not want to give anything, do not want to deal below the age of 18.
Thank you. My experience is that in most of the cases I don't require GnRH analogs. Rather, in some of the male to female, they are not happy with the decrease in hair growth. We have to add with the GnRH.
Yes, GnRH is from male to female, GnRH is very effective. But from female to male, it is usually not necessary. But with the GnRH, Devmallo has got more experience with GnRH therapy than me because his many patients receives the GnRH therapy.
Endocrine Society guideline, they recommend that post-puberty, I mean the adult patients, we should start with GnRH agonist to have cessation of menstruation cycle.
No,
I used in one of my patients GnRH agonist.
Yes,
for stoppage of the menstrual cycle. Then I started testosterone.
Yes, but you know that the GnRH is a costly therapy, and the GnRH, if you give GnRH, yes, menstruation will suppress. But the issue is if you give testosterone, that also suppresses the menstruation. So give a testosterone, attain the full days. In more than 80% cases, the menstruation will be suppressed. You don't have to give GnRH therapy for female to male. Usually not required.
GnRH therapy is generally not required in especially those who are going from female to males, because majority don't require, hardly couple of them. But with male to female, I think the satisfaction level with regards to is much better. And another advantage of using a GnRH, those who can afford, of course, is a lower dose of estrogen also. That may be beneficial, they can do with a lower dose of estrogen, and the target hormone levels are better attained.
Yes, if you give GnRH, quite naturally the testosterone gets suppressed. So you can achieve the testosterone target. But if you do not give GnRH, it is very difficult to achieve the testosterone suppressed just by giving feminizing hormone. And second is if you give GnRH, so quite naturally patient will have less side effects with the estrogen, because you are giving estrogen of lower dose. So side effect of estrogen will be low. That is an important advantage.
Thank you, sir.
Thank you.
So a big round of applause for sir. Coming to the next session, which is the last session of today, which is the thyroid clinic. At the first topic of this clinic is approach to indeterminate thyroid nodule by Dr. Shoham Tarafdar.
A very good evening to my respected teachers and the delegates. I'd like to thank Partho sir for inviting me to speak on this topic, an approach to indeterminate thyroid nodule. So there's a very famous saying by Sir Robert Hutchison, and this is very pertinent in the case of the approach to indeterminate thyroid nodules. Not all the thyroid nodules will require surgery, and a surgery would make a cure of the disease more grievous than the endurance of the same. So coming to a case, a 30-year-old lady presented to the endocrinology clinic with complaints of goiter noticed since last 6 months, gradually increasing in size, right side. She's not having any compressive symptoms, she's not having any concerns, cosmetic concerns, but she's concerned about the prognosis. There is no overt hyperthyroidism. So what would be the next best step? So we will go ahead with a high resolution ultrasonography, which showed a right-sided thyroid nodule, predominantly isoechoic, size was 3 into 2.1 centimeter, wider than taller, with well-defined margins, with a single echogenic foci with acoustic shadowing suggestive of a macrocalcification. And there was no internal vascularity, and the other half of the lobe was normal. There was no significant lymphadenopathy, and it was a TIRADS foldation. So what is TIRADS? So basically it's an imaging, it's a risk stratification score. So there are multiple nations have developed their own TIRADS stratification, and based on that the clinician can decide whether to go for the FNAC or not. So one of the most commonly followed is the ACR TIRADS, which is the most comprehensive, consisting of the composition, echogenicity, shape, margin, and the echogenic foci. But there is the cutoff for the TIRADS 3 or let's say TIRADS 4, the cutoff for the FNAC is a bit higher compared to the ATA guidelines, which is another score which has been used, and there are other Chinese and the Korean guidelines. So is there a comparison of the different risk stratification scores? So this is what I can find, that there has been a comparison made, and based on that, the yield of malignancy, if all the ACR TIRADS were biopsied, would be 14.2% compared to 10% in the ATA and 10% in the Korean TIRADS. And also, following the ACR TIRADS, the benign nodules which are biopsied is only 47%, and the nodules based on ATA up to 78% of the benign nodules also underwent surgery, and also the Korean, the 79%. We had our own publication in which we have shown that the risk of malignancy, which is obviously we should increase with the increasing TIRADS score, and the TIRADS score of 5 based on our finding had a high risk of malignancy, 86.66%. And so definitely a benign FNAC in the TIRADS 5 nodule does not rule out malignancy. We should go back and again redo the FNAC probably under the USG guidance. Also, among the individual parameters, we had found that the microcalcification particularly had a high likelihood ratio along with the taller than wide. So we went ahead and did the cytology of this patient. This patient had a stain smeared with follicular epithelial cells, mild to moderate pleomorphism, attempt to form a microfollicle formation, and the ATP of undetermined significance, Bethesda 3, was diagnosed. So there has been a change, this minimal change, but there is some nomenclature change which has occurred over the time. So this is the Bethesda system of reporting the thyroid cytology, first introduced in 2010, then in 2017, and this is the current iteration in 2023. So what they have basically done is that they have simplified the nomenclature without any unambiguous terms. So the Bethesda category 1, which had the term unsatisfactory, which was not really conclusive, not giving any extra information, so they had replaced it. Unsatisfaction dropped because the inadequacy criteria was already specified. That is the criteria that each slide containing 6 group of follicular cells with at least 10 cells in each group. The few exceptions to this criteria would be an aberrant colloid or lymphocytic infiltrates, which could be considered for a diagnosis. A repeat FNA. Before it was suggested that a waiting period of 3 months should be considered for repeat FNA, but there are studies which has refuted this claim, and that earlier, probably a weeks, 2 weeks would be efficient enough. And the yield is around 60 to 80%. The risk of malignancy in all this, the initial Bethesda categories, the Bethesda 1, 2, and 3, they are always overestimated based on the risk of malignancy that the Bethesda has suggested. Because all the patients who are undergoing the histopathology diagnosis, they are only considering those patients. So many of the patients who are in the benign category are not undergoing the surgery. So based on histopathology alone, there is a selection bias which is always overestimating that. In the Bethesda 2 category, the benign category, nomenclature changes a little bit. The follicular nodular disease terminology they have introduced, which includes the colloid nodule, the hyperplastic nodule, and adenomatoid nodule, all together can be reported as a follicular nodular disease. The risk of malignancy, as I suggested, is 4% if the histopathology is gold standard, but we consider that it decreases to 1 to 2% if the long-term follow-up data is also included in this. So another, probably the most important category, the indeterminates, we start from here, the ATP of undetermined significance, follicular lesion of undetermined significance. Now they have decreased it to only ATP of undetermined significance. Why is that? To avoid ambiguity, multiple naming system, and the follicular lesion is dropped, there is no practical change in the management. ATPia is more functionally subclassified into two categories, nuclear ATPia and others. Why nuclear ATPia? Because they have found that in the nuclear ATPia subgroup, the risk of malignancy drastically rises up to 50 to 60% compared to the others, which are the architectural, the prominent oncocytes, and the lymphocytic ATPia. Coming to the follicular neoplasm, suspicious of follicular neoplasm, and which has been decreased to only follicular neoplasm. Suspicious for malignancy is already a category there in the Bethesda 5. So in order to avoid the confusion, they have dropped the suspicion for the follicular neoplasm and included only follicular neoplasm. Characteristics include moderately cellular with predominant follicular cells, significant architectural abnormality including macrofollicles, crowding, trabeculae, and single cells. In order to include the NIFTP, which is previously included mostly in the Bethesda 5, this change has been done already in the last iteration. The cytology with mild nuclear changes like the enlargement, contour irregularity, and the chromatin clearing, these are included in the Bethesda 3, morely because the Bethesda 4, morely because the Bethesda 5 patients will undergo a more aggressive surgery, probably total thyroidectomy with lymph node dissection. In order to avoid that, they have done this. We should note that these patients should not have any true papillae or any pseudo-inclusions. Follicular oncocytic neoplasm contains exclusive population of oncocytes with scanty colloid and rare or absent background lymphocytes. So the Bethesda 5 and 6 has not changed much. So this is just the same. The risk of malignancy, as I discussed before, has been calculated based on histopathology data. So this data is overestimating in the initial groups of non-diagnostic benign, ATP of undetermined significance, and the follicular neoplasm. Another factor is that there is an entity called the NIFTP, which has been developed by the Nikiforov et al. To replace the encapsulated variety of the follicular variant PTC, just to exclude the term carcinoma and also remove the stigma associated with that. They are extremely low malignant potential. They are considered pre-malignant rather than benign. NIFTP cannot be diagnosed preoperatively, so that is a problem, and they can only make the diagnosis on the invasion based on the surgical biopsy. But the follow-up is less stringent and no requirement of iron-131 ablation postoperatively. So the diagnostic criteria of NIFTP has also changed over time. Before, less than 1% papillae was included in the follicular growth pattern, but some reviews have shown that in this category of patients, there are patients which are having metastatic lymph node metastasis and recurrence in this. So no well-formed papillae, the strict papillae, the criteria is also included. Also in the revised criteria, they have included a secondary criteria, which is a supportive diagnosis of BRAF V600E like mutations which are high risk to be, if they are included, so it's a high risk for the patient. So is there any way to pre-operatively predict the NIFTP? There is some basis for that. The clinical history, the physical examination, a larger nodule with invasive features at attachment to underlying structures could be a clue to the high-risk patient. USG findings, solid or isoechoic, hypoechoic nodules, oval to round, sharp, regular margin with hypoechoic rim with no high-risk features. FNSC findings, particularly most importantly, are the 3, 4, and 5, predominantly follicular pattern, hypercellular, microfollicular architecture or sheet-like, no prominent nuclear pseudo-inclusion or Samamoto's classifications. The molecular landscape has also been revised, and the molecular signature mostly are the RAS and the PAX-PPR gamma. but they typically don't have the BRAF V600E, the red PTC rearrangement, the TRT and the NTRK, which are the high risk mutations. This is one of the algorithms for the NIFTP. So the risk of malignancy excluding the NIFTP, we can see in the atypia group there's a 6.4% decrease in the risk of malignancy. In the follicular neoplasm group 7.1%, and in the suspicious of malignancy 9.1%. So what is the indeterminate thyroid nodule? Most of the indeterminate thyroid nodules are benign nodules. Up to 10 to 30% of the FNEC are cytologically indeterminate, and the Bethesda 3, 4 and 5, which constitute mainly of the benign category of nodules, are included in this. So definitely the next best step, as suggested by the ATA guidelines in 2015, that molecular testing is one of the mainstay of this. So before going to the molecular guidelines, this is just a genetic landscape of the currently which are knowing the papillary thyroid carcinoma. They are RAS-based tumors, they are BRAF-based tumors, and there are T53 TERT promoter mutations which are increasing the risk of invasion and the dedifferentiation. Currently, there are molecular testing available outside, not available in India currently. These are mostly based on the FNEC material which we can get from during the ultrasound FNEC. There are three: the Pharma, the Thyrosec, and the Thygenex Thyramir. So the molecular testing, what was the basic principle? So we either wanted to rule out a disease or rule in a disease. A rule out test should have a high negative predictive value, and this negative predictive value should be comparable to higher than a Bethesda 2, which is around 96%. And a rule in test should have a very high positive predictive value, which would be comparable to a Bethesda 6, which is having a 98%. So do we have that? Thyrosec is which is the first generation was developed, was a 7-gene panel, and in the initial iterations of this there was a high specificity but the sensitivity was low. So this was probably a good example of a rule-in test. But they were missing a lot of malignancies with these patients, with this panel. The second generation was developed, which included 284 hotspots in 12 genes, sensitivity 91%, specificity 92%, and the third generation genomic classifier. So what they have done, they have included the NGS, they have gone for the hotspot of 112 genes. So they have gradually increased the sensitivity, but by doing that, they have also lost the specificity of that. Pharma is a gene expression classifier, the microRNA based test with 167 mRNA. They had the sensitivity 92%, specificity 52%, high negative predictive value 93%. So it would have been an ideal rule out test for the intimate category. Second generation Pharma gene sequencing classifier is RNA based sequencing, which includes the specific mutations for MTC, the BRAF, V600E, the RET PTC, and this combined had improved the negative predictive value up to 96%. And there was some idea that can we do both together, both rule in and rule out together. So there was Thyrogen X, Thyramir. So Thyrogen X are the 7-gene mutation panel. Once the panel is negative, you move to the Thyramir. So including both the microRNA and the mutation-based sensitivity 89%, specificity 85%, negative predictive value was 94%. Comparison of the genetic tests available over time has the first, second, third generation. Gradually, the sensitivity has improved. Also, the negative predictive value have improved. So we are close to the very good rule-out test, but a rule-in test is still a bit dubious. The management of the indeterminate thyroid nodules. So apart from the molecular testing, so we can, based on the ATA 2015 guidelines, we can repeat FNEC. So what will happen if you repeat FNEC? We can see that there is some evidence of that up to 30% of these patients will have a repeat indeterminate nodules, and they have a high risk of malignancy. So again, we have to go for the surgery in this category of patients, but in the other 70% we'll have some conclusive diagnosis. Progress to surgery based on high-risk ultrasonography findings. Definitely, the high-risk ultrasonography findings, as I had discussed in the initial thyroid classification. So there are marked hypoechoic, irregular, microcalcification, taller than wide. All these suspicions of malignancy, these are features which have shown increased risk. In the other things, we can have the active surveillance, follow-up of nodule if molecular testing is negative, offer surgery to patients with cosmetic concerns and worrisome symptoms of a very large nodule with compressive symptoms. So the follicular neoplasm, the surgical excision is a standard of care. Lobectomy or hemithyrectomy is preferred over total thyrectomy. Molecular testing beforehand will be helpful in the determining the extent of surgery. Suspicious of malignancy, the surgical management of this category of this patient similar to that malignant thyroid nodule with or without lymph node dissection. So why not go for the obvious of total thyrectomy in all the patients and not, obviously there are the meta-analysis done which have shown that the vocal cord paralysis is higher in the total thyrectomy group. Also a related complication for all endocrinologists, the temporary or the permanent hypoparathyroidism is also higher. Any recent advances? So I'll just quickly go to the liquid biopsy part, which we have done in the study in our institute. So we had tried to find out that if the selfie DNA concentration could be helpful, or the detection of the the detection of the driver mutations could be done from the selfie DNA material. So we had done the plasma selfie DNA extraction. We had measured the concentration before surgery, after surgery, and we had also detected the individual 8 gene panel mutations. Based on that, we had initially determined the two groups, the Bethesda 2 and the Bethesda 5-6 as the initial benign and the malignant group. And based on that, we had got the cutoff of 67.9 nanogram per ml. This was further evaluated in the indeterminate category of nodules, which had 37 patients. We had a high sensitivity of 100%, specificity of 92%. Also comparing the saved DNA concentration before and afterhand, the post-surgical values were similar to the benign group. So mutation analysis was also done. The sensitivity in the plasma was around 81%, specificity 72% of the mutation analysis 8 gene, and the FNAC material was slightly higher and highest in the tissue diagnosis. This was the paper published in the JCEM and the European Journal of Endocrinology. So coming back to our patient, the patient had undergone a plasma selfie DNA estimation which came out to have 20.5 nanogram per ml, which was much lower to the 67.9 we had set. And our 8 gene panel was negative from both plasma and the FNAC material. Based on these findings, she was reassured about the prognosis, and she was not keen for surgery, nor did she have any cosmetic concern. She was asked to follow up. She was planned for annual follow-up with repeat USG and guided FNAC. So to have the practical takeaway points, a high resolution ultrasonography with thyroid score by an experienced radiologist is one of the mainstay for diagnosing thyroid nodules. And the performance of the USG guided FNAC, we should be focused by the clinician that it is USG guided or not. And the cytology by pathologists who are reporting in standard with the latest Bethesda guidelines is required, supplementing the clinical information. So clinics come first. We will not be overtly reliant with the molecular testing, and as it is not very widely available all over India, we will still be basing our treatment with the clinical information, and with the patient we have to discuss the patient's concerns or the worrisome symptoms, and considering all the evidences, we'll take the final diagnosis. So I'd like to thank Professor Sujay Ghosh for giving me the opportunity to work in this field, and thank Professor Nityapada Bhattacharya, producer, and I'd like to thank Sushmita Datta, who has worked very hard in this project. Thank you.
Thank you, sir, for the wonderful talk. So now question and answer forum. Any question from the audience?
Thank you, Soham, for that wonderful talk, and you have got a good volume of work, original work in this field. I was wondering if we have more than one nodule in the thyroid, one more suspicious than the other, we generally advise FNA from the more suspicious nodule. And supposing that turns out to be Tyrex 3 or 4, in that situation, do we go and stick a needle into the next nodule?
So basically, the ACR thyroid has suggested that individual nodule should be classified. So based on the individual risk of each nodule, we will definitely look for that. So I would not say that there are multinodular goiter, both nodules have got, both side lobes have got multiple nodules. We would not be going for FNAC from all the nodules. Probably the high risk who are meeting the thyroid criteria, let's say thyroid 3 more than 2.5 centimeter. If it is 1 centimeter, probably we will not go for that. So that is.
Thank you.
Any extra question or from the audience? I think there is no more question. So thank you, sir. Again, a big round of applause for sir. Coming to the next topic by Dr. Vagesh Iyer. The topic is new therapeutic options in thyroid-associated ophthalmopathy.
Good evening. Thank you, organizing team consisting of Dr. Shubhankar Chaudhary and the team for your invitation. Next 15 or 20 minutes, I'll take you a journey of our patient who needed therapy beyond steroids for control of her tau. So this is a brightly white 36-year-old lady presented with history of prominence of both eyes with pain and redness. She had a weight loss, tremors, palpitation to suggest thyrotoxicosis. She was toxic. She had a grade 3 goiter, bruit. Her tau clinical activity score was moderate to severe 4/7, and even a biochemistry was suggestive of a thyrotoxicosis with TRAP positivity. So she came somewhere in 2019. I think we were following the ETA guidelines of 2016. She was started on the steroids. We know that steroids are the mainstay of a therapy. IV steroids are the mainstay of therapy for a tau. So following the UGOGO guidelines, in a cumulative dose of 4.5 grams of a methylprednisolone needs to be given over a period of 12 weeks. Initial 6 weeks of 500 milligrams followed by an additional 6 weeks of 250 milligrams. But if you are dealing with the severe Graves' arboretopathy, I think we need to give a 750 milligrams. But one more caution here, not to give on a daily basis, needs to be given on alternate days. So we need to look into the contraindications of active hepatitis, patients having cardiovascular disease, any psychiatric illness. We need to use a calcium and a vitamin D to protect bones. To protect the stomach, we need to use a PPI. But most important, IV glucocorticoid therapy, the response rate is better than placebo and better than the oral therapy, and it is tolerated better because of the lesser side effect. But many patients respond initially, but subsequently they may not respond for IV glucocorticoids. Same thing happened with our patients. That's the question came, what is the next? What are the next therapies are available to use in this set of patients? Mainly we have got immunosuppressive agents. There are two classes of immunosuppressive agents. One is a specific like anti-TNF alpha agents or anti-interleukin 6 agents. Others being a non-specific including glucocorticoids like cyclosporine, MMF, azathioprine. All these things are a non-specific. What is the difference between specific and a non-specific is non-specific things just they prevent the immune system. That's the reason the chances of infection will be on the higher side. With the specific thing, what happens is they block specific pathways in the immunological system. Hence, the chances of superinfection and getting affected on the other immune systems are on the lesser system. The one which is more commonly recommended following a glucocorticoid nowadays is a mycophenolate mofetil. I think it's been extensively used by the nephro colleagues for their transplant patients. It inhibits the inosine monophosphate dehydrogenase, prevents proliferation of a B cell and a T cell, and also production of a antibody by the B cell. In addition, what it does, it induces the apoptosis of activated T cells. That's how it prevents the progress of the tau, and also it inhibits the adhesion molecules, inhibits the recruitment of the immune cells. So in the de novo pathway, it just blocks this inosine monophosphate dehydrogenase. Hence, there will be less and less of a synthesis of a purine. Hence, there will be less and less affection of the tau system. So this is extensively studied initially by 2016 or 17, but major impetus came following George Cahale's article in Lancet. So in Cahale's study, I think 164 active moderate to severe Graves' arboretopathy were studied who were steroid naive. For one group, placebo was given. For the other group, it was only the MMF was given, and what they found that at the end of 12 weeks there was no significant difference, but subsequently at 24 weeks and 36 weeks the group which had received the MMF fared better than the group which had received placebo. That's why If it is an entry-coated drug, we need to give 360 milligrams twice daily. If it is an not entry-coated, 500 milligrams twice daily, and it should be taken with the food because most common side effect is the GI side effect. If you are giving with the food, the chance of side effects are less, and by and large, it's quite safe drug. The next class of a drug which is useful being azathioprine. I think it's in use from long time, but only the experience is lacking. It showed a benefit in only one major trial, that is known as a CIRTED. It can be a valuable agent when steroids are not indicated, or when you are tapering the steroid, you can add this. By and large, lots of problems with the cell counts and liver enzymes, not very well tolerated by all population. Rituximab is the one which has been very well studied, quoted after steroids for a long time, but its use has been not very widely applicable, mainly because of the cost and also the efficacy. What it does is, it mainly acts on the CD20 expressing beta cells, interferes with the production of inflammatory cytokines which are driven by the beta cell, and it depletes the autoreactive T cells, and action starts within few days of giving and lasts for few months, anywhere between 4 to 6 months. There are mainly two studies done with rituximab, that is Stan et al. And Salvi et al. But what they have found in these studies is, if patient is younger, TRAb levels are on the lesser side. If it is a shorter duration, means recent onset of the disease, probably it works better, and it should be considered as a second line therapy in a moderate to severe case. And somebody has failed on the steroids, when you add, it works better. It's given in 2 dosages. Either you can give 2 doses of 1000 milligrams 14 days apart, or 4 consecutive weekly doses of 375 milligram per square. It roughly comes around 700 to 750 milligrams. It does have side effects, mainly infusion related complications. There can be chills, mild hypotension. Probably we can reduce this with the pre-medication, but by and large it can aggravate the IBS. Arthralgias can be encountered. Sometimes it can reactivate the viral hepatitis. Sometimes an encephalopathy has been reported in few cases, but the experience has been very limited. But one caution is, we should be careful. We should not use in patients who have got a optic neuropathy. Dysthyroid optic neuropathy, better not to be used, because sometimes there will be a worsening of the symptoms rather than a benefit. This is the next drug, teprotumumab. It's mainly on the IGF-1 receptor, because there is a crosstalk between TSH receptor antibody and IGF-1 receptor interference. So this has been recently approved by US FDA 2 years back. It mainly blocks the TSH receptor antibody where there is a crosstalk with the IGF-1 receptor. This has been studied in an optic trial where it has found to be superior to the placebo. Even on the follow-up of an optic trial, whether it's a proptosis, overall response to the CA scoring, even the diplopia response and all, better than the placebo. Given in a 3 weekly dosage over a period of 8 weeks, initial dose being the 10 milligram per kg body weight, followed by 20 milligram per kg if in the infusion. Most common side effect being the hyperglycemia. Control the glycemia, bring it less than HbA1c less than 8%, then only start the drug. Main side effects being the hearing loss, what we call it as otic changes, muscle cramps, alopecia, weight loss. There is even a cognitive decline has been noticed in some of the trials. By and large, still it is in the trials rather than widely used in the clinical practice. The next drug which is being used being the tocilizumab, which is an humanized monoclonal antibody against interleukin 6, approved for use in rheumatoid arthritis, hence being used even for TAO. There is no large randomized control trials are available, studied in the dose of 8 milligram per kg for every 4 weeks. By and large, data is quite restricted to few papers. There are other therapies which have been used, like IV immunoglobulin, response rate is close to 60%, CMXon is almost similar to placebo, somatostatin analogs, no way better than the placebo. Anti-TNF alpha, similar to the placebo. Methotrexate is there from long time. Only they have found benefit is the glucocorticoid dose comes down. So based on all these immunotherapies which are available, I think recently, nearly 2 years back, UGOGO guidelines came on tau. So somebody who has got moderate to severe active Graves' arboretopathy, I think the standard therapy remains same, 500 milligrams of intravenous methylprednisolone weekly for 6 weeks, and you can, in addition, you start using 720 milligrams of enteric-coated MMF. So if you are using enteric-coated, it's 360 milligrams twice daily, or else it's the 500 milligrams twice daily every day, and continue the 250 milligrams and give MMF for additional 18 weeks. Total duration of 24 weeks you give a MMF, then only they have found the response. If there is a good response, you can stop at the end of 24 weeks. If there is no response, move to the second line therapy. You need not try with again one more dose of intravenous steroids which was tried earlier. Somebody who has got a severe Graves' arboretopathy, we can give 750 milligrams of methylprednisolone weekly for 6 weeks. If there is a response or a partial response, followed by 500 milligrams. If there is a good response, you can stop. If there is no response, then move to the second line treatment. Second line treatment, again a second course of 750 milligrams of methylprednisolone. You can use oral or prednisolone along with cyclosporin or azathioprine. These are all based on the individual center experiences. Orbital radiotherapy with the oral IV glucocorticoids. Teprotumumab, whatever is available in the trials they have tried. Rituximab can be tried as a second line after a steroid failure. Even tocilizumab can be tried. If all these things result in the reduction in the activity of Graves' arboretopathy, we can follow up. I think what has been added greatly in the current guideline is MMF has been greatly added as adjunct to the steroids as a first line therapy and should be continued if there is a response for 24 weeks. So the combination of IV methylprednisolone with MMF as a first line in moderate to severe and active Graves' arboretopathy probably is the one biggest take home message from the UGOGO consensus 2021. And it has been found to be very practicable because the side effect of MMF is quite minimal, quite efficacious compared to the monotherapy with the steroids. Biologics, especially teprotumumab, to lesser degree even tocilizumab and rituximab hold a promise in the future if you get a good results. This is thanks to our SR in our department. Thank you for your patient hearing.
Thank you, sir, for the wonderful talk. Any question from the audience?
Yeah.
Sir, nice talk, sir. Sir, we have been relying much on the CAS or the CAS score to decide on immunosuppressives, and as you have showed that while deciding on further treatment, we need to look at whether there is partial response or no response, which I believe depends on CAS.
Yes.
But there are few patients who might not be fulfilling the criteria of active tau by CAS. But if we do MR of the orbits, there is significant inflammation of the orbital muscles. So which one do we rely on, the clinical activity score or the MRI findings suggestive of ocular inflammation?
I think should be an MRI should be used as an adjunct to the clinical. I feel solely going on the MRI. If there is a crowding around the optic nerve and all is there, still your additional second line drugs becomes less effective. Still you will be going on the steroids only. I feel it's mainly a clinical decision, further adjunct by your MRI findings. Yeah, not solely on the MRI.
Thank you.
Yes.
Do we have any more questions from the audience? Thank you, sir. Thank you so much for that wonderful talk. A big round of applause for Vagish, sir. We now come to the last talk for this hall, Hall B, on Crescendo 2023 on behalf of Endocrine Society of Bengal. And for that, I'd like to invite Dr. Oyon on stage. He'll be talking about pediatric Graves and how to diagnose and manage. Immediately after this talk, I'd request all delegates to move to Hall A, where we have the overseas speaker talk, and thereafter the other sessions continue in Hall A till maybe a little later, 8 p.m. in the evening. Thank you.
Timer. Okay, good evening all. I think we have come to the latter part of the conference here, and at the outset I would like to thank Dr. Partho Chakraborty, whom I fondly call Parthoda. It's a pleasure to be back in Crescendo again, to give a little bit on discuss this lesser discussed topic, particularly during our days, because this disease is pretty rare. As I was discussing with Deepta and Dr. Kaushik outside the hall, what is your topic? That time I understood that this is a pretty lesser discussed topic, and because it is rare. So Graves is particularly rare in children. How rare, that I'll discuss. And it is one of the most common cause of thyrotoxicosis. So whenever we are dealing with thyrotoxicosis in children, possibly we are dealing with Graves. The treatment options are same as in adults, like you go with antithyroid drugs, or you go for a definitive therapy with RI or surgery, but it requires precision because we are dealing with our kids. And it's a long affair. Why? Because the treatment requirement is much longer compared to our adults. So if you see the clinical epidemiology, it is considerably roughly 5 in a lakh of population, so it's a pretty rare condition. And if you go below 15 years of age, it is much lower incidence and prevalence it is having. But important to notice is that girls will have 3.5 times more Graves compared to boys. And if you go to below 5 years, the incidence comes to roughly 1 to 2. So it's pretty rare, and there will be no sex predilection. And how do they present? Whether they are different from adults? Yes, to some extent they are different from adults, because most of the pediatric Graves disease are biochemically overt. Rarely there is subclinical hyperthyroid phase, and most of them will have clinically severe disease. And there is some specific presentation apart from the commonest toxic symptoms like accelerated growth due to accelerated bone maturation that can occur, and school performance, deterioration in the school performance, some behavior alteration, subtle changes, and anxiety and disturbed sleep. I often receive patients from psychiatry department regarding, and whatever Graves I have seen after coming from this new institute, I have received patients from psychiatry actually. So that you have to keep it in mind. And another thing is that thyroid eye disease will be relatively less severe. Usually they do not have thyroid eye disease, and even if they are having, they don't have inflammatory features that much. And you see, they will be going to different types of OPDs to have their diagnosis, because some will have palpitation, some will have some respiratory causes, and they will go to pulmonary. So diagnosis is often delayed in Western countries also. It's not in our countries. So after seeing that they are clinically different, immediate point comes in mind whether whether in the pathogenesis or something is different, particularly genetics. Why these people are having more common, they are developing Graves at a little bit earlier phase rather than the older one. So this is a very interesting study which has seen the allele frequencies of 40 common Graves related genes, and they have found these 3 genes particularly important, and I will discuss about HCP5 little bit more. So this HCP5 is an RNA gene which is related to the MHC1 complex, and that is related to the autoimmune T cell activation. So in another study in recent times, it has been shown that there is a particular polymorphism, that is that RH3094228, that in the HCP5 allele, which gives more predilection to develop Graves' disease in a younger child, and this is HLA-DR B103 independent. But this gene has to prove its causality in future and has to come through the cellular studies, cellular biology, that this is really causative of Graves' disease. But definitely there are some certain genes which will predict our children to develop Graves' disease. And okay, so whenever you are dealing with a pediatric Graves, you need to see other associates with it. Most commonly type 1, we do see celiac, vitiligo and all those things that will be readily apparent. Down syndrome patients, think about Graves. But in the 15% of cases, normal autoimmunity can be associated, like mother can be having autoimmune thyroid disease and all those things. Important to remember in those centers where bone marrow transplantation is done and children are being treated with HIV therapy, remember that they might also develop Graves. But whenever we are dealing with a thyrotoxic patient in a kid, always remember that apart from Graves, lots of other differentials are there. Subacute thyroiditis, autonomous nodule, McCune-Albright. Currently I am dealing with 2 of such patients, McCune-Albright, who presented with thyrotoxicosis. So, and another TSH receptor activation, even RTH, they have different thyroid profile. We know we can differentiate, but it is better to keep those things in mind. So how do you diagnose? Diagnosis is straightforward. You do FT3, FT4, that is elevated, TSH is suppressed. In pediatric patient, you do anti-TSH receptor antibody. But remember that initially it may be negative, but later on it can become positive. It's preferred over a thyroid scan because we do not want radiation exposure. And in pediatric patient, contrary to adult, do a thyroid scanning with a vascular Doppler flow. And if you found a inferno pattern or something, pretty increased vascularity, that will help you in avoiding scintigraphy also. So after you diagnose one patient, most of the issues, controversies comes related to the management. The management basically dwells on 2 points. One is the first medical management to stabilize, and second thing, when to do the definitive therapy, what are the choice of definitive therapy, that I will discuss. Fortunately, we have a guideline recently in 2020 from European Thyroid Association, and before that there was ATA, that was 2015, and after that lots of data has been added. But it's important to remember that this is a rare disease, and so data is almost, it's not that robust, and this is one topic where we found that earlier studies with a very long follow-up gives us pretty good evidence. So what are the medical treatment options? It's just like adults, you treat with carbimazole or methimazole with the ratio 10:6. But propyl thiouracil is absolute no-no in pediatrics because of chance of hepatic failure. You cannot monitor hepatic failure in a pediatric because it may, ALF, acute liver failure may happen within 2 to 4 days. You cannot monitor. That's why it's absolutely avoided. Initial dose depends on the patient's severity. If it is a mild to moderate cases, you can start with 0.15 to 0.5 of MMI. Or if it's little bit on the severe side, you can start with 0.25 to 0.75. But usually 1 milligram or 1.3 milligram per kg is not required unless and until it's very compelling. In pediatric Graves, block and replacement regimen has been used for a long time, and some group has proposed it is as a better option. But still now we have, this dose titration approach is preferred. Why so? I'll come to that. So why do you think we need a block and replacement strategy here? So whenever you are using a higher dose, immediately the kid is going to become euthyroid or hypothyroid with that kind of dose. So you initiate a LT4 as an age and weight appropriate LT4 after they become euthyroid. What are the advantages? So why do you need a BR in this place? So previous studies, multiple studies, particularly their prospective or retrospective studies with a small number of cohorts, they have shown that it reduces the hyperthyroidism and hypothyroidism swing because, and you will achieve a more stable course on the illness, because in children it's difficult because the tablet dose is 2.5 to 5. If you give to 2.5 extra, they might land up into hypo. If you reduce 2.5, they might again go into hyper. That's why it was initially, many of the groups, they have told that you can do for block and replacement. But fortunately now we have a RCT where 37 population in each group were randomized to receive block and replacement versus dose titration. It has been shown that there is no difference in the fluctuation in TSH and FT4 level. That means the stability which was being proposed earlier possibly is not there, and there was no difference in the adverse event either. So based on this RCT, the guideline currently recommends that you use the dose titration, do not use the block and replacement therapy. So how you monitor? You monitor 2 to 3 monthly TSH, FT3 and FT4, adjust the dose, either you increase or decrease by 25 to 50%, that we regularly do. But what is the chance that a child who is treated with antithyroid drugs is going to in remission? The chance is only 20 to 30%. That is the point of bother, because you expect relapse in almost 70% of the kids who are being treated with ATD. And if you use a longer dose of ATD, you can see the remission is on the much higher percentages. Particularly if you go to 5 to 6 years, it will be in and around 43%, but even again 50% child will require other therapies. So if you see, this is a bubble diagram of all the studies, whatever has been done till now in follow-up patients. Most of the patients you can see that is here 3 to 5, around 3 and 5 years of duration they have been given. Only one study in the furthest corner you can see, that has followed patients for 9 years. In that 9-year follow-up study, the remission was somewhere between 60 to 70%. So the longer you treat, the longer chance of remission will develop. But it requires patience from the parents. That is very important, and we need to counsel. So how do you judge a patient is going to be remitted? You have a raised TSH according to your lab reference ranges. You have a very minimal dose of ATD, 2.5 to 5 milligram of methimazole, and please do a TSH antibody titer. If your titer is low or normal, possibly you are going to achieve remission. If your titer is elevated, do not stop ATD and do not go for remission. So when should be ATD stopped? The current guideline recommends, as we have seen in the evidence, it should be at least 3 years of ATD treatment, that you need to counsel the patients and parents also at day 1. And potentially, if you will be ended up in treating for 5 years or more in those kind of patients. So who are those patients who will have a high likelihood of remission? Those who are in older age, have female sex, goiter size is small, mild biochemical derangement, and the TSH antibody titer is lower, and those who have other autoimmune conditions, and obviously the duration of the ATD treatment, the longer the better. Relapse you need to discuss all the time, because there is a high likelihood of relapse. Usually all the relapse happens within 12 months. So you need to educate the parents and the kid also to come back whenever you are having relapse related symptoms. Why it is important? Because you should not withdraw ATD during the important event. Suppose somebody is going for a board exam, you should not withdraw the ATD because the patient might go into relapse. That might hamper his board exam also. So now discuss about the definite therapy, that is radioiodine versus surgery. So as you know, 70% will go into relapse. So we have to have some definitive therapy. What are the indications? Obviously relapse is the first and most important indication. If the person has developed serious or persistent side effects, particularly major side effects to ATD, they have poor compliance, they are coming from far places, they do not want to get medications, and obstructive symptoms from a large goiter. So what are the two first we discussed about RI, radioactive iodine ablation. The aim here is to do complete thyroid ablation, not to leave any thyroid tissue behind so that future malignancy risk will be higher. You can do a 3-approach strategy: fixed approach, limited personalization, or dosimetry. Whenever nuclear medicine colleague, consult a nuclear medicine colleague and ask him or her to do a dosimetry, because that is the best method. Our aim is to give at least 7 to 11 megabecquerel per gram. This volume of the thyroid you can generate from ultrasound thyroid. So one important thing, that the success rate is roughly around 95 to 100%. So from 5 to 10% patient may not respond, may require a second RI after 12 months if this thing is there. and dosimetry is always to be done. When we do not give a patient RAI, when the age is less than 5 years, that's an absolute contraindication, and the person is having active Graves' orbitopathy, fortunately, which is less and rare in children. But age between 5 to 10 years is a relative contraindication. We may proceed to RAI if the dose is less than 10 millicurie in total. How do you prepare? You make patients euthyroid because there is a risk of development of thyroid storm, but it's quite rare, but it may develop in a children. So what we do whenever total T4 or FT4 is more than 5 or certain level, we continue the MMI and also the beta blocker, but remember to stop it 3 to 7 days before the RAI. You can continue the beta blocker afterwards, and you can adjust the ATD, or you can continue the beta blocker. One important thing that kids will become hypothyroid very early compared to adults. Within 7 to 10 days, they may become hypothyroid, or their thyroid function might become normal. So ATD adjustment may not be required. And you repeat the TFT after 4 to 6 weeks. Certain side effects will occur, mild tenderness. Other than that, it's very well tolerated by kids. So if you see, we are worried about the long-term data of RAI, but there is a recent systematic review which has covered 23 studies with more than 1,200 of children. There is no additional effect on thyroid cancer, leukemia, or impaired reproductive capacity in any of those children. So, and there is no increased frequency of congenital anomalies also. So after this data, we feel that it's quite safe to give RAI in a patient who is more than 10 years of old. Now, when do we give a total thyroidectomy? A contraindication to RAI becomes an indication to total thyroidectomy. So, but problem with total thyroidectomy here, chance of post-operative complications are higher in children, particularly transient hypocalcemia or post-op hypopara. Roughly 20% of patients will develop that, so that we have to discuss, and around 4% will develop vocal cord related issue. So we need to discuss the pros and cons of RAI versus radiotherapy, RAI versus thyroidectomy with the parents, and a shared decision must be taken. Little bit of words about pediatric Graves. Pediatric Graves orbitopathy is usually a mild disease, and it doesn't result into severe disease like dysthyroid optic neuropathy or something like that, but the prevalence is similar to adults. But it will be relatively mild disease, and interestingly, inflammatory features are much rarer, and whenever we are achieving from hyper to euthyroidism, their Graves, orbitopathy will be usually remitted. And for that, we need to follow an expectant course, and selenium supplementation in a dose of 1 to 2 microgram per kg can be recommended, but there is no trial obviously. And lastly, we discuss about the pediatric Graves' disease and thyroid cancer. As we all know that Graves' disease increases the cancer risk relatively on the, marginal increase. It is being seen in pediatric patients also. The ratio is roughly 6% versus 4%. That kind of scenario, not that high. But what does it actually materialize in terms of clinical things? Those patients, pediatric patients who have Graves develop DTC, they have multifocal papillary microcarcinoma rather than unifocal. They have more lymphoinvasion, they have more lymph node mets. But if you do proper management and all that, it has no effect on the mortality, no effect on survival, and no effect on prognosis. So basically, pediatric Graves' disease, even if it predisposes to some cancer, the final outcome is not different. Importantly for clinicians to note is that if some Graves' child has developed a nodule, get an ultrasound done, get the thyroid scoring done, and then go accordingly. So from this discussion, the take-home points are that pediatric Graves' disease are rare but require a precise approach. We need to initially stabilize those patients, followed by we have to give a definitive choice, and it's always a shared decision between the clinician, between the parents, and the initial therapy lasts usually longer, 3 to 5 years minimum therapy. After that, you give a definite therapy. more than 10 years, give RAI, it has a definite outcome, and side effects are almost not there, and always discuss all those options and have a shared decision. Thank you again.
Thank you, sir, for the wonderful topic, for the wonderful talk that you have given. So now coming to the audience, question and answer. Any question from the audience?
Excellent talk, Ayan. Did you find anything like the grade score, like predictor, some quantitative predictor for remission or something in pediatric Graves population?
Yeah, actually, GRADE is actually, I mean, it's mostly in adults also, GRADE and GRADE plus, but there is no such predictor in children. But you see, I have told regarding certain clinicals, if you see in the GRADE also, no, what are the goiter size, FT4, presence of TSH, titer, age, those kind of features, those are clinical predictors. But if you can see here, there are certain predictors who will go into remission clinical, here. Mostly this reflects that the disease is less severe. So once we are treating a less severe disease, the chance of remissions will be higher, but even then it will be only 30 to 40% with MMR. We need to understand, actually we need more research here. Why don't they go for much this thing, whether the genetics is playing a role, or whether we're not treating effectively, that we need to see, and much research is required.
And given the fact that relapse is much more common in pediatric population than adult ones, so do you recommend routine TRAB before deciding on withdrawal of therapy?
Yeah. That absolutely, I recommend that, and I have told that also, because if you see the studies which has tried to predict who is going to remission, almost all are based on TRAB. Because TRAB is readily available, TRAB is quantitative, and TRAB has a very good sensitivity initially. And one interesting thing, actually want of time I could not tell, even at diagnosis, if the TRAB level is more than 2.5 to 3 times higher than the normal range, then the chance of going into remission is less. So at diagnosis it has role, while you are going to discontinue ATD therapy, if your level is not normalized, then also it has a role. So definitely you do TRAB.
At times I find some difficulties, particularly for adult ones. For an example, someone who is well controlled with a lower dose of methimazole, carbimazole, and we do not look into the functional type of the TRAB. Many times the pattern of TRAB fluctuates. So I am looking at TRAB in someone who is well controlled with a low dose of carbimazole, and I am not sure whether we are dealing with a stimulating TRAB or a blocking TRAB or a neutral TRAB. So your comment on that?
Yeah, actually, since unfortunately we don't have a functional assays here, it would have been better if we have had that. More precision medicine would have been applied there. But even then also, there are studies which has seen functional assays also in pediatrics and in adults also. But what you have readily available in your hand is a quantitative method for TRAB. So basically, I think then also I will recommend that you please do a TRAB, because TRAB has a pretty good, prediction level.
Thank you.
I understand that I could not answer your question finally, firmly. The reason is that we need to develop our own functional assay.
Thank you, sir. A big round of applause for sir. Now here we come at the end of the session today from Hall B. Now I request everyone to please shift to Hall A for the further session.